majority or various other things. So I read the script.
All right, give me just a moment to set everything up for you, Representative Pearson. I'll be right there. All right, go right ahead.
As chairman of the House Health, Human Services, and Elderly Affairs Committee, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic, and in accordance with the governor's emergency order number 12, pursuant to Executive Order 2020-04, this public body is authorized to meet electronically. This is a committee meeting of the Health, Human Services, and Elderly Affairs Committee of the New Hampshire House of Representatives. Please note there is no physical location for members of the public to observe and listen contemporaneously to this meeting. However, in accordance with the emergency order, I am confirming that all members of the committee and select legislative staff have the ability to communicate contemporaneously during this meeting through the Zoom electronic meeting platform, and the public has access to listen contemporaneously, and if necessary, participate in this meeting by the Zoom platform or by telephone. All necessary access information has been made available in the House calendar and through the electronic calendar on the General Court website. The notice for this meeting complies with House rules and RSA 91-A. Anyone who has a problem accessing the meeting should call 271-3600 or email hcs@leg.state.nh.us. In the event the public as a whole is unable to access this meeting, the meeting will be adjourned and rescheduled. Christina Dyer, committee researcher, will be the staff assisting us. Please note that all votes that are taken during this meeting shall be done by roll call. Let's start the meeting by taking roll call attendance. When each member states his or her presence, please also state whether there is anyone in the room with you during this meeting. And this is required under the right to know law. Representative Marsh will be joining us. He is testifying elsewhere. And Representative Folsom will be joining us soon after she finishes a doctor's appointment. Will the acting clerk please call the roll?
Thank you, Mr. Chairman. I may be going in a different order, so be prepared. Representative Marsh, Representative Folsom, Representative McMahon,
Present. I'm alone in my office in Windham.
Representative Nelson, President, yeah. Present in his home in Brookfield, sorry. Representative Acton,
I'm present, alone in my kitchen in Fremont.
Representative Gay. Representative Gay,
She's
Representative Cushman,
I am present in my home in Ware, and my husband and children are in the house, but not in the room.
Representative Kelsey,
I'm present at my home in Bedford. I'm in the room alone, but my daughter is in the house.
Representative King,
Present, I'm in my kitchen alone. My son is upstairs and doing college studies.
Representative Kofall,
Present, I am in my home office in Wilton. There are other people in the house, not currently in the room though.
Representative Weber,
I am at home in Walpole and I am alone.
Representative McKay. Representative McKay,
Representative McKay, you need to unmute.
you can see him, Representative Weber?
I can see him, yes.
I can see him too.
All right, he's here. Representative Snow,
Here in my home in Manchester, in my apartment. My wife is present elsewhere in the apartment.
Representative Knirk,
Here in my study in Freedom, my wife is elsewhere in the house.
Representative Salloway,
Present, at my home office and alone in Lee, New Hampshire.
Representative Cannon,
I'm present. I'm home alone in my home in Somersworth, New Hampshire.
Representative Nadarapam,
I'm here in Nashua, alone in this room, but another family member is in the house.
Representative Shapiro,
I'm home alone in my office in my home in Keene. My wife is
Representative-
elsewhere.
sorry, Representative Woods,
Yes, President, I'm here in my study in Bow and in the house by myself.
Representative Merchant,
Here, I'm in my home in Claremont, New Hampshire. My wife is somewhere in the house.
Representative Pearson,
Here I am, I say, presently, in my house in Hampstead. No one's in the house with me.
we have a quorum, sir.
Thank
I
you.
would-
And
I
yes,
want to let you know that
Here too.
Representative
McKay is
Gay is here.
unmuted.
This is Betty Gay, and I am here finally with great difficulty.
Glad
Hey,
you're here. Where is here?
Oh, in our office, and John is in the house.
Okay, good. Thank you. All right, with that, I am going to, at the request of the sponsor of House Bill 582, take this one out of order. Representative Mary Beth Waltz needs to be in an exec session when her bill was originally scheduled. So with that, I call to order a hearing on House Bill 582 relative to prescriptions for the treatment of attention deficit disorder or attention deficit disorder with hyperactivity. And the chair calls on Representative Waltz to present her bill.
Oh, here she is. Okay, sorry about that. Go ahead.
Okay, I'm here. So you guys don't do video, it looks like.
We do.
I'm on video if you want to turn it on.
We're running with a new but quite able technician who is learning the ropes.
And I'm not sure that webinar supports video for the participants rather than the for the attendees rather than the
I
think
think I'd have
At
to.
least I
promote the
couldn't figure out
panelists.
how.
We're running
She's
with
all
a
set
fairly
to go.
I'm here. I'm
There
here
she
on
is.
audio and video, so thank you.
wonderful.
So I've done this. This is like the third or fourth committee I've been before, so I know it can be done. So first of all, I want to thank the chair for rescheduling this. I do have an exec session at 10, and I'm very appreciative of him choosing to take this bill first. And with that, I'd like to introduce myself to you. I am Representative Mary Beth Walls. I represent Merrimack District number 23, which is the towns of Bow and Dunbarton, along with Representative Woods. We share a district. So this bill came from a constituent request. And as you all know, we kind of all live in small town America. And as it worked out, when I was campaigning last fall, I first spoke with the patient's family and then with the patient's doctor. And they all asked for the same thing. So I said, sure, I can put a bill on this. And that's the bill that you have before you. And you will later hear from both the patient's family, Mrs. Fortier, and the doctor, who is named Dr. Call, both of whom should be in the waiting room on this to testify as well. But with that, let me introduce the bill and tell you a little bit about it. What this bill does is it extends the length of time for a renewal on a prescriptions for ADD from 60 days to 90 days. And what that means for the patients and for the doctors is that it goes from 6 copays a year to 4 copays a year. Now, it turns out that health insurance companies don't prorate copays. So let's say your copay is $100. If you've got a 60-day prescription, you pay the $100. If you've got a 90-day prescription, you pay the $100. So you're going from, by going from 6 copays to 4 copays, you're saving, at least out of pocket, a third of the cost of the drugs for the patients. In addition, I'm sure you all know there is a shortage of psychiatrists in this state, and there's an especially acute shortage of child psychiatrists. And Dr. Call is just that, a child's psychiatrist. And for them to have to write that many more prescriptions is really onerous. And in some cases, they have to, patients have to physically pick up the prescriptions. So they have to coordinate with the doctor to actually physically receive the prescription. I know that this rule is inconsistent with all the other drugs that patients are taking. The other drugs that they take are on 90-day renewals, including things like Xanax, which is even far more dangerous than these kinds of drugs that you are on for ADD. It's kind of ironic because it's particularly difficult for this illness. Patients who have ADD have difficulties with executive functioning, which means prescription renewal. They're often not organized enough to repeatedly order refills on time so they don't run out. This extends the time between refills. It gives them better options to doing that. And it requires fewer refills. So there's less times, less opportunities they have to miss getting a refill. I'm not really sure why this drug was changed from 90 days to 60 days, but I have a suspicion it had to do with the opioid crisis. But you will hear from Dr. Call that really whether somebody has a 60-day supply or a 90-day supply does not influence whether or not somebody's likely to try and sell these to their friends. And so that extending this to 90 days is unlikely to have any effect on whether the patient tries to do something illegal with them. Drugs are expensive and refills are, frankly, we all know, a pain in the neck. I'm asking with this legislation that you please support these patients, help these patients, and pass this bill. Thank you.
Any questions from the committee for Representative Waltz? I'm going to need to be told who has hands up because I see any. And that's probably because she did such a good job.
We have State Representative Chris Schultz ready to speak as well.
I have the list of people who wish to speak. Thank you, because I don't usually, but thank you for that. I do see a hand. Representative Shapiro.
Thank you, Mr. Chairman, and thank you, Representative, for taking this question. Can you explain why there's a distinction made for prescribing the same kinds of medication for narcolepsy as opposed to attention deficit disorder?
Well, the law did that. And the request to me from my constituents only was for ADHD. Subsequently, I was talking to Dr. Collins. She looked at the bill and looked at the law and said, "Ah, I should have asked you to do it for narcolepsy too." And she said the same issues apply. But given that the request to me was only for ADD, that was all I changed in the law.
Thank you.
I want to follow that up myself and ask Representative Waltz if someone from our committee brought forth an amendment to add narcolepsy, would you be okay with that?
I'd be completely supportive of it.
All right. Who would like to do that? Representative Shapiro, thank you so much. Therefore, we will hold the bill for executing when we get to the end of this, so that can be brought forth perhaps by next week. Anyone else on the committee with a hand up? Seeing none, thank you, Representative, and have a good exec session.
Thank you.
You're welcome. Chair now calls Representative Schultz, who has signed up to speak.
Can you hear me?
We can.
Oh, great. Thank you, Mr. Chair, and to the committee. I'll be very brief. I also heard from constituents who were very excited about this bill. They are two adults that are a couple, and they've said almost verbatim what Representative Waltz said, that it's a cruel irony that there are extra hoops put up for people who have ADHD that affects executive functioning, because the very medication that helps you with executive functioning and the ability to pick up the medication more frequently is exactly the hoop that you're jumping through. So I am here on their behalf. I don't know that I can answer any of your questions other than I know that one of the female of this couple has been taking Adderall for 14 years and has shown consistency in her prescription, and except for the times when it's been difficult to pick it up because of the hoops, and to have this made available like the rest of her prescriptions for a 90-day supply would enable her to only have those sorts of hoops, at the same rate she has her other medication. So this would be very helpful to many people who suffer from an affect disorder that affects executive functioning. Thank you.
And thank you, Representative Schultz. We'll be seeing you this afternoon with your own bill at 1 o'clock.
Looking forward to it.
All right. The chair would now like to call Dr. Linda Call.
Hi, can you hear me okay?
Yes, we can.
All right, perfect. So I am Dr. Linda Call. I'm a board certified child and adolescent psychiatrist, as well as board certified in adult general psychiatry. Absolutely, I think Representative Walz really nailed the heart of what this is all about. And that is making sure that we have equitable treatment for this medication that has been absolutely life-changing for a number of folks who are struggling with ADHD. ADHD is one of those what can be a very debilitating and can lead to all sorts of, if untreated, all sorts of risks to academic, social, emotional problems, self-esteem, seeing folks seeing themselves as being lazy, not able to get tasks done. Untreated, it certainly can lead to more job performance for issues for adults, marital and family issues. We know that the likelihood of having a negative effect, it goes up, it's at least twice for those who are untreated for things like likelihood to use substances to try to self-treat. This is for folks who are not treated. The folks who are treated are much more likely to be right on line with their peers who do not have ADHD. So when treated, these meds are extremely beneficial to even the playing field in terms of some of the risks. In my experience, I have not seen any downside to having 90-day scripts, which prior to being in New Hampshire was the case where it was a federal law. I've not seen, I'm very careful about diagnosing and prescribing, and I've seen the benefits of these medications for treating ADHD, and the frustrations to both the prescribers, and most of all the patients when when the meds are not in line, both the cost of paying for a 90-day script, but getting a 60, or having to go to the local pharmacy and paying the higher copay every 30 days. Most of the insurance companies are not recognizing a 60-day script. They either want the 90 for chronic meds or 30, so it becomes this whole enormous difficulty to overcome. I am thrilled to be here, and I thank you for all of your time and understanding about that. What I find is that when patients are on these medications and stabilized, that there's not, that they do well. There is huge positive benefit, and there is no negative to receiving a 90-day beyond 60. I also appreciate that the bringing up of the neurology. Since I don't prescribe as a psychiatrist, I don't prescribe for narcolepsy. I refer. I'm in the same board, but that's not my area. It just didn't dawn on me when Mary Beth Walz and I were speaking, but I absolutely agree that anything we can do to make this a better experience for those of our fellow New Hampshire residents, I think would be fantastic.
Will you take questions?
Absolutely.
Dr. Shapiro?
Thank you, Mr. Chairman, and thank you, Dr. Cole. Is it true that there are some people who are treated for attention deficit disorder with non-stimulant medications? And
Yes.
if so, is that an issue for them in terms of the length of prescription?
No, there's, they are allowed. So some of the stimulant medications are meds like Intuitive, which is in the blood pressure class. It's long-acting guanfacine, meds like Strattera. Those meds are 90-day scripts, and they actually are allowed refills. The stimulants, we're currently limited to 60 days, and there are no refills allowed.
Follow up?
Yes, sir.
I can assume this from your comments, but I probably should have asked before I offered to write an amendment. Do I take it that you don't see any contraindications or dangers for making the same change for narcolepsy?
Absolutely. I think there would be no contraindications, and I think this would be enormously helpful for narcolepsy as well. To have scripts aligned with the other medications, which is very often 90-day scripts at this point.
I have a question for the doctor. Where is your practice based?
So I'm in Concord. I live in Bow. I'm in Concord. I'm at Concord Behavioral Health.
Okay.
89 North State Street.
Thank you. I asked that because I'm looking for a child and for an adult psychiatrist to refer some of our patients to. And as has been testified, you're very thin on the ground.
Absolutely true. So just a very brief background. I started off teaching math. I taught everything from 7th grade through calculus. I loved it. I absolutely loved what I did. But I also saw the effects of not treating in childhood for a number of different reasons, whether it's anxiety, ADHD, or a number of other factors, trauma. And so I went to med school.
Bless you.
And because I finally reached the point where I said, I'm a parent and a grandparent. There's no place for these kids to go, and there's just such a huge shortage. I either have to, to knowing that I could do it, I needed to do it. Well, I wasn't sure I could do it, but I did. Because there is such a huge shortage, and I do my very best to try to keep the door open as much as I can so that new patients aren't left without a place to go.
Thank you so much for your service.
Thank you.
Is there anyone else who wishes to testify that is not on my list? They would have come on in the last hour.
Mr. Chairman, this is Representative Walls.
Hi.
Do you have Joanne Fortier there somewhere, or is she?
Yes, I'm looking right at her name and totally not comprehending. I should not say this in this company. Several scripts will be written and sent in. I'm sorry, Joanne Fortier, please, you're the mom.
Good morning. Can you hear me?
Yes, we can. Thank you for coming to testify.
Wonderful. I appreciate you taking the time to hear what I have to say. My teenage son has ADHD. He's been on medication for 7 years. It is tremendously helpful in managing his schoolwork and his focus, his ability to stay on task. The change in the law would simply enable us to get prescriptions less frequently. And it's not just the copays, but the time it takes to manage getting the prescription at the appropriate time, not too early so as it can't be refilled, but not too late so that he runs out. So I greatly appreciate your willingness to consider this bill.
We're happy to help. Any questions for the mom? Seeing none, I thank you for coming and thank the representative for this bill and Representative Shapiro for going to get an amendment. And seeing no one else wanting to testify, then I will bring this hearing to a close on Bill 582. We will hope to exec it next week. I now open the hearing on House Bill 143. Representative, our own Representative Merchant, and would you introduce your bill, please? And I believe an amendment as well.
That's true, Mr. Chairman. I come before the Committee of Health and Human Services and Elderly Affairs and colleagues, public members. My name is Gary Merchant, representative from Sullivan County, District 4, Claremont Ward 2. Before you today is House Bill 143. There are 3 distinct sections to the bill. The first one regards to e-prescribing, or what they call electronic prescribing. The middle one is dealing with a provision in the Consumer Protection Law dealing with software vendors that have a tendency to violate their what they're doing within the software functionality used by prescribers or by clinicians, and also a requirement for the data that's supplied by the pharmacy, that the data also includes a data element to help monitor electronic prescribing. So let me do with the first one with e-prescribing. E-prescribing is now required, will be required in January 2022 by the federal government. Unfortunately, the federal government only deals with prescriptions paid by Medicare Part D. So to address all prescriptions, the law, the intent of it is to fill in the gap. So it includes all prescriptions regardless of the payment source, whether it's Medicaid, a commercial payer, or cash. And many times when you're looking at diversion, it's the cash paying customers that create a lot of the problem with diversion. So by asking them to electronically prescribe, it does a couple of things. One is there's a better data transmission between the prescriber and the dispenser. Going back to what we saw before that we talked about with 582, with prescriptions, one of the requirements is including a diagnosis, whether it's narcolepsy or attention deficit disorder. That may have to be written on the prescription. If it's electronically prescribed, it can be placed in a note field and sent from the prescriber to the dispenser to use to be sure they have compliance with the law. Secondly, when you look at paper prescriptions today, many times it's a source of diversion. A paper lends itself easily to be manipulated. You can take something that has a 5 and put a 1 in front of it to make 15, or take a number 50, make it a 6, and make it 60. So by having something electronically prescribed, the ability to divert or to change and manipulate written prescription becomes less of an issue. And that's primarily the reason why the federal government, through the Sports Act, decided to have electronic prescribing for Medicare Part D plans in the first place. 26 states in the country deal with this, and we're on the, I would say at this point in time, it's probably another 10 in the fold that will probably become within the next year or so. But one of the things I want to also point out, besides electronic prescribing in the bill, is the issue of something that came to the attention in Vermont. It was Practice Fusion. What Practice Fusion did in their software, this is before Allscripts bought them. Allscripts, when they bought them, the lawsuit was filed. It was determined that built into the algorithm used by clinicians to assess patients was a functionality to assess pain. And if you had a certain threshold, it automatically, without any reason from the provider, it just generated what they call an opiate treatment plan. And in the opiate treatment plan, happened by was a drug for controls. And one of the manufacturers of that drug was also providing a stipend to Practice Fusion. And what happened to the whole thing was that the FDA, the Department of Justice, through the Vermont chapter, did some research and determined that the software, in fact, was steering providers in a direction towards a product by the manufacturer. So what this law basically does is try to allow in our state law in the Consumer Protection Act language to help prevent that, or at least if it happens, we have some language to go back and saying it shouldn't have happened. We can find them, take action against them. The third part in the law deals with electronic prescription monitoring. And basically, if the pharmacy sends to the prescription drug monitoring program the type of prescription used by the prescriber, whether it be e-prescribed, whether it be faxed, whether it be written or oral, because there are exceptions in the rule to accommodate that, that the database in the prescription drug monitoring program can then run reports for the licensing board. There is no penalty in this for non-compliance, but we're trying to allow the licensing boards to look at where they may have to spend some time educationally to help prescribers with e-prescribing and try to determine what the barriers are to not doing the e-prescribing. And lastly, in the amendment, what came before was the issue of the veterinarian community. In talking with Dr. Stephen Crawford and Dr. Jane Roy Barlow, it came to my attention that there is not really widely available, if any at all, software for a veterinarian to e-prescribe. So to ask the veterinarians to e-prescribe when the software and the tools that are necessary to do that didn't make sense. So I wrote an amendment to then exempt the veterinarians. And the way it's written was modeled after the Arizona law. And in the Arizona law, what they basically said was, it's up to the veterinarians themselves, the Board of Veterinary Medicine, to determine on an annual basis when the software becomes widely available. So the veterinarians are total control over when to enact that provision within the law. Also, in the e-prescribing part of it, there are times in which, if you look at the exceptions, when the internet goes down, when a person's not able to get to the internet, you're on a phone call with a provider, the last thing you want to do is delay therapy for a patient. Delaying therapy for a patient is not healthy to them. We're trying to find a way to get a patient taken care of in a timely, prompt manner. So by allowing exceptions in the bill, in the law, it does allow for those things to occur. Sometimes it could be a simple thing where you don't have access to the internet, not because it's not functioning, it's just wherever you're at. There are parts of this world, believe it or not, that you just cannot get broadband internet. It's amazing. It does happen. So this does allow for that flexibility.
Please.
To allow the prescriber to have some options to opt out of it. And because of that, we don't want to, again, delay the patient getting treatment. We don't want the pharmacist in a position to try to determine whether they have met the exception or not. So we exempt the pharmacist from trying to verify the use of an exception and take the honor of the person who's doing the prescribing. They use the exception appropriately. So that's the intent of the law, is to try to fill in the gap around CMS, so it covers all providers. We did build into the law, into the bill, exceptions to deal with things that do happen. There's also a waiver requirement. So if a provider is a small provider in an office and does 50 prescriptions, like a pathologist, radiologist, they don't have to comply. They can get a waiver from the licensing board. We did deal with the issue of practice infusion software vendors that abuse their privileges of their software functionality, not to the benefit of the patient, but to the benefit of themselves. And we also built in there a way to monitor e-prescribing through the data collection with the prescription drug monitoring program to help the licensing boards identify where they have to spend additional resources, whether it be educational or whether it be financial, to help the prescribers comply with e-prescribing. And that's the end of my testimony.
Thank you very much. Do any members of the committee have a question? Well, until others do, I have a couple.
Excuse me, Mr. Chair, Gary, Representative Woods, I believe, raised his hand.
Okay,
in the
I will get to him in a minute. I've been scrolling back and forth, but I'll get to him next. And my two questions, I'm going to assume the amendment which says veterinarians don't have to do it if they can't do it, and the Board of Veterinary Medicine shall make the determination. I assume you've had good conversations, Representative Merchant, with the veterinarians.
I've had conversations with the veterinarians, and I talked to Dr. Crawford. He was going to bring it to the veterinarian board, which I believe is tomorrow. So I have not heard back from the veterinarian board. I think in general, the veterinarians like to be excluded completely. And I think that's a wise thing for us to do. And that's why the amendment was written the way it was, is for the vets themselves to determine when they should have the availability of the tools, if you will, to do the job.
I must confess that I skimmed too fast because I saw that the part that said until they can, but the last line says they decide.
Yes.
The Board of Veterinary Medicine shall decide.
Yes.
I missed that. Okay, thank you. And then the second question, and again, I think I know the answer, but I'd rather have you tell me. And that is the information set from the pharmacies to the feds. It's simply a percentage of how many electronic prescriptions versus not per provider, or does it get into a little bit more detail about what those scripts are for?
No, it does not get into details of why the prescription was written. It's only the format of the prescription.
That's it. So nobody could guess that Dr. So-and-so prescribed such and such for a certain patient.
Correct. The intent is that in the database, that there'd be a report going to the respective board and say, Dr. Pearson has an 85% electronic fill rate, or Dr. Woods only has 25. It goes to the respective board, whether it be a board of medicine, a board of dentistry, the board of nursing, to help them understand where they may have to engage with the conversation, try to determine how to get the percentage up, or maybe the person needs a waiver and offer the waiver to them.
Thank you very much. Representative Woods.
Thank you, Mr. Chair, and thank you, Representative Merchant, for taking my question. On page 1, line 21, it's the references, the board. Is that meant to be the respective board? If a nurse practitioner is prescribing, that would be referred to the nursing board. If it's a physician, it'd be, and I was just wondering, I think way back a ways when you first brought this up, I think we brought that up. Did that need to be clarified as to what board that is?
Representative Woods, yes, I remember that conversation, and I did not correct it in the amendment. I think it's the intent is it goes to the respective licensing board, but to add another word in there saying to that effect, I have no issues whatsoever. I think it just clarifies the language in the bill.
Any other questions for Representative Merchant from our committee? I see none. Thank you very much, Representative, for presenting your bill. The chair now calls Paula Minahan, who is testifying in support. Welcome back.
Thank you, Representative Pearson and members of the committee. Can you hear me?
Very well.
Great, thank you. Good morning. For the record, I'm Paula Minahan, Senior Vice President for the New Hampshire Hospital Association, representing all our hospitals in the state. We are supportive of HB 143, and this is a very similar bill that was passed out of your committee last year, which was House Bill 1332, but did not make it over to the Senate due to the COVID-19 pandemic. I want to make clear to this committee that the hospitals in New Hampshire are supportive of requiring electronic prescribing for controlled substances, and the reasons for moving to electronic prescribing for controlled substances are compelling. I have submitted testimony, so I won't read all of our reasons, but just to highlight, enhance the safety and quality of the prescribing process, reduces errors, and supports clinical decision-making, along with reducing theft and increased security. And I think Representative Merchant did a great job outlining the rest of the bill. We're really focused on the e-prescribing piece. And in fact, many hospitals have already implemented electronic prescribing for controlled substances. Several others are in the midst of doing so. As Representative Merchant mentioned, it is a requirement of the federal government for Medicare in about a year, less than a year. So they're in the midst of implementing that So we are totally supportive of that provision, and we thank you for the opportunity to testify in support of HB 143.
Any questions for Ms. Minahan? I see none. Thank you for your testimony.
Thank you.
The chair now recognizes Jane Barlow Roy from the New Hampshire Veterinarians. And would we bring up Ms. Roy?
Trying to find her in the list here. There's about 34 people. So if people can raise their hands, that would make it a bit easier. There we go. All set.
Thank you.
Hi, my name is Dr. Jane Barlow Roy. I am the representative to the New Hampshire Veterinary Medical Association. I thank you very much for letting me testify in front of you guys today. We are opposed to the bill as written, but we have been talking to Representative Merchant about the amendment. I will make my testimony short because Representative Merchant has kind of brought up all of our issues with the bill as far as there is no software available currently widespread in the veterinary community. The top kind of, I would say 5 veterinary softwares out there do not have any sort of e-prescribing capabilities, technologies, however you want to call it. So we don't have the capabilities of implementing such a bill. So we are willing to keep updated on when such a software will become available. I have talked to our software provider named Avamark. They're one of the top veterinary softwares out there. And they actually said that they have no desire to actually create this e-prescribing software at the current moment. They did not give me any timeline as far as whether or not they will be forced on the federal level to create something should it become more widespread. But currently 13 other states do exempt veterinarians. I know that our language is in the amendment was modeled after another state's exemption. But that's basically the crux of my testimony today is we do need some sort of exemption as veterinarians because our software just does not exist.
Will the doctor take questions?
Certainly.
Representative Weber.
Thank you, Mr. Chair, and thank you, Dr. Roy, for taking my question. I just want to be very clear. Have you read the amendment that was submitted, and is it acceptable as it would apply to the veterinary community?
I can't speak on behalf of the amendment in regards to the Board of Veterinary Medicine. I do not represent the Board of Veterinary Medicine. I don't sit on the Board of Veterinary Medicine. That is something that Representative Merchant has been speaking with Dr. Crawford about. And I know that they are meeting tomorrow and they will speak to it. We are very happy that the amendment does include us with the exemption. But like I said, any language that pertains to what goes on after that and how it involves the Board of Veterinary Medicine, I cannot speak to.
Thank you. Thank you very much. Appreciate it.
Any other questions? Thank you, Doctor, and thank you for coming. Oh, I do see a hand. Representative Nelson.
Yes, what happens with the 13 states you said do exempt it? How about all the other states? What do they do?
I'm not aware of what the other states are currently doing. We, in New Hampshire, with our prescribing things, we do tend to make calls into pharmacies as far as those prescribing goes, and faxing in prescriptions. The only times we really write a written prescription, in our practice at least, is for those scheduled controlled substances that require by DEA rules to have a written prescription. But to your question about what the other states that don't exempt veterinarians, I'm not sure what they do. And I apologize for that.
Thank you.
Seeing no further questions, again, Doctor, thank you for your testimony.
Thank you.
The chair now calls Gina Balkus, who signed up in support of this bill. And if you could wave your hand for my studio technician.
Thank you, Mr. Chairman. Can you hear me?
Again, thank you.
Good morning, Mr. Chairman and members of the committee. I'm Gina Balkus, and I'm the CEO of the Granite State Home Health and Hospice Association, which advocates on behalf of home care, hospice, and palliative care providers in New Hampshire and the people they serve. House Bill 143 was reviewed by our legislative committee and several hospice medical directors in our association. And we support House Bill 143 as a way to enhance patient safety and reduce the potential for drug diversion. However, we would ask the committee to consider some clarifications. First, we believe House Bill 143 should include an exception for electronic prescribing of compounded medications with controlled substances. This is a significant concern for hospices, as compounded medications are used frequently in hospice care and generally cannot be ordered via e-prescribe platforms. And it's really not clear if lines 17 through 19 of the bill would cover that scenario. And while lines 27 through 30 would still allow pharmacists to dispense medications that are otherwise validly written, oral, or faxed, a specific exception for compounded medications would provide more clarity in this bill. Secondly, we want to be sure that this bill does not impact the timely prescribing of controlled medications for dying patients. It's not unusual for a hospice nurse who's visiting a patient at home to contact the hospice medical director after hours when the physician might not have access to their e-prescribe platform. And this happens when a hospice has a new patient admitted who's actively dying, or when a patient runs out of medication unexpectedly due to a dosage change, or when there's a delay in delivery from a mail order pharmacy. So I would suggest amending lines 11 and 12 to include the words "or other circumstances when the prescriber cannot access electronic prescribing." Another option would be to specifically exempt hospice prescribers from the statute. That would be another option. So I also just wanted to share that the hospice medical directors who reviewed House Bill 143 were surprised by the sections of the bill that deal with clinical decision support alerts in e-prescribing programs. None of them were aware of any alerts that were designed to increase prescriptions for controlled medications. Their experience was that e-prescribing has no impact on doses or amounts of medications prescribed. And one physician stated that the alerts generally tamp down prescription patterns rather than seek to increase it. I did hear Representative Merchant talk about the situation with Allscripts in Vermont. The experience that our hospice providers, they are not experiencing that type of situation. So I just wanted to share that with the committee. Lastly, I would recommend the committee check the citation on lines 25 to 26. I looked up this RSA 318B2 Roman 6A, and there is not one. It just goes to Roman 6. And I wonder if the proper reference is 318B1, not B2. So I just urge the committee to check that. It wasn't clear to me what that, it says in circumstances where electronic prescribing is not available due to RSA 318B2 Roman 6A. And so I'm not sure what the intent of that line was. So I'm happy to work with the sponsor and the committee on the language to address our concerns. Most importantly for us is the compounding issue and the issue of access to the platform after hours, to an e-prescribing platform after hours. So those are my comments, and I'm happy to answer questions, and thank you for the opportunity to speak.
Any questions from the committee? There's a little button you can push too, Representative Knurk. It waves at me. You see it?
May I?
Well, yeah, but
It's more a clarification for the person testifying, because I've been caught the same way. I think that, and because I thought Representative Merchant might lead to this, but that's because 6A doesn't exist yet in statute. It gets created on page 2, lines 2 to 6. Though again, I don't understand the referencing, but that's where that appears to come in place. I just want to clarify that as best I can for everybody, if I have it correct. It is not in statute yet. It would be created by this bill. Thank you.
Thank you so much, Representative Knurk.
wow. Anyone else with or without yellow hand up? Representative Gay, thank you for putting your own hand and the yellow hand up both. Now all you need to do is unmute and you've got the trifecta. Thank you.
Okay. Thank you for taking my question. So all your points seem very valid. So I'm just hoping that the method to add the amendments can be done efficiently in our current method of communication.
Thank you.
I'm Representative Gay. In response to your comment, like I said, I'm happy to work with Representative Merchant or members of the committee to discuss language that might add clarity.
Thank you.
And I will reach out to Representative Merchant directly after this hearing.
Well, he's got another hearing and then one after that, but I know what you mean. Thank you. Seeing no further questions, thank you, Ms. Balkas. And now the chair recognizes Neil Kirk, representative of many years, now in retirement. Representative Kirk.
Good morning, Mr. Chairman. Can you hear me?
I can.
Good morning to you, sir, and to members of the committee. For the record, I'm Neil Kirk. I live in Ware, and I'm testifying as a member of the public.
You bark again.
I oppose this bill with respect to its limitations on a patient's right to have a paper prescription to a certain extent. The purpose of the paper prescription in the PDMP and a whole variety of other legislation is twofold. First, to allow the patient to shop around for the best price. When you have a paper prescription, you can take it to a pharmacy and find out what they charge. If you don't have a paper prescription, generally the pharmacy will not give you the answer because the estimate, because they don't have enough information to do so, even if you have the exact information to give them orally. Also, there are many people who buy their prescriptions online, and having a paper prescription allows them to search out the best price there, whether it's in the United States or abroad. The second reason for the paper prescription has to do with privacy. If you have a paper prescription, it's not in the prescription drug database. Frankly, I wonder whether it's in the state's business to know where a person buys his drugs, whether it's the local pharmacy or Walmart, out of state or online. And is it really the state's business to know what kind of medication I'm buying? An ED drug, an HIV drug, a cancer drug, all of these are controlled substances, and they're all covered by the PDMP through electronic prescription. I'd remind folks that over 80% of the voters supported the recent constitutional informational privacy amendment. And I really wonder whether this bill and indeed existing law is consistent with that amendment. I hope the committee will consider that issue. Here are the specific problems with House Bill 143. First, and I apologize, Mr. Chairman, I can't cite page and line numbers because my copy of the bill does not have them. But Roman 1, pharmacists and pharmacies, probably line 3 or 4 on the bill, when the text of the bill starts, has an exception for paper prescriptions with respect to controlled drugs. In other words, you can get a paper prescription except for controlled drugs as defined in RSA 18B 1 Roman 6. Now, I'm not sure I understand that, but I think that refers to opioids and opioid copies. If that's what it does, I think that's not bad. That's reasonable. We have an opioid crisis, and there is a legitimate interest in the state to get that information. But if it covers something beyond that, then I would ask you to consider limiting it to the opioid type prescriptions. Secondly, Roman 2, 3A, couple of lines down, probably on the first page too. It says, notwithstanding any provision of law to the contrary, which means it ignores and overrides what we just discussed on about a paper prescription. No person shall issue a prescription for a controlled drug unless it's made by electronic prescription, etc. In this case, controlled drug is not defined, not limited in the same way it is in the 1B. And so I wonder if there's not a conflict here. Again, if the words controlled drug in 3A had the same limitation as defined in RSA 318B16, then I think we would be avoiding a conflict and still allowing paper prescriptions for all controlled drugs except opioids. I think regardless of what the committee's decision is on the issues that I'm raising, I think it's very important to deal with the consistency issue. I don't think in the same statute we should use controlled drugs in different manners, unless that's intentional. But the idea that in the same, that the legislature giveth in section 1 and taketh away in section 2 strikes me as somewhat strange. I don't think that was intentional, but I think that's what's happening here. That completes my testimony, Mr. Chairman. I'd be pleased to answer any questions if the committee has them.
Anyone with a question for Representative Kirk? Seeing none, thank you, Representative, for your testimony.
Thank you, Mr. Chairman.
This exhausts my list as printed out at about 8:45. Has anyone else signed up that Representative Acton can see on his screen?
I think that's it.
That's it?
Yep.
Well, then, before we end the hearing, what is your pleasure, Representative Merchant? Would you like us to move to exec this right now, or would you like to give it a week and wait for the veterinarian board to speak and perhaps you to speak with Dr. whoever it was, Gina Balkus or others, and come back with an amendment if you wish, and we can exec it next week? What is your pleasure?
I would prefer to work on an amendment. I need to address a couple of issues I think are raised by this committee, by some of the people testifying before the committee. I'm looking at with Representative Woods about the clarification on which board provides the waiver. I think that needs to be addressed. I think also I need to look at the federal law and how it deals with compounded medications, if they do or do not, because in hospice, a lot of it's paid for by the Medicare program. So therefore, even though we may exempt it for compounded medications, if the federal law requires it, then we can't exempt the federal law. So I need to work with Mrs. Balkus about that to get that clarified, and also wait for the veterinarian board if the amendment is approved by them. So if it's okay with the chair, I'd like to hold this, not exec on it, and work on an amendment and work with the parties to make the amendment work for everyone as much as we possibly can.
That's our way here, is to make good things better. So yes, come back. I'd like to exec it next week. We have until March 11th to get everything done. So we're going to be moving a little more quickly, but thank you so much. And with that, I recognize Representative Marsh, who just beat my gavel to the wooden desk.
Thank you, everyone. I just want to be compliant with 91A and tell everyone that I am here present and I'm at home alone in Brookfield and there's nobody in the room with me.
With that, we close the hearing on House Bill 143. And we now open the hearing on House Bill 572, relative to pharmacist administration of vaccines and allowing a licensed advanced pharmacy technician to administer vaccines. And before I ask Representative Merchant to bring forth his presentation on his bill, I'm going to ask my vice chair if he would to text me, and as we've been doing, the people who are signed up to testify, because I don't have that information. We're breaking in a new printer and it's doing everything except printing. So if you would do just one thing, that's all. All the lights and bells are great. Thank you for that. And Representative Merchant, please present your bill.
Well, thank you, Mr. Chairman. I'm still Representative Merchant from Claremont, New Hampshire, Sullivan County, District 4. And also wanted to recognize the committee and also the public that may be listening in. Today I bring to you is House Bill 572. And what we're trying to do with House Bill 572 is two fundamental things. One is to align the vaccines that can be given by a pharmacist in a pharmacy to what the CDC guidelines have provided they're approved by the FDA, which is something we need to add an amendment. The reason for it being is that as we look at vaccinations, we recognize as a society that vaccines are cost effective, they're helpful in trying to prevent a lot of disease, and the cost of the disease, not just financially, but the cost to the patient for getting the vaccine to prevent it in the first place. Today, 34% approximately of vaccines given in the state of New Hampshire are given by a pharmacist in a pharmacy, which is a tremendous stride in the direction of trying to increase access to vaccines so patients can get a vaccine at their convenience in a location that's close to their home. But the challenge we're running into in the pharmacy world is also the question about having personnel, and that's been shown in the, in the COVID situation, enough personnel in the pharmacy to give the vaccines and to do it in such a way that it can be done safely, it can be done cost effectively, and done in a timely manner. Most of the reason why patients go to a pharmacy in the first place is because of convenience. They do it on their time off. We don't delay them. They come in at that point in time, have ready access to it. It doesn't require an appointment. Vaccines have been shown to be extremely safe and effective and so forth. So therefore, we're trying to just expand the vaccines, but not so much to expand it, but to align it with the CDC guidelines for immunizations for adults. So if the CDC determines that another vaccine should be given in the adult profile, we don't have to go back to the state law to add it to the list. It automatically becomes part of it. The other part is on the licensed technician. We've seen also with COVID that personnel and having people trained to give a vaccine comparable to what we do in a medical office. The physician per se does not give the vaccine, but they're the ones that have to be approving the vaccine. They're the ones that screen the patient for it, et cetera. So just as a physician's office, you have a medical assistant that actually administers the vaccines. They can't approve it, but they can administer the vaccine. And I also worked with Representative Woods. Initially, we talked about supervision, and instead of having just general supervision, we had to be sure that the pharmacist is on site. And the reason for that being is that if something goes wrong, they're the ones trained to address the issue. It's one of the things to give the vaccine, but if something, heaven forbid, happens, the person on site, the professional, is the pharmacist to deal with that situation. And fundamentally, what we're trying to do is make this as easy as possible for patients to get vaccines, and trying to minimize the barriers, either financially or time, for them to obtain it. What's nice about today with the Affordable Care Act Most vaccines are paid for. There's no copays and no deductibles. So the financial burden has been lifted on most of the patients. The challenge now is getting the convenience so that people can actually get to the vaccines in their own time and their own schedule. So the intent of this is to expand the ability to give as many vaccines as we possibly can in society in a location that's very convenient, and at the same time, not delay the patient from getting the therapy they need. One of the things that we talked about before, when we had to have a prescription for a patient, the delay for the patient can be sometimes a day or two. Trying to reach a provider today in an office is very difficult, very challenging. We see that happening a lot of times with prior approvals. Patients can wait up to 2 or 3 days for a medication before the insurance company will pay for it. So we're trying to, again, minimize that inconvenience that is created by going through another safety check, if you will, when probably it's not required at all. So looking at it that way, this again goes back to my original comment. We need to find a way to align the CDC guidelines for adult immunizations. And number two, we need to try to make it as convenient as possible for the patient and allow for personnel to administer the vaccine in a way that helps the patient obtain it timely, easily, and conveniently. And this is really what the goal of the whole bill is, to allow for licensed technicians. We 2 years ago approved for them to be licensed. They're not somebody they go through 2,000 hours with the training courses and so forth. So it's personnel that are highly trained as technicians to do work, and we're just adding another task or function to that functionality in that scope of practice. With that, I'll take questions.
Are there questions? I have one. I think I know the answer to it, but I'd like to hear it from you. If one of my medical assistants gives an injection to a patient and something goes seriously wrong, there is a physician or occasionally just a nurse practitioner on site that can step in with whatever went wrong. Would you consider a pharmacist to be the equivalent level of backup?
They're trained to deal with those situations as part of the training they go through. It's a 20-hour program on top of what they do through school itself. So yes, it's not so much their equivalent in their training and what they're doing diagnostically, but they're trained to deal with the issue that may arise, how to use an EpiPen, how to help the patient out. So yes, in that capacity, they're equal, but I don't want to confuse people in thinking that a pharmacist is trained like a physician, because they're not, but they are trained to deal with the situations that may arise within the pharmacy.
Thank you. Representative Leah Cushman.
Thank you, Mr. Chairman. Representative, I'm just wondering, does the on-site, I see that you said that, having the on-site word added to the bill creates more oversight, but you strike out the word direct.
Mhm.
So can you just speak to that a little bit? Because
Yeah.
I'm a little confused.
The word direct is the same with inside of a physician's office. The medical assistant doesn't have direct supervision by the provider. The provider could be in the area. So the medical assistant is giving the vaccine, if you will, in a room, but the provider may not be in the room to provide direct, but they are on site. So that was one of the concerns we had before, is to ensure that in fact the the LAPT cannot work independent, if you will, from the pharmacist. They have to be there physically to deal with the issues that could could arise.
Okay, thank you. And follow-up?
Follow-up.
Does the notification piece that you had struck out, does that require the PCP to be notified and respond to that notification prior to the administration of the vaccine?
No, it's to allow for the PCP. A lot of times, just to be clear about this, in the world of pharmacy, many patients don't have a PCP. There are a lot of patients out there that don't have a primary care doc. So therefore, that's one of the issues we run into. But the goal here was to get the information back into the medical record of the primary care doc or the provider overseeing them. So what we basically at that point in time want to be sure we have as much as possible a comprehensive record with the provider. So if a pharmacist does get the vaccine or is given by them, that is reported back to the primary care physician so that they could be part of the medical record of the patient.
Can I have one more follow-up?
Oh, one more.
I see that line is struck in your bill for the COVID-19 vaccine, so that it doesn't require notification.
That was the reason. That's why it was there first. I'm sorry about that, Representative Cushman. What we now have is a registry, and I'll speak to that as well. The communication back to the provider, if we have the registry in place, the provider can have access to the medication or to the vaccine and the information there. What we did do within the law, if you look at the line, as required by state law. So if the law does not require the pharmacist to put it in the registry, if the patient wants to opt out or opt in, that's another discussion. It depends upon what the law requires. The pharmacist will then have to comply with whatever the law is. But we're trying to look for a communication tool between the pharmacist and the provider. Before the registry, we had no other way to do that. We only could do it verbally or through a fax to get it back to the provider because there's no other communication tool. By using the registry, there is a communication tool between the provider and the pharmacist. However, if the patient opts out, then it's up to the patient to notify the provider that they want it in their record.
Representative Soloway, you had your own hand up.
Thank you, Mr. Chairman, and thank you, Representative, for taking my question. So the data on immunization does get into the registry. What about unanticipated adverse events?
That would be, if they had an event, I would expect the pharmacist is not required to make a communication back to the primary care physician, if they have one, to notify them of a situation that may have occurred. It's back to the healthcare team in which the pharmacist is a part of, is somehow getting it back to the provider if there was actually an adverse effect. The bill does not address it, Representative Soloway. It doesn't require the pharmacist to give it back, but they wanted to add that in there. If the person had an adverse event, I mean, we could do that, but it's not there.
Thank you for taking my question.
Representative Woods.
Thank you, Mr. Chair. I would like to offer a little bit of perhaps further clarification about striking the direct. That was something that we had a discussion about. And direct means in the past has been by telephone, so that a pharmacist potentially could be the mentor directly to, being absurd, 50 pharmacies and have no direct contact. When I chaired the State Workers' Comp Commission, we discovered that caseworkers were doing it directly, but they, again, telephonically, and some were in California being case managers. So my goal was to sort of avoid the individuals monitoring just by telephone many sites, which is not what we wanted, and changed it to on-site so that there would be direct supervisory interaction.
If I may, Mr. Chairman, that was one of the things that was discussed too, is we didn't want to have direct done remotely with a camera. So it does provide direct sight because you can visually see somebody, but you're not physically on site, which is what Representative Wood was concerned about, as well as myself.
Representative Gay.
Thank you. Thank you for taking my question. I may not have understood exactly what y'all are talking about, but the adverse events, the VAERS, I don't know what the status of VAERS in New Hampshire is, but certainly if we're going to be doing recording, optional or not, whatever's legal, if we're going to do recording of immunizations, I think any kind of adverse reactions needs to be in there, but it doesn't sound like there's any field in this system that allows for that, much less requires it? That was really a question.
I'm not an immunizing pharmacist. I have to go back and look at that, Representative Gay. My understanding is that if you do have a reaction to a vaccine, from the peers that I've talked to, there is a requirement to notify there's a form to fill out to complete that, to notify within registry, not so much the state, but the federal registry with what's going on with the vaccine. But it's not a requirement built into the law. I'd have to go back and look at that and find out if it's actually required as part of given the vaccine, that vaccine reactions are somehow recorded in some other database, which I'm not aware of.
Yes, follow up,
Mr. Chair-
Representative Gay.
Yes, well, the system that you're talking about recording, are you just talking about the system that we're considering whether to make it happen or not? It sounds like you're counting on using some kind of system so that the PCP can be notified without you having to send a fax.
No, just the level set, we don't require today. So I just wanted to be clear that we've been given vaccines in the pharmacy community for quite a long time, and 34% of them are given in the community pharmacy. So whatever is being done today, we're not trying to change. We're trying to basically leave it alone. It seems to be working. The communication back to the provider is the critical part to it. I do know if you have an adverse drug reaction, that there is a requirement to report that to the FDA, so the FDA can monitor certain things. But to your point, it doesn't go back per se to the provider themselves.
Thank you.
And it doesn't go in the registry either. Registry is only to record the actual vaccination, not recording adverse effects that they may occur within the vaccination. That's not part of the registry.
Okay, thank you.
I have two more on my list. Representative Marsh.
Captain Meese.
Yes, thank you, Mr. Chair. And I wanted to discuss a little bit more the vaccine registry and the requirement to notify practitioners about vaccinations. Given that the vaccine registry, whether we make it opt-in or opt-out, we have another bill about that. There will still be some people who are going to opt out of it, whichever way it goes. Given that system is not yet functional, don't you think it might be a good idea to continue to require that PCPs, when they are known, be notified about vaccinations that are given?
I think until the registry is up and fully functional, that could be a logical thing to do. I think we want to be sure that the PCP is aware of what's going on in the vaccines. What we're trying to avoid in that is two things, I believe. One is notification to the PCP so that they're aware of it. But number two is not to have both providers giving a vaccine when they don't require the patient to do that.
Right.
I've been in my situation before in a hospital where we had a patient get a pneumococcal vaccine in a long-term care facility because of their requirements with CMS. They go to the hospital for an acute situation. They get another pneumococcal vaccine. They get discharged to a third facility, and they get another pneumococcal vaccine. So I think communication is key to it, Representative Marsh. And until that registry is up and running, I would say, yes, it makes logical sense to maintain some sort of communication tool back to the primary care provider until the registry is fully functional. Then I'd be not opposed to it.
And not least, but at this moment last, Representative Weber.
Thank you so much. I'm really sorry. For some reason, my little yellow hand is not yellow, and it turns out to be exactly the same color as the paint in the room that I'm sitting in.
I like the hand you raised.
But
knew of,
I
yeah.
have made other arrangements.
Yeah.
Thank you, and thank you for taking my question. I am hearing Mrs. Casey, my third and fifth grade teacher's voice in my ear as I read this. And if you look on lines 6 and 7 of the bill as drafted, it says may administer vaccines as approved by an immunizing pharmacist and which have been approved by the Center for Disease Control. But I think the words which have been approved by the Centers for Disease Control ought to follow the word vaccine. And then there ought to be a comma, and as approved by an immunizing pharmacist, because those words relate to the vaccine. They do not relate to the pharmacist. And I would just suggest
That's
that
correct.
if there is a
Yes.
if there is an amendment, that might be put in as a thought.
Representative Weber, thank you for that. I totally agree with what you're saying. I also, in the amendment, inserted the fact that, which is not coming, the one before you doesn't include it, but the one that's coming is going to use this, unfortunately, the same language that you're referencing, but it did include the language that the vaccine also had to be approved by the FDA, not just by the CDC. So that's going to be included in the amendment, but I will definitely go back and work on the language. And if you'd be so kind for me to send it to you to review it before I submit it, I would appreciate that.
John Sherrill, my editor of my second and third book, would like to meet your third and fifth grade teacher, Representative Weber. I didn't know that until I started writing as an adult, and you were well educated. Thank you. Representative Cushman.
Yeah, Leah, unmute.
You're on mute, Leah.
Thank you. Thank you, Mr. Chairman. Thank you, Representative Merchant. I am wondering, does this bill, so if we are, and I'm glad that you said that you have an amendment coming forward to include FDA approval. This opens it up to pharmacists being able to give a lot more vaccines than they are currently able to give under statute. There are, I counted last night, 89 FDA approved vaccines. Many are competing with competing manufacturers for the same disease. And I just see this changing the dynamic on how pharmacists decide to recommend vaccines. And I see an opportunity for we see some whining and dining of physicians to prescribe certain medications by pharmaceutical reps. And, even when those are not the first line treatment or, the best option for a patient, as evidenced by the literature, the physician has chosen those based on their incentives given to them by a pharmaceutical representative. So my question is, should we really be opening this up for a pharmacist to, it could become an opportunity to sell as many vaccines as possible for any disease under the sun, including ones that are not typically recommended, like the BCG, the live BCG, which is the tuberculosis vaccine, and the anthrax vaccine. Those have high rates of adverse reactions. And I'm not sure if pharmacists take an oath to do no harm, but I just see some problems opening that up. Would you be okay with an amendment to keep it limited to the current vaccines that are administered by pharmacists: influenza, hepatitis A, hepatitis B, Tdap, MMR, meningococcal, and COVID-19, pneumococcal, and herpes zoster?
Representative Cushman, I want to say thank you for the question. What the amendment does, because I did make an error when drafting it, and it included all vaccines, and it was never the intent. So the amendment clarifies that to only the vaccines that are on the CDC schedule for adult vaccinations, which includes 10 vaccines. So within those 10 vaccines, basically 8 of them today a pharmacist can give, or adding the other 2 to align it completely with the CDC guidelines. As far as looking at the vaccines and which ones, most pharmacists today work in corporate America, so the decision upon which vaccine is being purchased, if you will, is not done locally by the pharmacist, it's done by corporate America. So that's kind of, I hear the concern, but I would say the concern for the most part doesn't really exist at the pharmacist level because they're not the ones deciding upon which vaccine, which brand of a vaccine to utilize. It's done by their the corporate America that they work for.
Representative Gay.
Thank you so much for taking my question. I'm sorry I didn't know it before. VI, record the vaccination in the state vaccine registry. Since that is going to be an option, if people so choose, the rest of VI says, to me, the whole thing, maintain a record of administration of vaccinations for each individual as required by state and federal law. Would that be acceptable to you to remove that, record the vaccination in the state vaccine registry and just use the rest of the sentence?
Representative Gay, can you say that again? Which line do you want, ma'am?
VI,
Yeah.
the first words are record the vaccination in the state vaccine registry and,
Line 26.
yes, sorry, line 26. Because that's a choice of the person who's receiving the vaccine. And right now it doesn't even exist. But the rest of the sentence says it. It says you maintain a record as required by state and federal law. So to me, that would cover it without
Yeah. I'm not
making it
opposed.
mandatory.
Representative Gay, I'm not opposed to taking out the word record the vaccination in the state registry because at the end of the sentence, it does say as required by state and federal law. So if the state and federal law do not require it, then in essence, that takes precedent over the earlier part. So, but to pull it out completely, I have no objection to that. I just think that it helps to clarify it so that the person only puts it in there if it's an opt-in, opt-out situation, which is a different bill. I just want to be sure that we don't have language in one bill that conflicts with language in another bill. So I'm trying to write in such a way that when you look at the state law, whatever the state law is what you have to comply with. So if it's an opt-in, they do that. If it's an opt-out, they do that.
Representative Gay, do you want to follow up?
Yes, so is that acceptable to you to take that out? To take the record the vaccination in the state vaccine registry? Remove it? It would make me a lot happier because that comes across as we're gonna do it and you've got to make quite an effort to make sure it doesn't get recorded if that's so what you so choose.
I'm not opposed to taking it out, but I do concern myself is that down the road, if the law changes or something else, I just want to be sure that whatever the law is there, which we can leave in there, is what we comply with. So if you want to take it out at the beginning of it and say maintain a record, the question is what's the record? Because there's no reference to what that record is. If we don't have a registry, when you talk about maintain a record for administration, where is that record going? But back to the same thing with Representative Marsh, then we could go back to the paper system and saying you have to submit it to a provider, a PCP, whether you have one or not. That's been difficult for us in the past because many times as pharmacists, we provide information back to the provider's office, but it doesn't get into the chart because the staff at the office doesn't always put it in the chart. So I'm trying to be sure that whatever vehicle we have for communication is going to be workable, timely, so that all the parties are aware of what's going on in the vaccine world. And that's my concern is that if we don't put something in there about the registry, then what are we going to use for recording the vaccine? What's the record? I'm not opposed to it. I'm just not sure what the alternative is.
Thank you. Representative Weber, you had your hand up. And your mic muted.
That was user malfunction. I'm sorry.
Test them all out. We got to do that periodically. Representative Cushman.
Thank you again for taking my question, Mr. Chairman. Representative Merchant, I am just wondering, what are those 8 vaccines that you were saying? So in addition to the ones that are in statute currently, can you send me those 8
Yeah.
and tell me what? Well, I mean, I can figure out which ones are not.
Last night I sent out to the committee, if you look on the CDC guidelines on the links to it, if you look at the vaccines that are on the CDC, I can pull it up to share the screen, but there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 8, 9, 10. There's 10 of them that we currently are allowed to administer, and there's 2 additional ones. And the 2 are HPV, and the other one's Haemophilus. Those are the only two vaccines that are on the CDC adult immunization schedule that are not currently allowed by law for the pharmacists to administer.
May I have a follow-up?
Follow up.
So the HPV vaccine, that's one that's also got a high rate of adverse reactions. And I think that these are in statute specifically named for a reason. We don't want to give, open this up broadly to anything that the CDC decides is added. And I think we want to keep the control within the state on what we can have our pharmacists give. So would you be okay with an amendment? Would you look at an amendment to just keep it with what we have in statute currently?
I would look at an amendment, but I think, again, the same thing, what we're running into now with COVID, which is showing us whenever there's another vaccine that the CDC wants to be able to be provided by a pharmacist in the pharmacy community, then we have to go back to the statute or through emergency order to add it. And my concern is that by doing it that way, the ability for us as a state to react to something in a relatively timely manner is diminished.
Thank you. The chair recognizes me, who has his hand up. I'm part-time CEO of a massage and counseling and family practice facility with 3 PCPs. And we have, as most primary care offices, our patient visits skew very much to the older. We don't see the youngins very often. We see the older ones quite regularly. And they have at least as bad a memory as I do, which is not very good. And I'm sure there are occurrences where they don't remember that their PCP gave them something 3 months ago. And here they are in the pharmacy. And it sounds like it'd be a good idea. And they're with somebody and said, Nana, did you get your shot? And she says, I don't think so. And wouldn't it be advantageous before the pharmacy gives the shots, not because they're not capable of it, but the person before them may have already had one and doesn't need one? Wouldn't that be a good idea, is to call the PCP first, not later?
Mr. Chairman, you spoke very eloquently to why we should opt in, not opt out of the registry. I couldn't have asked for a better introduction to that. I think part of it is communication. I think that's one of the reasons why other states in the country have a registry, to avoid that, because even myself as a patient, I don't always keep track of my vaccines, but if it's in the registry as a record, and therefore everyone has access to it, then at that point in time, the provider can go to the registry and say, oh, Mrs. Smith, you've already had your pneumococcal vaccine. You do not need to have it again. You had it 2 or 3 months ago, or even a year ago, 2 years ago. So to answer your question, I think it's back to the communication tool that we all use. And therefore the registry becomes the vehicle that we can all utilize independent of each other. So therefore I would say that, yeah, that's definitely a situation, but don't forget also, I don't know about you folks, but most people today, I know my father goes to probably 3 or 4 or 5 different doctors. So the world of having a primary care doc per se, he has a pulmonologist, he has a cardiologist, he has a rheumatologist. And he sort of jokes about it. He says, I go back to the old days when I had Dr. Welby, MD, and I had one physician. It made my life a lot easier. In the communication. So I hear what you're saying, Chairman.
Yeah, I wasn't trying to be eloquent. I was just trying to make more work for my staff. But thank you for connecting the dots. Anybody else with a question from the committee? In which case, thank you. And thank you for being our committee now. Appreciate that very much. We've got a couple of people that I've been informed wish to speak, and they wish to testify. They include.
Mr. Chair.
Yes.
I'm sorry, Representative Nelson has his hand up.
Oh,
Representative Nelson, thank you so much, Representative
Thank you.
Cushman.
Thank you to both of you. Could all the people who have all these suggestions for amendments, could they please directly send them to the author of the bill? Because I can't keep track of them all, the suggestions they have to fix this or that.
Spoken as the clerk should speak. Yes, they should go to the primary sponsor who coordinates all of that. And
Thank you.
Anybody can make an amendment.
Yeah.
Anybody can come in with a hostile amendment, but it would be much better, I think, and who we are, if everybody with an encouragement, a suggestion, or even something a bit negative would get to Representative Merchant, so we could have one amendment. And if that doesn't satisfy an individual, we will entertain that individual's contra amendment as well.
Thank you.
But thank you. Laura Condon, please, is invited.
Good morning.
Good morning.
Okay, good. That means you can hear me.
It does.
Morning, Mr. Chairman, and honorable committee members. My name is Laura Condon. I'm from Bedford, and I'm a volunteer New Hampshire Director of Advocacy with the National Vaccine Information Center. And I testified today in opposition of House Bill 572 for three particular reasons. But before I get to my three reasons, I would like to add some information to prior testimony. Number one, the adverse effect reporting from adverse effects of vaccination is required by federal law that providers of vaccination do submit vaccine adverse events to the vaccine adverse event reporting system. There was question whether that would be required of pharmacists. My understanding, I'd have to double check federal law, that it requires providers of vaccines, and I assume that would include pharmacists. So I do believe that is a requirement. It'd be great if that was highlighted in the bill. There was also mention that it is difficulty for providers to keep a record of vaccines, and how is a pharmacist going to keep that? Current law requires that doctors keep a record of vaccination given to their patients. I'm not sure if that law makes the same requirement on pharmacists, but it certainly does on physicians. And it also requires that those individuals being vaccinated be given a record of their vaccination at the time of vaccination. So those things are currently required under current law by doctors. I'm not sure if that extends to pharmacists. I'd have to check that. So just wanted to mention those. My objections to the bill are, number one, is that influenza vaccines should be limited to adults. In this law, it allows for influenza vaccines to be given to the general public, which of course would include infants as young as 6 months of age. This trivializes the very real vaccine risks and serious reactions by giving flu shots to infants and children in the corner drugstore or grocery store pharmacy. Most pharmacies and grocery stores don't have life-saving defibrillators. Will pharmacists have the equipment and training to be able to tell the difference between cardiac arrest, anaphylaxis, fainting, and act accordingly to save the lives of babies and children who react at the time of vaccination? Also, this bill undermines the need for a medical home for a child. Pharmacists don't have the necessary medical history of an infant or child, or the time to pre-screen for contraindication based on the child's personal and family history and unique health needs prior to vaccination. Children today may get as many as 70 doses of vaccines for 16 different diseases. Many vaccines now come in cocktail shots containing up to 5 different vaccines in one shot. It is difficult for parents to remember if the flu shot was one of them. This is why they need a medical home to keep a patient history and vaccine schedules, including the flu shot when appropriate. In addition, influenza vaccination rates have been reported by Beth Daly of DHHS as being up to 70% for children in New Hampshire. So certainly there's no problem with access to flu shots for children. My second objection to the bill is that vaccines given in a pharmacy should be limited to vaccines for which actual FDA license has been given, and for those individuals for whom the CDC has recommended vaccines according to the details of the CDC's ever-changing recommended adult vaccine schedule. A pharmacy is not the place to be giving experimental vaccines like the COVID shots, for which there is only FDA emergency use authorization given and not FDA license. And my third and final objection to this bill has been mentioned here is it, and I think maybe there's a resolution to it, that it cannot be required that a pharmacist enter a customer's information into the state vaccine registry, because that is a voluntary program. And it is the customer and the pharmacy who is the controlling person, whether that would get entered or not. So I appreciate recognition of that concern. And for these reasons, I oppose this bill as written. Thank you very much for your time.
Will you take questions?
I certainly may.
I have one. I'm a little confused about your point number one, because as I am reading the bill, it says on line 4, immunizing pharmacist, and it has some helpers up there previously, may administer influenza vaccines to the general public, lots of. Line 7, to individuals 18 years of age and older. So I think that obviates your point 1, unless I'm reading it wrong.
Actually, I believe that what it's doing is it's doing a carve out here, that the reason that the influenza vaccines are mentioned separately is because that would be for the general public at any age, but all other vaccines would be limited to those age 18 and older. And I'm sure that Representative Merchant can correct me if I misunderstand that.
Well, I'm really looking for Representative Weber's 3rd and 5th grade teacher here, because it is a linguistic thing.
Yeah.
And we can't bring up the bill's sponsor to answer at this point, but we can bring up anybody else who's learned to read on the committee. So am I correct, or am I misreading it, that lines 3 to 7 limit flu vaccines to those 18 years and older? Am I correct, Representative Cushman?
The way that I read it is the way that Laura Condon reads it. I see that that is for the general public for the influenza vaccine. And then the 18 years or older applies to all the other vaccines approved by the CDC as written in the bill.
Well, I can't call Representative Merchant back up, but what I will do is ask him to make the wording a little clearer so we know exactly what you mean. And I'm quite happy to be proven wrong, but you got to prove it. And I'm sure Representative, no, I didn't promote you, Miss Condon, you've done a lot of work in this. So if Representative Merchant could clarify that linguistic question for me, at least. Anyone else wish to address Laura Condon? Representative Cushman.
Thank you, Mr. Chairman. Ms. Condon, do you see any issue with opening it up to the vaccines that are on the adult CDC schedule, in addition to the ones that are explicitly mentioned in the statute currently?
Yeah, I appreciate that question. It gives me an opportunity to clarify further, as I do know that it has been stated by the sponsor is that pharmacists can currently give, I think, eight or 10 different vaccines, but in fact, the law specifically limits it to influenza, pneumococcal, and varicella zoster. So which is only 3, which is what is listed in the law now. And that's being, crossed out in this bill, and then expanding it to all vaccines recommended for adults. As long as it's age 18 and over, Representative Cushman, I think it's buyer beware. It's up to the consumer to do their their diligence. These are adults. This is an access issue to vaccines. And, you know, I wouldn't curtail that. Personally, I wouldn't curtail that access.
May I have a follow-up?
One follow-up.
Thank you, Ms. Condon. And I'm just going to point you to the line in the bill. It's section 2 where it says repeal RSA 318-16D. That one actually does, it's in a separate section, but it's like a repeat of this section for specifically hepatitis A, B, MMR, and a couple of other vaccines. So they are, just to let you know, that they are in the statute currently. So there are 8. Sorry, that's not a question.
Well, you got to learn the art of faking us out by saying, wouldn't you believe, or haven't you seen, or do you know the little guy who told
May
me?
I point you to?
You're getting it.
Yes, you may. Thank you.
Anyone else? Well, thank you. Thank you again. You're one of our go-to people here on these matters. Now the chair recognizes Holly Stevens.
Good morning, Mr. Chairman, and members of the committee. My name is Holly Stevens. I'm the Health Policy Coordinator at New Futures. New Futures is a nonpartisan, nonprofit organization that advocates, educates, and collaborates to improve the health and wellness of all New Hampshire residents. In this role, we work extensively with policymakers, healthcare providers, and families to increase access to quality, affordable healthcare, including access to important vaccines throughout the Granite State. New Futures appreciates the opportunity to testify on House Bill 572. This bill not only expands on pharmacy staff allowed to administer vaccines, but it expands on the types of vaccines they are able to provide to the public. This bill would expand that capacity to all CDC-approved vaccines for adults and the COVID-19 vaccine for children and adults when it is readily available. While New Futures certainly supports increased access to vaccines for all Granite Staters, to do so while not knowing how affordable that access would be is problematic. While understanding that this testimony is on House Bill 572, it would be remiss not to mention the intersection of this bill with House Bill 604 and House Bill 221. The intent of House Bill 604 is to increase access to vaccines while reducing costs to the overall healthcare system. The pharmacies have resisted being involved in the proposed expansion of the state's vaccine program to include adults. However, they are asking you to expand the scope of their vaccine practice. Additionally, having pediatric COVID-19 vaccines administered through the pharmacies could undermine the successful and well-functioning children's vaccine program that has existed for nearly 2 decades. Additionally, this bill removes the requirement, as has been mentioned earlier, for pharmacies to notify a patient's primary care physician about vaccines given, relying solely on the pharmacist entering the information into the state's vaccine registry. And while I do believe some sort of a fix has been discussed here, my testimony was drafted in consideration of the bill as introduced. But House Bill 572 in its existing form would need House Bill 221 to be found inexpedient to legislate for it to function in a way that the patient receives continuity of his or her health care. And not only that, but in listening to the testimony here today as well, even if the registry was an opt-out alternative, those who decide to opt out of the registry because they don't want their information maintained in a public registry held at the state, they still may want their doctor to know. And I don't know that it's good enough to just say, well, then it's on the shoulder of that patient to let their provider to know. As Representative Merchant discussed, not all individuals have primary care physicians. And for those who currently don't have one, end up getting a number of vaccines at the pharmacy and then 2 years later obtain a primary care physician, they may not remember what vaccines they received at the pharmacy. So, and also, they may not remember even 2 weeks later when they have an appointment with their primary care provider, if they have one, to let that provider know that they received vaccines. It may not be high on their priority list if they're dealing with other medical concerns. So until the overall impact of this legislation is known, given its intersection with other bills that the House is currently considering, New Futures takes no position on this bill at this time. Instead, New Futures simply urges the committee to fully assess the ramifications of House Bill 572, especially in conjunction with House Bill 604 and House Bill 221 before proceeding forward with the bill. This assessment should include any potential impact to the overall cost to the healthcare system. And I didn't mention this in my written testimony, but any quality issues too. There were a number of quality issues that have come to surface during the discussion on this bill. And I just want to echo some of those concerns. The concerns mainly with the providers being informed of the vaccines and, you know, how pharmacies are going to deal with the COVID-19 vaccine with children and with adults. Currently, adults have to sit somewhere for 15 minutes after receiving that vaccine as they look for any signs of an adverse or allergic reaction. Are pharmacies going to do this? Are they going to have a place to park children and adults, requiring them to sit there for 15 minutes and make sure that they do, and or have them sign a release that if they have an adverse reaction and they leave, it's on them, it's not on the pharmacy. So with that, I will take any questions if there are any, and allow you guys to do the wonderful work that you do.
Any questions? Getting ready. With that, I close the hearing on 572. We're going to take a break in about 30 seconds, but before we go, please, everybody with some input, desired changes, suggestions, talk to Representative Merchant. And I might suggest, and it's only a suggestion, that a bill of this number of lines, which is to me a small bill, 30 on one page, one on the other, by the time you cut and paste, an amendment should go here and an amendment should go there. Allow me to suggest that you write an amendment that starts off roughly with the words, after the enacting clause, replace the whole darn thing with the following. I mean, you wouldn't say that exactly, but that's what it would want to say. So that way we look at a clean copy. We look at the bill as you have worked through what you wish to take from the suggestions of various people, rather than having to draw arrows and scissors and paste and so on.
Thank you for that advice, Mr. Chairman.
Well, something I learned the hard way, like most things. Anyway, let's take about a 10-minute break, folks. And we will be back then with Representative Merchant and another bill.
Chairman? Mr. Chairman? Apparently not. Okay. Mr. Chairman?
Yes.
I just wanted to note for your information that as I look out the window, the ice here is beginning to build up fairly alarmingly. So if I vanish, I will do my very best to find a different way back to the meeting, but it just looks like branches are beginning to be weighed down a bit. So I wanted to let you know. Thank you.
You're in Concord. You're in Concord?
No, I'm in Walpole.
Okay. All right. I looked
Although-
at, yes,
Walpole has not yet had any flutters of the electricity, knock wood, but Concord has, so. go
well,
figure.
I looked in the weather, 7-day weather forecast, hoping that we might have a snowstorm next Tuesday, but unfortunately it's snow on Monday and we meet next week on Tuesday. So,
Yeah. And Lucy, one time I did actually use the cell phone. It's, it's not optimal, but that's also going to be my backup if the power goes out, although we've got a generator, so I should be okay. But the cell phone is not fun, but Bill can attest to that one. But
I have a generator and I have an iPad.
Well, I have a generator, but that doesn't help me a bit if the cable goes down.
oh no, if the cable's down, you're screwed. Well, the phone though, the
Well, I
phone.
have an iPad that connects to satellite, but
Yeah, then you're good. Yeah.
Yeah, I set up my phone so I can have the app on my phone if I need to, like Jerry suggested. So I won't get stuck like I did last time.
and I am hoping, no, darn it, I didn't manage to change the color of the hand, so. I will say that when the hand is raised, the person raising the hand, if you're using gallery view, goes to the upper left-hand corner and they show up in the order in which they have raised them. So I have found that to be useful in other meetings.
I wanted to make my raised hand be
it's not
purple
so
because then everybody would see me first.
it's been done already. Hasn't it? Hmm? Okay, we are on, whoops, we're not. Wait a minute here. And it's that time. So I open
479.
the hearing on House Bill 479 relative to pharmacist provider status and nicotine cessation therapy. And that will be introduced by Representative Merchant. I hope.
Representative Merchant was rebooting his computer, so it looks like he's just reappeared.
I see him.
There he is. 479, Representative rebooted Merchant.
Thank you, Mr. Chairman. Also, the members of the committee. For the record, my name is Gary Merchant, Representative Gary Merchant from Sullivan County District 4, Claremont Ward 2. I'm here today to present House Bill 479. House Bill 479 has two components to it. One is reimbursement through Medicaid, and the other one is an expansion of scope of practice to allow pharmacists to provide nicotine cessation therapy. Let's talk about the first one, healthcare provider status, and why that's important. CMS will only reimburse the state for services provided by a recognized healthcare provider, and it has to be done in statute. So Currently, when a pharmacist provides services that are not related to the dispensing functionality, such as smoking cessation or other things they may have within the scope of practice, they cannot bill Medicaid. And the reason why they can't bill Medicaid is Medicaid can't go to the CMS at the federal level and seek reimbursement, which is only about 50% of the cost. So what this bill fundamentally does is recognize pharmacists as healthcare providers, which therefore allows Medicaid, the state plan, to seek reimbursement from the federal government on the provision of what's provided by the pharmacists within the scope of practice. So it's a simple fix to basically allow for that to occur and for the state itself to get at least 50% of it back from the federal government. The other one is about smoking cessation, which is really kind of an important part. If you look at the U.S. Surgeon General, the report in 2020, one of the things that was brought out by the report is we know tobacco smoking is a major contributor to healthcare cost because of all the disease and so forth related to it. What we're trying to do, which is what the report stated, was to make it as broadly available to patients to have access to products that would help the patient to quit smoking. There's numerous studies that show that it takes multiple times sometimes for that to occur, but the primary reason is the patient has to decide when they want to quit. And trying to take advantage of that by allowing the patient to have access, easy access, timely access to a therapy will help immensely in compliance for the patient to make the decision to take themselves off from tobacco products. So the intent here is twofold. One is to increase the reimbursement through the Medicaid system for the services provided. And number two, to simply allow pharmacists to provide smoking cessation therapy, nicotine replacement, based upon the schedule of the patient versus otherwise. So we know that access is a primary issue. Timely access is important. And all this does is fundamentally allow the pharmacist to provide that access point for the patient to pick up nicotine replacement therapy at their discretion when they feel comfortable to do it. Number two, when you look at the number of times a pharmacist interacts with a patient, studies have shown that most patients, particularly in Medicare, visit a pharmacy twice as often as a primary care. So they're in an ideal situation to identify patients or look and help through a conversation with the patient to encourage them to actually take and stop smoking. But again, it's one thing to say to stop smoking, but to be able to give them a product that will actually help them quit the nicotine cravings that the body incurs when you're onto a nicotine product like tobacco. So that's the intent of the bill. It's fundamentally to allow for reimbursement and to allow pharmacists to have the ability to help patients in their quest to stop smoking. So I'll open it up to questions.
Representative Nutter-Upham.
Hello, thank you for taking my question. I know some people take Chantix, if I pronounced that correctly, to stop smoking. Would a pharmacist be able to distribute that or prescribe that?
If it's approved by the FDA for that reason, yes, they would. So the law only allows a pharmacist to provide to a patient products approved by the FDA, which have an indication for smoking cessation. So if the product does not have that indication by the FDA, the pharmacist would not be able to provide it.
Okay, thank you. Thank you for taking my question.
You're welcome.
Representative Snow, please unmute and ask your question.
So you're on mute.
Representative Snow, you're still on mute. We can't hear
close.
you.
Am I unmuted now?
You're good. You're good now.
Okay,
brother.
should I, sorry about that.
You start over. You can start.
All right, I'll start all over. Thank you,
Yep.
Mr. Chairman, and thank you, Representative Merchant, for taking my question. I just need to be assured that what's on page 1, lines 3 through 6, which basically gives carte blanche to pharmacists to perform any services that are provided by physicians or ARNPs, and yet they don't mention any specific services that come under. But I think that gets clarified, if I'm not mistaken, on page 2, where it does describe that it needs to be done under a prescription from a pharmacist or an ARNP. In other words, they have to order that specific treatment, smoking cessation. And it wouldn't also allow this pharmacist to do heart surgery or something else that a physician could do, or any other medical practice. Am I correct in that assumption, that this is not carte blanche, but it needs to be specifically ordered by a physician?
Representative Snow, thank you for that question, and I will clarify. The ability for the pharmacist to provide a product is twofold. One is the authority to provide it, but also they work under a standing order from a provider. So they don't have individual prescribing authority. They work under the standing order of a physician or nurse practitioner. And also there's a statewide protocol developed by the Board of Medicine, the Board of Nursing, the Board of Nursing, Medical, and also the Department of Health and Human Services. So the protocol, which is what they would follow, is guided by those respective boards in the Department of Health and Human Services, as well as the authority to do it flows through a provider through a standing order.
Okay, and that standing order has to be very specific. In this case, it would not necessarily extend anything not named in that standing order that would ordinarily be provided by a physician. Is that correct?
Correct. That's so basically the standing order, which is what the physician is providing, will specify to that exactly. And then what it normally says is that the pharmacist, through their authority, can follow the protocol as this protocol is written.
Thank you very much.
Stay within those boundaries.
Thank
It's
you.
not allowing them carte blanche to do anything.
Yes, thank you.
Representative Woods.
Thank you, Mr. Chair, and thank you, Representative Merchant, for taking my question. We discussed this some time ago, and I've forgotten how this came out, so my apologies for asking the question again. But that refers to the standing order, which is introduced on page 2, line 17. I need clarification again, exactly how that's structured and how it's interfaced with primary care and his physician. And I have a follow-up depending upon the answer. Basically, my question is, how is that standing order promulgated and how is it instituted? I mean, there's a standing order and I'm a primary care. Did I write it? Is it a standing order written for each individual primary care? If it's not, if it's written by somebody else, an agency, what's the ability for a individual primary care to, shall we say, opt in or opt out of that standing order? You're on mute.
That's why I was talking so well. So given the fact that today patients see multiple providers, which pharmacists are basically, in this instance, becoming part of the healthcare team, we don't require the physician or the provider to go to notify the primary care if they want to treat the patient. It's not built into the system today. Again, back to my father who sees a cardiologist, who sees a rheumatologist, and sees a pulmonologist and so forth. The pulmonologist doesn't call the primary care to initiate therapy. There was probably communication back with the primary care, but it's not required. The issue we're trying to talk to, I think, is a fragmentation of healthcare system that we're involved with today. And what we're trying to do fundamentally is not to build barriers up to it, but accept what's in place that we have today that allows for multiple providers to help treat a patient. In this particular case, we're talking about smoking therapy cessation. At that point in time, because you're working under a standing order, the authority flows through that physician, just like you would any other physician. And as far as getting back to what you're trying to get to is when the standing order comes from the physician, so that standing order would therefore have to come not so much from the primary care doc, but from the physician that the patient's coming under, which would be the person writing the standing order, or taking the authority from that point of view. I do hear your concern in there, and I go back to what I mentioned before. With the system we have today, it's not always the ideal system, but it is the system we have. And with the what's available versus putting a barrier in place.
Representative Shapiro has his hand up.
Thank you, Mr. Chairman, and thank you, Representative Merchant. I know the first part of the bill recognizes pharmacists as providers for the purposes of Medicaid state reimbursement. Does this bill also imply that pharmacists will be able to be reimbursed for prescribing smoking cessation therapies? I know they're not technically prescribing it, but through a standing order. Would it allow them to be reimbursed?
Yes, it would allow them to be reimbursed for the evaluation, because when you look at the patient coming in, what the pharmacist is going to have to do is sit down with that protocol and go through that protocol with the patient to be sure the patient, in fact, meets the criteria within the protocol, and that takes time. So therefore, that time element would be built to Medicaid. The dispensing of the product, if it was so desired to do that, would not be a service, patient care service, it'd be a dispensing function. So this allows for the pharmacist to be reimbursed with the time element that they need to do it appropriately to be sure the patient meets the criteria within the protocol. If the patient doesn't meet the criteria within the protocol, then the pharmacist would therefore make a referral to a provider because it goes beyond the constraints within the protocol.
Thank you. Could I have a follow-up?
Follow-up.
So would that work through private insurers as well, or just through Medicaid?
This is only dealing with Medicaid.
Okay. One more follow-up?
One more follow-up.
Okay. So in trying to understand the standing order, the standing order is not given by the primary care doctor, but does each pharmacy have a specific standing order from a specific doctor, or is there just a statewide standing order?
That's a good question, Representative Shapiro. We don't use the statewide standing order, but we do use it in naloxone. So for instance, in naloxone, the Department of Health and Human Services issued a standing order at the state level. So all pharmacies can therefore provide naloxone, Narcan, to patients or family members that may have an issue with opiate addiction. This one here is more specific than that. It's not broadly written so that it covers the whole state. The physician that does it would covering only those that are under the direction of the pharmacist. So in other words, if you're writing a standing order, only the ones that can use the standing order are the ones that are coming under the standing order by the provider. It's not statewide, it's specific to what the provider wants to do. So if the provider wants to make it general, they could, but if they want to make it narrow, they could too. They could specify within the standing order, they only want these pharmacists to be part of it, or they can make it broad and say, I'll take on the responsibility for the community at large.
Thank you.
Representative Gay.
Thank you very much. I guess I need to clarify something really basic, and that is by making the pharmacist a provider, at least to Medicaid people, that's another clarification I need. By making the pharmacist the provider, that means they can order the prescription. They can write the prescription to use the standing order. So that's question one. And question two is, what exactly is considered nicotine cessation therapy? Because it says means medications, and the medications are either with prescription or without. And if you don't need a prescription, what exactly is nicotine cessation? Is there any counseling involved in this? Is this just writing a prescription?
Okay, let me, so the first question, Representative Gay, in regards
Yes.
to the authority to prescribe is not independent. The authority to prescribe, and it's really not prescribing in a sense, but to order the medication flows through a provider. So it's going through a physician or a nurse practitioner. So the pharmacist does not independently have that authority. They have to work with a provider or a nurse practitioner. So they are the ones that assign to the pharmacist the authority under their authority to provide the product.
To order the product too?
Correct. So in other words, they only can do it if they're given authority by the physician through the standing order. So they cannot do it independent of a provider. So their authority flows as a subset under the provider. They don't do it independently. Okay.
You want to follow up, Representative
Yeah.
Gay? You okay?
Yes, thank you. Does this mean that the provider through whom okay, it sounds like a pharmacist has an agreement with the provider that they can use a standing order, which brings up to me a question like, does the person who's asking for this treatment, is this their provider, or is this just a provider who has given authority to a pharmacist without regard for who the person is who comes in for the treatment?
The authority flows again back to the provider. It's kind of, in other words, how can I say this? When a patient comes in and has the therapy, what the standing order does through the provider is say, if a patient comes into your pharmacy, I will give you authority to treat that patient, but you have to do it within the constraints of that protocol. If you don't follow the protocol, you don't have any authority. So at that point in time is the physician or the nurse practitioner is granting the pharmacist the ability to treat the patient, provided they follow that protocol.
Okay.
They can't, they cannot, as a pharmacist, they cannot deviate from that protocol. It's basically an algorithm they have to go down through. It's a checklist to be sure the patient qualifies for the therapy. But the authority flows back to a physician ultimately.
Okay, and my first question?
Can you?
My second question, what comprises nicotine cessation therapy other than just ordering a medication?
Well, this is another quirk in the Medicaid system. Medicaid recognizes that nicotine cessation products to help a patient get off from tobacco products can be over the counter as well as prescription. However, Medicaid will only pay for a medication if it's ordered by a provider. So if the patient decides to get nicotine patches, instead of them having to reach into their pocket, which becomes a barrier, a financial barrier, what the state recognizes is that we want them off the tobacco because it's in the best interest of the state, both economically and for the patient health-wise, is if the provider authorizes it, the state will pay for it. So it's a quirk in the system. It's in a lot of ways, it's the same way with healthcare insurance today. If you have an over-the-counter product, sometimes the insurance company will pay for it, sometimes they won't. But if it's not something in which a provider's ordering for you in some capacity, they won't pay for it. So it's one of those things where we're trying to write it and saying, whether it's over the counter or a prescription, Representative Gay, then reimbursement to the pharmacist for the product as well as the service would occur. And we're trying to encourage, again, back to the same thing we talked about before. It's not just the assessment of the patient, it's also the counseling that goes with it. So it's time consuming. When you start looking at the engagement with the patient, we want to be sure that the pharmacist is fairly compensated for the additional time that they have to take with the patient to do it safely and appropriately, so that they have the counseling and have the right product they need to try to get to the end result, which is getting off the tobacco products.
The chair
that
we're going to move on to the chair recognizes Representative Knirk. Yeah, you.
Sorry, I didn't realize I was up next. Thank you very much for taking my question. So on page 2, lines 26 through 29, which prohibits seeking personal financial benefit with incentive-based programs, which I think is great. Wish we had it for surgeons. But in any case, because there is a bit of a conflict of interest with a vertical monopoly where you decide that the patient should get it and also you provide it. So does this sentence apply to only outside inducements, like from a company that makes them, or does this also apply to the metrics that might occur in the pharmacy guiding compensation based on the productivity of the pharmacist?
That's a good question, Representative Knirk. The language in there applies to all providers, including physicians and nurse practitioners. So therefore, whatever is applicable to a provider, be a physician, nurse practitioner, and so forth, as far as the disincentives that we're talking about, would be equal across the board. So all parties follow the same rules and regulations. So if a physician is in the office, could do the same thing where all of a sudden a patient comes in and the provider could look at it and saying, I'll give or do something for the patient procedure wise and so forth, because I'll get extra revenue. That's not what the intent here, but it's nothing to prevent a provider from overdoing things for a patient either.
Well, I agree, but
would you like a follow-up?
Yes, sorry, I agree. My apologies. I agree, but my question is, what about are there incentive programs for reimbursement within the pharmacies based on pharmacist productivity in terms of the number of people they either interact with or that proceed on to the intervention? I don't know. I'm asking.
No, I think, not that I'm aware of. I think it's somewhere along the way, we're all, including providers and physicians' offices, we all have people that look at our productivity and say, are you generating enough revenue to support yourself? I mean, it's very much a common in the medical. Where I worked before, because a lot of doctors were measured by their RVUs, relative value units. And if they didn't have enough RVUs, which is kind of the same thing in a law where you billable hours, someone had to talk to you. So I don't like it, but it could possibly be there.
Yeah.
Want another follow-up?
Please. Yes, and I agree with you. It's a problem. So here's a question too, though, that relates to the same issue. If a patient comes in to fill a prescription for lisinopril or something, is the pharmacist allowed to solicit and ask them about, are you having any difficulties with tobacco and would you like to participate in nicotine cessation? Or must the patient initiate the visit for that purpose of nicotine cessation?
Wow, good.
Well, I would say that's a possibility, but I would also encourage the pharmacist's engagement with the patient because, as I mentioned before, the number of times a patient goes into a pharmacy to see a pharmacist is probably twice as often as a primary care doc. Right. They know the patient population. I would not want to gag the pharmacist when they recognize a patient may benefit from the therapy with a fear of someone saying, well, you're trying to do it for self reasons versus for the patient's reasons. It's a difficult thing to tackle. I don't disagree where you're going, but I would not want to include in the bill some sort of a clause in there. I think we have to look at people professionally and honorably, and until otherwise, that they're doing things best for the patient and not for themselves. And that's kind of why we're professionals. I hope that stays with most of my peers and colleagues.
Right.
Representative,
one other really quick one, if I could.
If it could be very quick.
It is quick, I think, because I think it's obvious, but I'm not sure. But thank you, and I agree with you. You mentioned this is only Medicaid, so why not including other insurances, or is that just too complex?
It's too complex because the Medicaid system, it's just a long story.
That's fine.
It's very complex and it's not prime time for us to go.
Thank you, Representative Weber.
Thank you, Mr. Chairman. And I realized when I was listening to some questions by Representative Gay that I may have been making assumptions about who we are contemplating as a provider. Is this intended to be used by individual providers prescribing for individual patients known to them? Or is it intended to be the sort of standing order that one of the state doctors writes as a statewide thing? Or is it intended to be both?
It could be either. It would be nice if we could do something at the state level. The chief medical officer within the Department of Health and Human Services would sign a standing order, which applied throughout the state. In the past, that hasn't been the case. So it does allow for a physician within the confines of whatever they want to control and say, within this group population of pharmacists, I'm okay with giving them the authority because I have some way to direct it. If I'm working in the medical center and I have the ability to work with pharmacists in an outpatient setting, I'm only giving out authority to people within my own organization. So it could go at the state level, which is what I'd like to occur, but we haven't had that successfully done except for naloxone. But this does allow a physician within an organization to say, if the pharmacist is within my organization, I feel comfortable and they can come under the standing order. But the physician controls it ultimately.
Okay, thank you very much.
Representative Woods.
Thank you, Mr. Chair. And again, I'm going back to the same question. I'm a patient and I come in and I have no doc. I'm just, I want to get rid of this smoking problem. Do you have the standing order from someone? How do you proceed if I don't have a doctor?
Because in that case, if you have a need for the therapy, it's been identified as appropriate, the authority of flow would be just like a provider. The pharmacist becomes another provider within the realm of the healthcare team. So the authority for them to be taken care of flows through a physician. And therefore, we've lowered the barrier for the patient to get the therapy versus making another appointment with somebody else. So if you have a primary care doc, you probably would not go to a pharmacist. Sometimes you would have a situation where if you don't have a primary care doc, they could walk into a mini clinic now and see a nurse practitioner. They could walk into an urgent care center. So basically, we're trying to build access points for the patient to have the ability to see a provider who's been trained appropriately, like all the others, to provide the therapy. But the authority for it flows through the physician or nurse practitioner, not independent of them.
But I understand that, and I understand the need and the arc of the changing of medical care, such as we have hospitalists and some physicians don't go to the hospital anymore, and a variety of other changes. But again, going back to my question, what happens to the person who comes in? I don't have a doc, I don't have a nurse practitioner. How do you get the authority at that juncture? The point has been made that it flows through the physician or nurse practitioner. So I guess I'm dense here and I need some help. But how does that person that comes in that has no contact how does the pharmacist get the authority?
Well, I think there's two parts to the question. One is the patient doesn't have a primary care doc, and then they're sort of out there on their own to some degree. They don't have a medical home. They don't have that kind of infrastructure that they can advantage of. What this bill does allow the patient to do is access therapy through a pharmacist. Now, back to the issue about the authority the pharmacist works under. The pharmacist works under authority like pharmacy. At that point in time, there's a physician at the medical center who gave me the authority through the standing order to treat that patient. So therefore, if the patient comes in, wants to have access to nicotine cessation therapy, and I recognize that they do, and they can follow within the guidelines of the protocol, then because of the authority from the physician within my organization, I would be able to provide it. But it's up to the physician at that point in time deciding upon what the extent of authority they provide to the pharmacist, because they control it. It's kind of like working under a PA or someone else. So you give them the authority to work with the patient. And I'd like to see it at the state level so that we have to put each organization approaches it differently, so we don't have a state standard, but that's kind of the way it was structured.
Representative Marsh has texted me thinking that he might be able to answer this question with other language. So I'm going to bump him up to next. Representative Marsh.
Thank you, everybody. I think I'm unmuted. I wanted to help participate in the discussion. I hadn't originally signed up to speak, but I think I can answer your question, Representative Dr. Woods. The way we originally crafted this language was to craft it with the most flexibility possible. So if you, in your local community, where you've been the primary care physician forever and a day, want to take care of the members of your community and issue a standing order to your pharmacist to say that if people can come in, they want to start smoking cessation therapy, fine. Got to give them this counseling. You can do this particular treatment, and then they have to come in to see me 2 weeks later or whatever. You can include all of those things in your protocol as you write it. But we're controlling that by the protocol, so it's under the physician's control and not mandating it by the legislature, putting in particular requirements. So it's not that Representative Merchant is trying to not answer your question. It's that we intentionally left flexibility in the way we structured it.
So a pharmacist could have something from Dr. Pearson saying, treat any and all, have fun. And therefore the pharmacist is now got his standing order.
Well, if Dr. Pearson were a licensed medical doctor, yes, that could be true. Yes, but I think that since the pharmacists hold liability here, if they don't follow things correctly, they would be well served, and I think intentionally would only follow standing orders that they too feel comfortable with. So they do have to work as part of a team, and the idea is to increase patient access and use the pharmacists as physician extenders. So ultimately, we can reduce the cost of healthcare for the state of New Hampshire.
I actually was referring to my wife, but I'll let it go. Representative Snow.
Thank you, Mr. Chairman, and thank you for taking my question, Representative Merchant. I'm confused, which is not unusual, but there are two documents we're talking about. One is a standing order, and one is a protocol, which, as I understand it, is a list of questions that are asked to determine whether it's appropriate for the person to receive this treatment. Now, does one grow out of the other? Are they totally separate documents? And who originates those documents?
Representative Snow, that's a great question. There's two separate questions in that question. Let me deal with the first one. The authority to do something flows through the physician or through the nurse practitioner. So an authority to provide product for the therapy patient. Now, as far as the protocol is concerned, that protocol is developed through a joint effort with people from the Department of Health and Human Services, from the Board of Medicine, and the Board of Nursing. So they're the ones that create the protocol based upon national, which pharmacist has to follow. So there's two things to it. One is, if you're given the authority under a provider to provide the therapy, you have to stay within the guidelines of a protocol based upon national standards approved by the Board of Medicine, the Board of Nursing, and the Department of Health and Human Services. Does that help answer the question?
Yes, for one follow-up though.
Go ahead, follow-up.
Follow-up. Has that protocol been developed, or is it something you would develop once this bill is passed? And isn't that sort of putting the cart before the horse? I mean, shouldn't we have this protocol available before we approve using it to qualify people to get into this program?
The protocol is not developed. The protocol needs to be developed. We did the same thing with another form of therapy. We basically, things change, standards change, and basically at that point in time, we're leaving it to the authority and the wisdom of the Board of Medicine, the Board of Nursing, and as well as the Department of Health and Human Services for them to develop a protocol that did for that therapy. Pharmacy is not developed, will have to be developed. But until the Board of Medicine, the Board of Nursing, the Department of Human Services signs off on it, it would not become active.
One final brief follow-up, Mr.
So
Chairman.
there's a safeguard.
Yes, go ahead.
Am I assuming then the date in this bill coming into effect is July 30th, 2022? Is it my assumption that prior to that time, this protocol will be developed or not? Did you hear me? Am I not muted again?
No, you're okay. I don't know where Representative Merchant went. There he is.
I'm having a little problem with I'm having a challenge with connectivity. I'm hoping in this neck of the woods, like Representative Weber talked about before, we don't have a problem. I think the wires are starting to wiggle, but I'm holding on as much as I can. Representative Snow, can you repeat that question, please?
Certainly, I'm sorry. Yes, I noticed that the date this bill comes into effect is July 30th, 2022. That's a year from this July. Can I make the assumption that this protocol will be developed and in place prior to this bill going into effect? Did I come across that time?
Representative Snow, yes, that's the reason why is the delay in the implementation is to allow for the protocol to be developed. And quite frankly, even if it's after January 2022, until that protocol is developed, the pharmacist cannot proceed accordingly. So it's going to require the consensus of the Board of Medicine, Nursing, and the Department of Health and Human Services on that protocol before they can move forward, regardless of the date.
I read on page 3, line 18, the effective date is January 1st, 2022.
Oh, I'm sorry.
That's okay. Your question still holds. And I believe the answer was whenever the date is, it won't happen until protocols are in place. Representative Weber.
Thank you, Mr. Chairman, and I'm going to try one more circle back. And I'm going to hope that we do not get swept away again with authorities flowing from one person to another, because I'm going to ask the question in the other direction. If I walk into a pharmacy and I say to the pharmacist, I desire to stop smoking, but I do not have a primary care provider, and I do not have a prescription. I just want you, Mr. Pharmacist, to very kindly help me stop smoking because now's the moment. Am I correct in thinking that unless you have some kind of standing order, if there is no standing order that I fit, you have to say to that patient, you need to go down to the urgent care center and talk to a provider, and they will then contact me, and at that point I can help you with your smoking cessation? Is that how it works?
Representative Weber, thank you for the question. Exactly.
Thank you.
If the pharmacist doesn't have that authority, you send them to another provider.
Thank you.
Good. Thank you. Representative Nelson.
Thank you for taking my question. Is the authority of the local doctor, whatever, provider, is that somebody sitting in the Walmart out in California, a doctor sitting there in a big office saying, I give you the authority to do that? Or does it have to be somebody that the person sees locally? That's my question.
Well, if you go back to on page 2, under line 18, it has to be a licensed practitioner in the state of New Hampshire. So if the provider is from California and does not have a license in New Hampshire, they would not qualify to create the standing order. It's limited to those who are licensed by the state of New Hampshire, both a physician as well as a nurse practitioner.
Follow up?
Follow up.
Well, if Walmart hires one doctor just to do this in Concord, New Hampshire, he does the entire state for Walmart, sits at home. Can he do it for any Walmart all over? Never, could he do it for any Walmart in the state of New Hampshire?
You talking about outside of the state of New Hampshire or within the state of New Hampshire?
Within the state of New Hampshire.
They could because it's within their organization. So you got to realize the physician, when they sign that standing order, takes responsibility as well as the pharmacist.
Okay.
So it's a shared responsibility between the two. The physician does not escape some liability because if they gave the standing order to a pharmacist that wasn't qualified and the pharmacist did something on behalf of the patient, they would have the liability as well.
Thank you.
So,
Dr. McKay.
Representative
muted.
Acton,
Jim,
if
you're
you
muted.
if you ask Dr. McKay to unmute, he will get a button that he can see right on his screen.
Dr. McKay, please unmute.
Unmute.
I think Lucy meant that Dennis has to ask him to unmute.
Right. Well,
Yeah.
he doesn't have to, but if he does, there will be a button on his
Yeah,
screen.
yeah.
You can see.
Yeah, I just maybe couldn't tell him verbally.
My list is sorted by first name alphabetically, so.
Right, Jim.
And you need to go to panelists rather than attendees.
Yeah.
Oh.
If you go to panelists and then Jim, you can give him a button to unmute.
Sorry about that.
Where is he? Why can I not see him? Oh, there he is. He's under initials RJ, if that helps.
Okay. And you're unmuted, Jim.
Okay, can you hear me now?
Yeah.
Okay, I'm sorry for that. Lucy has been great helping me, but I'm not a good student. But my interest is that having watched over time the evolution of pharmacy care, that at the same time, my impression is that the training of pharmacists has also evolved, particularly at the doctorate level. And some of these questions have to do underlying with the competence of pharmacists. So I wonder if Representative Merchant very briefly would say something about how this training has evolved.
Representative McKay, that's a good question. To ground us, when I was first a student in pharmacy, I worked with a colleague who was my mentor at that time, who actually never graduated from college. All you're required to do was take a apprenticeship program under the auspice of a pharmacist at that point in time, and then pass the exam. Since that time, it's evolved, to your point, where a pharmacist today spends 4 years in graduate school to either a 2 or 4 year undergraduate degree. So the level of training and expertise, as well as the classroom experience that we have, a lot of people today as pharmacists go into a 1 or 2 year residency program and set up a hospital on top of that. So pharmacists are well educated, well trained today to assume some of the responsibilities we're talking about today. And that's kind of what we're trying to advocate for, is that we have a resource within our healthcare team that is many ways underutilized. And we have a situation today in which we have a tsunami coming at us with a lot of people looking for healthcare, and we can't meet it, or we have access issues that we need to address. So by elevating the pharmacists to allow them to do more things, we accomplish two things. One is we allow the patient greater access to that healthcare point. Number two, we allow providers themselves to work at the top of their license so that they could take care of more complex patients and allow the pharmacists to do some of the things that they could do within their training they have today. So I do want to say thank you for that question, Representative McKay, because it's an important one.
I see no further hands up from the committee, and I see no attendees with a hand up indicating wishing to testify. So it looks like we're finished, and when I find my gavel, we will be, but don't run away. Here ends the hearing on House Bill 479.
Mr. Chairman, we had three people who signed up.
There they are suddenly with their hands up. So I am going to reopen this hearing. And I beg your pardon, I didn't see them with hands. So there they are now. The chair recognizes Bob Terrio, and with apologies for somehow missing you, you may come into the meeting.
Thank you, Mr. Chairman. Can you hear me?
We
speak?
can, sir, we can.
Okay. I've hit the unmute a couple times. Thank you. And
We're
members
good.
of the committee.
We're good.
All right. My name is Bob Terrio, and I'm speaking in support of House Bill 479. I'm a pharmacist. I'm the director of pharmacy at Wentworth Douglas Hospital, and I'm the legislative chair for the New Hampshire Society of Health Systems Pharmacists. What I'm hoping to be able to talk about is provide some examples of pharmacists as part of the healthcare team and physician team extenders. At my health system, we have a number of pharmacists that have collaborative practice agreements with providers. And so in our Seacoast Cancer Center, I have pharmacists that work with providers, and in their practice, they work with the patients, and they work on the anti-nausea medications and their pre-meds. They order them, monitor their treatment. I have a pharmacist in cardiology that also meets with patients on heart diseases and anticoagulation. And then I have a pharmacist in primary care that has a collaborative practice agreement with diabetes. And all of these pharmacists practice like a provider. They have appointments, the patient comes in, they sit with the patient, go over their drug therapy, they monitor their drug, they order different drugs, they change doses. And currently, they don't get paid for that service. I've had other clinics request those types of services, such as chronic pulmonary disease, pain management, and opiate use disorders. And again, to make the business plan, it's often hard to make a business plan with just quality metrics and freeing up the provider time. So payment for our services would really help give more access to care and would improve quality outcomes for some of these patients. Additionally, when you look at some of these diseases, so cardiac disease and cancer, a number of patients do want to quit smoking. And so it's not included in their CPA right now, but a standing order with our chief medical officer would allow during one of these appointments, if a patient expressed that they're ready to quit, that pharmacist could then initiate smoking cessation therapy. Additionally, at Wentworth Douglas, we have a community retail pharmacy. So when you get admitted to the hospital, one of the questions that is asked, are you a smoker? And are you interested in quitting? And so that information, again, during the hospitalization doesn't usually get addressed. But one of the visions we have is our ambulatory or retail pharmacy would have access to that information. And then upon discharge, they could work with the patient to implement smoking cessation and become, their source for helping them quit tobacco utilization. So any questions that you might have, as I said, I'm in favor of this. I think pharmacists are well-trained, as Representative Merchant said. They have a doctor of pharmacy, and most of my pharmacists are residency trained, either 1 or 2 year post their PharmD program. Thank you.
Any questions for Mr. Terrio? Seeing none from the committee, I will call next on Tanya Carlton.
Morning, can you hear me?
We can.
Good morning, Chairman Pearson and members of the committee. Thank you for the opportunity today to provide testimony. My name is Tanya Carlton. I am currently the clinical pharmacy manager at Wentworth Douglas Hospital in Dover, as well as the immediate past president of the New Hampshire Society of Health Systems Pharmacists. I'm here today to express my support of HB 479 and its goal of increasing patient access to nicotine cessation therapy. So as you all know, cigarette smoking still remains the leading cause of preventable disease, disability, and death within the United States. We still have approximately 34 million Americans who currently smoke cigarettes, and most of them are still smoking daily. Smoking kills over 500,000 Americans every year, and millions more live with serious chronic diseases caused by smoking. In addition, smoking-related illness in the United States costs more than $300 billion a year, including nearly $170 billion in direct medical care for adults and $156 billion in lost productivity. In the 2020 Surgeon General report on smoking cessation, the Surgeon General of the United States states the following: clinical interventions for smoking cessation are critical if we are to achieve our goal of eliminating the devastating effects of smoking on public health. Primary care physicians, nurses, pharmacists, and other providers in all medical disciplines and in all healthcare environments should take advantage of these opportunities to inform and encourage smokers to quit. Therapeutic assistance for smoking cessation includes medication treatment of nicotine dependence and counseling based upon behavioral science for psychological dependence. Pharmacists play an important role in encouraging smoking cessation and are poised to provide this type of support. Pharmacists have a good understanding of the medical condition and pharmacotherapy to treat patients and are able to obtain training specific to smoking cessation. As Bob said, currently at Wentworth Douglas, we have 3 pharmacists that provide care to patients in the ambulatory settings of oncology, cardiology, and diabetes management. All of these pharmacists have their doctorates in pharmacy, have obtained advanced training, and have advanced certifications. Collaboration between physicians and pharmacists with respect to managing smoking cessation therapy could achieve 2 beneficial goals of reducing demands on physicians' time while increasing access to therapy that can help those motivated to quit smoking succeed in this endeavor. One of the factors that plays a key role in the underutilization of nicotine cessation resources is the barrier to accessing a medical professional who can prescribe smoking cessation medications at the time when a patient decides to quit. HB 479 eliminates this barrier by providing pharmacists, one of the most accessible healthcare professionals, the ability to manage pharmacotherapy for smoking cessation. Thank you for your consideration, and I can answer any questions you might have of mine.
Before I turn anyone loose to ask a question, I'm going to ask Representative Folsom, who has just joined the meeting, to give us the essential information about where you are and how many people are there with you.
Hello, good morning. I am at home in Wentworth and my husband is roaming around the house somewhere.
Thank you. And
Thank
I'm
you.
going to keep Representative Nelson on as clerk until we're finished with this bill because he's doing a great job coming out of retirement.
Thank you.
Representative Gay.
Thank you. Thank you for taking my question, Mrs. Carlton. I just have one question, and that is, how much time with a patient do you envision the therapy to offer?
So our ambulatory care pharmacists, they have, like Bob said, they actually have appointments with these patients. And so they can piggyback onto, if they're managing a patient for heart failure or for anti-coag or for diabetes, they'll spend upwards of half an hour with these patients. They can include nicotine cessation as part of this conversation, which if you're talking about oncology patients and lung cancer, or cardiology patients and heart failure or cardiovascular disease or diabetes management, including smoking cessation and the ability to be able to treat it is vital to improve patient outcomes and improve patient access to these critical medications. They are also counseling and educating the patient on how best to take these medications. And they also have full access to their medication history, allergies, drug interactions, so that they can provide the appropriate care to these patients.
Follow up.
You're on mute.
This bill seems to apply just to Medicaid patients. For your private pay patients, do you get to bill for them? Because it sounds like y'all offer a lot of time. So is this a standard thing that you can bill for in other insurance?
At this point in time, no, because we're not considered to be providers. This bill's only going to allow us to bill Medicaid at this point in time. However, we would still offer these services to anybody that we see. However, we wouldn't receive payment.
Thank you.
Any further questions for Ms. Carlton? Seeing none, the chair recognizes Brianna Wheeler to speak.
Good morning, Chairman Pearson and members of the committee. Can you all hear me okay?
Perfect.
Perfect. So as you stated, my name is Brianna Wheeler, and I'm here to testify in support of House Bill 479. I am a pharmacy student in my final year of school at the University of New England School of Pharmacy, and I'm graduating with a PharmD in May. I currently live in Hillsborough, New Hampshire, and I'm a student at Wentworth Douglas completing clinical rotations right now. And so I recently had the opportunity to complete a clinical rotation with Dr. Maureen Brady, who is the ambulatory care pharmacist at the primary care setting, who has the ability to treat patients with diabetes. And so a large amount of these patients struggled with addiction to nicotine, and numerous patients did express interest in wanting to be rid of this addiction when asked. And so without pharmacists having the opportunity to take lead on managing treatment for these patients, they were not given the attention they needed, and many were lost to follow up. As you know, nicotine addiction does take a lot of time and attention. And so this bill could change that, as the pharmacists did have a lot of time and opportunity to create appointments with these patients and spend the time really needed to help them. And so I saw firsthand the impact a pharmacist could make on the patient's health and quality of life when given the chance to manage more serious conditions such as diabetes. So if you can imagine the impact this could make on the serious disease of nicotine use disorder. This bill is not meant to undermine the leadership of the patient's PCP. It is merely adding another tool to the patient's toolkit. And so with that, I thank you for your time, and I can answer any questions that you may have.
Well, as I think you know, because we've corresponded, my wife graduated from the University of New England with a doctorate in osteopathic medicine some years ago. So that prods me to ask the questions, since UNE has a pharmacy school and an osteopathic medical school. What collaboration do people from both schools do along the way?
We have many instances to collaborate, not only with the medical students, but we also have a school of dentistry, nursing.
Wow.
And so we actually fall under the umbrella of the Westbrook Health College, College of Health Professions. And so we have activities that we're required to complete that are called IPEC. So it's interprofessional collaboration, because, you know, outside of school, we are expected to communicate with the rest of the healthcare team. So we are trained fully to do that many times through our school career.
And you know, osteopaths love that stuff.
Yes, as do pharmacy.
Anyone else have a question for soon-to-be D-Farm Brianna Wheeler? Seeing none, thank you so much.
Thank you all.
And I see no one from the attendees who has a hand up who hasn't spoken yet. So I think we are finished on the hearing, and I will reprise my closing the hearing. Now, let me ask Representative Merchant, are you ready, if we choose, to exec the bill, or would you want to hold it a week and tinker with it?
I think the bill, talking about Bill 479,
Mhm.
I think it's ready for prime time to exec on it, based upon the testimony and also based upon the questions from the committee. I do see a challenge though with 572, and also see a challenge with 143, which I
Right,
need
so
to.
do I. And we're going to do them next week. Well, seeing that, I am opening what I hope to be an extremely brief exec session on Bill 479. And Representative Merchant, would you care to make a motion?
Thank you, Mr. Chairman. I will definitely make a motion. I make a motion to ought to pass on House Bill 479.
And would Representative
Marsh seconds.
Second it? I had a
Yes.
feeling because it's right here on my paper. Okay, so any discussion? Seeing none, I am going to ask the acting clerk to call the roll. Representative Nelson as acting clerk. Never thought you'd get to see this happen again, did you? Well, here we
Could you repeat the bill number, please?
479. Look at, he's right in there. He got right back in.
Okay, here we go. Representative Marsh,
Votes yes.
Representative Folsom,
Yes.
Representative McMahon,
Charlie?
welcome back. Representative Nelson, yes. Representative Acton,
Yes.
Representative Gay,
Yes.
Representative Cushman,
Yes.
Representative Kelsey,
Yes.
Representative King,
Yes.
Representative Colfault,
Yes.
Representative Weber,
Yes.
Representative McKay,
Oh,
Representative Snow,
Yes.
Representative Knirk,
Yes.
Representative Salloway,
Yes.
Representative Cannon, Representative
Yes.
Nutter Upton,
Yes on Cannon.
yes on Cannon,
And yes
Nutter
on
Upham.
Nutter Upham, yes.
Shapiro, Representative,
Yes.
Representative Woods,
Yes.
Representative Merchant,
Yes.
Representative going back to McMahon, Representative McKay,
Representative McKay signified by raising his thumb.
We honor his thumb.
And is doing
Representative
so
Pearson.
again.
Yes.
Okay, that's it, all but one.
So what's the
All in
time?
favor.
What's the count?
Well, I can't keep track of the count.
It's, excuse me, Mr. Chair. the
Oh, no, we're, no,
is-
you are not recognized. Representative
19,
McMahon.
19, 0.
Who's missing?
Could I ask who's missing? Because we have 21 and I think
It's-
only McMahon did
Oh,
not.
that's true, good point. I don't know, let's put it up to 20. How about that? And I'll recount.
Is that your final answer?
That's my final answer.
Okay, well done. 20-0. Anybody object, and I don't know why you would, to consent?
No.
And Representative Nelson, you may go back to being a civilian, and thank you so much for your work.
Oh, you're quite welcome.
And I may just do it again sometime when Representative Marsh can take the chair. With that, we close the hearing on 479, and we will see you all back at 1 o'clock. Look at that lunch break. I can't
I
believe
get
it.
lunch.
51 minutes.
Yeah.
Wow. I got here just in
Yeah.
time.
For lunch.
Hannah,
Good
Hannah,
timing.
McMahon, Charlie was treated as he was not there, right?
Right. He was treated as absent.
But he's there.
He's here.
Charlie, if you had been able to speak, would you have been in favor of this bill?
He's muted.
He's muted.
Well, he has to unmute.
And I should remind everyone, if you were on the executive session and your face was not showing, then you would not have.
Right.
So
I know.
And he arrived partway through. I don't think he
Oh,
was
he
here when the question
can't.
was put. And we have ended the session and
But if all of those things weren't in place, what would you have said?
It's a hypothetical question.
It is totally.
Is he there?
He's saying nothing.
He's still muted.
he's
Well,
still
I know
muted.
that.
Yes.
Well, okay, then we can all go to lunch
Must be
very
away from
quietly then.
PC.
And yeah, we're 20-0, as Representative Nelson said. Let's go to lunch, folks.
Till when?
When? Right now.
Oh,
For
well,
1 o'clock.
till when? Do we have to come back? Are we executing?
Well, you don't have to come back, but we all are coming back at 1 o'clock. We have a bill. We have someone wishing a point of personal privilege, and then we're going to exec. So it's going to be quite an ordeal. So I would make sure you have plenty of protein at lunch. 1 o'clock.
See you then.
Representative Marsh, are you still on?
Yes, I am.
Do you want to just run through for me what happened this morning?
We heard testimony on 4 bills and we had one exec, which I've recorded on the exec session bill report form, which I am completing.
Okay, we just
That was the
exec
bill we just did.
479.
Yes.
Okay, so 143, is there going to be an amendment brought in?
I was actually at the chair's meeting for much of this morning, so I can't
Oh,
answer all of the
okay.
questions.
Okay, I'll check with him later.
Yeah.
When I talk to him off screen, then I'll go get some lunch.
Representative, regular chair, you can get in touch with me, but we're going to, on 572 and 143 and 582, we have finished the hearings. We are going to be in exec session, we hope, next week, and there will be some amendments
Okay.
followed all this way across. Okay?
Great, thank you very much.
So you really didn't miss anything. You got here for the fun.
Yeah, here you go. I thought I'd let you all know that on the 24th and the 25th, if they let us out of our seats, I'm going to come find all of you so we can actually meet face to face. So don't be surprised if I am walking around with a floor plan or whatever seating plan trying to find you guys, because that's my goal for those days.
I think that's a wonderful plan.
Yeah.
Very nice.
I wonder what the rules will be for eating lunch.
No lunch.
Well,
No, the clerk has circulated.
I've
questionnaire
already
about
filled out
lunch.
my request, so.
Yeah,
For
I
one
may
day.
or may not feel comfortable eating lunch depending on what it looks like when I get there.
Did you get a request recently?
Yes.
Yeah,
Clerk
it came
sent it out
like a
on
couple days ago.
Saturday.
I got
Came
so
from
many
Paul
other
Smith.
emails about bills. I could have missed a lunch invite. Still not sure if I'm gonna go or not, but anyway.
Well, if you search under Paul Smith, that's where you'll find it, but I think you have to reply fairly soon.
Well, you
Because
could just call them.
It
Just
did
call
not
the
sound
clerk's office.
anywhere near as appetizing as the lunches we got at UNH. The last one
Really?
at
Lunches
UNH was
at
really
UNH
yummy.
were very nice.
Yeah, those were really good.
Yeah, they were nice. I went to Trader Joe's yesterday. I haven't been in there, I don't know, months and months, and I bought quick stuff for today. So had a nice lunch today.
Well,
I
I
had
didn't eat
leftovers.
my lunch at the UNH, Representative Marsh, for the same reasons that I didn't want to take the mask off, but I certainly enjoyed it on the way home.
Yeah, I broke the rules and went outside.
Hey, Jerry Canuck, did you have your PB&J today?
Yes, I had my usual peanut butter and jelly.
Yeah, there we
All
go.
right.
Very simple, quick.
Never spoils. You can eat it 3 days later and it's just as good.
Yeah, the bread's a little crunchy. I like it like that.
Do we thank George Washington Carver for our peanut butter sandwiches?
Yeah.
I hope so.
I think we should. If his birthday is in early August, I think we ought to have George Washington Carver Day and have another 3-day holiday.
I'll take that. I've got a birthday early in August, so
Yeah.
that would work
How about the
nicely.
Lucy Weber day?
I have done nothing anywhere near as important as
Well, you've never been a peanut farmer either, but.
Well, I was born on a holiday, but he's not popular anymore. So,
Who's that?
Who would that be?
Christopher Columbus.
Oh, Christopher Columbus. Oh, yeah.
Oh, we
he was
still
kind of a
like
big-
him. You know.
Yeah, I know. I mean, if you know the whole story, it's fascinating.
Well, speaking of outcasts, as one of,
I don't know if you
as one
should
of
go any
7
further,
litigants in the new lawsuit against the state, against the speaker, I think I would not be offered a lunch, even if I did attend.
Ken,
You
could
read
you
the-
say that again? Could you say that again? I missed the gist of what you said.
Well, recently, Rennie and 7 others of us filed a lawsuit against the speaker in court, looking for remote access to the sessions because we've been denied. And I can't go, and a lot of other, Susan Rogers can't go, a lot of it. I'm absolutely prohibited. I can't join any meeting larger than 10 people because of rules that have been imposed upon the place where I live.
Right, right.
So we
pretty
need to
pro-
make you your own room,
They
your
split
own
us up
room
in
of
10,
10.
in groups of 10. Can you imagine? That would be 40 different rooms.
We only need a couple of for you and the
Yeah.
other fellows who need it.
Well, you can tell that to the speaker, but
Okay.
I think
Well,
what? No, I don't think anything's going to come of it, to tell you the truth.
How big does the room have to be?
Oh, I don't think that's really, although around here, we have a huge kind of living room area where a lot of us meet in the evening for a little together time. And they're only allowed to have 10 in that whole room, and you have to be 6 feet apart and wearing masks.
Yeah.
And the fact of the matter is, we don't object because up until recently, we've all been very safe. We haven't, nobody in the independent living apartments in this unit, even though a lot of the people in the nursing home got it. But recently we've had 9 people, which is kind of that community spread thing. And so they've really nailed down on us now. And I don't resent it because I don't want to get sick again, but.
How about putting a tent up? Could you put that in Bedford, right on the grass there, set up a little tent so you'd be all by yourself?
Yeah, that would be good. No, I asked about that at one time. Is there any way I could be in a separate room down at UNH? And they said, oh, absolutely not. And I said, what if I stayed in my car and I just got a call when I can listen to the going, and then you call me and I'll walk to the doorway and vote. And they said, no, you can't do that either. So,
But
anyway.
this isn't UNH. UNH has their
No, I
own
know it
very
isn't.
persnickety rules. I surely think we can make you a room. And there must be some
well-
other people who need that room too.
No, because he would need to have remote access. The only way to hear is to be remote, and that's what's not being allowed.
Yeah.
If
If
it's
he was
remote,
in
it's
a
remote.
room
Well,
right
I'm
there,
hoping, I'll tell you what I am hoping. I just got my first shot last week and I get my second shot March 2nd. And then 14 days after that, which is the day before St. Patrick's Day, I'm through. And then I can seek permission to see if I can then join in the legislature, and I have a feeling they'll approve it. But
I think our
Not up-
chairman
that-
wants us.
Back to work.
I really was enjoying this, and particularly Representative Snow's wanting to multiply 3-day paid weekends. I just wonder if he ever worked for a municipality or anything that would give him such an idea.
well, I never actually did work for a municipality, but I've lived in a number, not a number,
Well,
small
and
number.
you're living in one now. Okay, good. All right, we're going to start the hearing,
Okay.
opening up the hearing on House Bill 492, requiring the maintenance of the COVID-19 dashboard and establishing a legislative committee to study healthcare disparities experienced by underrepresented populations during the health crisis. And we bring in to introduce her bill, Representative Schultz. The floor is yours.
Hello, Mr. Chair and HHS Committee. I'd love to be on video if that's, I saw Mary Beth earlier ask for that, but regardless, it's an honor to be here. I also was enjoying the discussion.
That's us.
She just got muted.
How can she be unmuted?
I was just chatting away. What? Can you hear me now?
Oh, we
Yep.
can.
I think I'm even going to be on video. Hey,
There you are.
There she
Yay!
is.
I was saying not only are some of my favorite human beings on this committee, but that includes some of my favorite Republicans. And if you think I'm talking about you, I am. So here we go. This topic is an interesting one. And I hope that the discussion around this bill and this topic in some way becomes a benefit. And just want to tell one quick story that gets to the root of what my intention is with this bill. I grew up in an area of the country where being aware of the sirens that the government would sound to alert us to tornado warnings, and knowing where to get your news source for those tornado warnings improved over time as I grew up. From using the basic data that was available from the National Weather Service, which is basically what the Weather Channel uses, all of that data and made it a company. Good for them. To news stations fighting over who had the best Doppler radar. And it really literally hit home, bad analogy, but when my brother's neighborhood was in the path of a bad tornado, and they of course sought safety, and it did in fact level most of his neighborhood, and miraculously his house had very little damage. Having that ability to know with the sirens and with the news sources and the National Weather Service issuing those warnings and perfecting it over time has definitely saved lives. So talking about the COVID database in this way and the dashboard in this way, that's my intention, because people are making life and death decisions based on the data, where the hot spots are, where the flare-ups are. It has hopefully saved some lives, and concerns from my constituents, probably from your constituents too, and just criticisms of various aspects of the dashboard is what led me to want to do this bill, to make sure that in no way, shape, and form is the information that is available influenced by political decisions, to make sure that it is nonpartisan, unbiased, and impartial as the Doppler radar is. I also, though, want to say for just a moment what I'm not criticizing. As the spouse of a software engineer who worked for the Department of Information Services and Admin Services, who also handled state data, I am not criticizing the staff who are doing their jobs and doing what their boss orders them to do. In no way, shape, or form, I believe for sure that those workers are doing their best to help inform the public and affect safety. Maybe my criticism is of the commissioner of HHS, possibly the governor, and concerns that my constituents have had about discrepancies in data regarding school systems, that what is on the dashboard often didn't match what was being reported from their home communities through local information sources, that there hasn't been, until more recently, enough sunlight placed on other areas, the way that the school system had its own segment of the dashboard. We should have always had as well sunshine on how is this affecting minority communities, because we've seen in other places where the data has risen more, or where the cases were more cases of COVID were happening more quickly and more severely than New Hampshire, that early data was indicating that the number of deaths and hospitalizations among African Americans and Latinos were much higher. And while technically we have a smaller population than many to most states, any way, shape, or form that it would affect our 10% of our population that are people of color, we definitely should be mindful of that. I have also, and I'm sure we will hear from staff at HHS who've done a thorough job of raising their points regarding that data. I think that's, again, I don't criticize them at all. I think that that is good information that will be helpful to make this bill better. And really, I'm not exactly sure how we get to, other than reporters' questions and things I've heard from my constituents, how can we make this nonpartisan, unbiased, and impartial? And I've made an attempt to do that with this bill. And so let me go through a couple of the details on the bill itself. So as I try to figure out where I had it open, here we go. So in the first section, it's just because there is no official, I don't believe, statute requiring any sort of COVID dashboard in the first place. I realize that has been voluntary on the executive branch's decision making, and I'm grateful. I'm sure we're all grateful for that. If we could find a way to codify this for the future and not just have section 1 specifically about COVID-19, if you perhaps as a committee would like to make this something that any pandemic would produce, I think that's also a good idea. But for now, this, obviously the text is just about COVID-19. Included UNH. I thought that might be a way to ensure that the nature of the dashboard can be impartial. Include lots more demographics. Not all of these need to be released to the press necessarily or to the public, where it would, you know, I definitely would want to be mindful of not just HIPAA laws, but privacy in general. But at the town level, have the amount of data I've listed in here is age, race, town, and eligibility. And also that vaccine information could be cross-referenced by geography, age, race, and eligibility. I'm not sure if anything you or the governor have done thus far already addresses the vaccination issue, but when I wrote this bill, I wasn't aware yet of how far that information was being made public, other than what I saw in the press conferences, which were at that point inadequate. That has improved by necessity to some degree, but there still are questions about vaccinations and where is the flow going well and not going well. I think that also is important for the public to know. So folks in any areas that have difficulties, that shining a light on it, being transparent about it, can help everyone maneuver the system and improve it. And I also include, really for the purposes of, since we've gone through not quite a year of COVID in New Hampshire, but maybe close to that, a legislative committee, since the majority of COVID decisions have happened under executive order, and you know, in conferring with the state epidemiologist, the governor and his staff, and the commissioner of HHS and her staff, I thought it might be a good idea to include a legislative committee, you know, not ignoring Gopher, but to do a review of this information. This could become something that would review how have we done under COVID, but really with at least the way it's written now, looking at underrepresented populations in the pandemic. And then more details about that committee. I know study committees are not really happening right now. I will also admit I am not an expert. This just comes out of concerns I've heard from the media at press conferences here, from news stories from Florida and New York, and just from conversations between lawmakers and the general public, my constituents included, that there have been times that the New Hampshire COVID database, for lack of a better term, has felt opportunistic. No, that's the wrong word. Has seemed to have been influenced potentially by politics or political decisions. I don't have any proof of that. This is just going, and when data seemed to be flowing more freely versus when it wasn't, somewhat in proximity to an election. I'm not raising specific allegations other than I heard concerns about that, and I did see there were times that the data lagged and it just so happened to be near an election. I am not saying for sure that someone did anything wrong, but I do know the system as it exists today, for all of the good intentions of the staff implementing the dashboard, which again I'm grateful for, are no doubt above board. But by including the legislation or the legislature and some oversight, that we can look at the COVID database and future pandemic dashboards in the same manner that we do the Doppler radar. That's my purpose. Other folks that are speaking are much better at the details and are better experts than me. I just hope that this conversation and hopefully this bill creates the scenario where, to whatever degree we as a legislature can improve this process for the health and well-being of our citizens, that we can do that. And on that note, I will take questions. I will try to answer them.
Have we lost Representative Pearson? I've been trying to make sure we actually had a host here.
Looks like he's muted. Mr.
Yeah.
Not
Chair.
anymore.
All right.
Which is why I am so understanding with all of you, my colleagues. Representative McKay, would you please unmute so we can hear your question to the representative?
Thank you very much. Am I coming through?
You're doing great. Better than I did. Thank you.
During the break, I went out and came back in again, so straightened out that little problem. But Chris, I think this is a thoughtful committee. I'm not sure. It sounds as if this committee does not gather data, but it reviews data that exists in corrections, health and human services. What I don't know is how are you going to use that data, and who is the audience for this committee?
Well, this data would be hopefully used to improve the dashboard as it continues to exist in the short term. I do think there's, again, a value to looking at this information and questions that maybe weren't completely answered by the media and by our, some concerns that our constituents have had about the discrepancies between what numbers seem to be reported in local communities on even just schools versus what was showing up on the COVID dashboard. I think it would also be helpful to have a review of some sort, which is what in part the intention was by creating a committee. So does that answer your question?
Partially, but
Would you like a follow-up, sir? Would you like to follow up?
no, I think I'd like to listen to others' questions.
Okay, thank you. Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. I'm wondering how you are thinking about dealing with the issue that, unlike tornadoes, we have conflicting interests here, one being the very real necessity for sunlight and data and information that people can use to make important decisions for themselves and their loved ones. But on the other side, we have the issue of privacy for many of our citizens. And if we're looking at a system that can be cross-referenced via age, race, and geographic location, I'm thinking about living in a small town, and the number of African Americans in my small town is very small, and I could find out an uncomfortable amount about their health if I can cross-reference according to all of these factors. So my concern is, how do you envision resolving those two issues, the one of privacy versus the access to data?
That's a great question. And I'll be honest with you that it, maybe because I'm from Concord, it didn't occur to me. But as you asked that is obviously a concern. I know I used to go to a retreat center in Springfield that would bring in African American retreat leaders. And I realized from the population that Springfield had 2 African Americans based from the last census in 2010, and we would more than double the population of African Americans in that town. So I apologize that it didn't dawn on me sooner. It would probably be a great idea then to regionalize certain rural areas based on perhaps, well, you guys probably have a better idea of how regionalization already occurs in various healthcare populations. I know whether it's from the opioid crisis to just which hospitals serve which communities. I'm not the best person to draw those boundaries, but I would be more than happy to research that and make a determination to regionalize that to some level. But I'll admit that didn't occur to me until you asked the question, and I apologize because it's a great point.
Thank you.
And Representative Shapiro, unmute and have at it.
Thank you, Mr. Chairman, and thank you, Representative Schultz. I'm assuming that the COVID dashboard currently is set up and run by Health and Human Services without the help of the university system. Is that correct?
It's my understanding that the university plays some level of a role. I will be honest that I don't know the details. Actually, I think a member of your committee might be able to answer that. I might be wrong on that. But that was my attempt to make sure that those working on the database had a level of impartiality that could possibly exist with the university system to be impartial. Anyway, I'm basically repeating things I've already said, but it's my understanding that UNH plays a role already. If I'm wrong on that, I apologize. And I know I'm going to go back to the way it's worded in here.
Representative, you may be interested to know that Tricia Tilley from DHHS is next up to speak, and
Oh,
she may be able to address a number of those things.
And her email outlining a number of things I found very helpful, and I wish I had connected with her when I was writing the bill. So that's a good point.
Well,
Follow up?
Yes.
Okay, I will wait for that information from the next speaker. I have a question about the committee, which is, while I really like the fact that it's very, well, maybe very is not the right word, but it's narrow in that it's supposed to address disparities in care and treatment during the COVID pandemic. I think that's a good thing. Do you know if there is or are going to be committees or commissions that have a more overarching effort to just evaluate our whole response to the pandemic?
I don't know the answer to that question. I will be honest that when the bill was being drafted I started working on it in October and November, this was a concern that was being raised by minority health advocates. And because of that, I wanted to include it. I believe that the executive branch has now, some time ago now, addressed and released data on some aspects of this. If I could rewrite the bill today, which we can amend it, and I'm very open to amendments, I would maybe rework this to include that as a item of study, as well as a review of what worked well and what didn't go well with our data dashboard, and where were we able to successfully keep folks safe and make good decisions for their communities or schools or businesses, and what can be improved for the next pandemic.
Representative Schultz, when I introduced a bill to a committee 3 weeks ago, I had the good liberal arts, broad, 50,000 feet up in the air, top-down looking approach, which is sort of my worldview anyway. And I suggested to the chair that since the person from one of the departments knew way more about the details than I did, could I turn my time over to that person and then perhaps come back for a little few minutes at the end? And that was
Sure.
allowed. Would you be comfortable if I asked Tricia Tilley to speak next, as long as I give you a last at bat?
I am always very eager to say when I don't know something. So please, I would love to hear from her. Go for it.
Thank you for your cooperation. And could we bring in Tricia Tilley, please?
Good afternoon, Mr. Chairman and members of the committee. For the record, my name is Patricia Tilley, and I am the Deputy Director of the Division of Public Health Services here in New Hampshire DHHS. So the department truly appreciates the concerns the sponsor brings forward, and I think what I would like to do today is seek to provide some additional information about our dashboard and the efforts that we've had to address the health disparities to supplement any of the additional testimony that you're going to hear today. Above all, we share the common goals of data transparency, sunshine, and most importantly, the improvement of health outcomes for all Granite Staters. And we agree full-heartedly that the data is critically important. So let's talk about the dashboard. So DHHS has had a COVID-19 dashboard available to the public for much of this pandemic. It's updated daily, and is actively used by the public and the media. The bill is in alignment with much of our current practice, with some notable exceptions. So first, there's a reference, as we've just been talking about, to the university system of New Hampshire. The university system currently provides us with timely data, and they are a great partner, but the website itself is not necessarily a collaboration. UNH is developing their own dashboards, and we link to them from the school's dashboard to gather information that we provide, but we partner with an existing vendor to actually do the development of the dashboards. And ultimately, the dashboard is managed solely by the Department of Health and Human Services. To some of the other points in the bill, we have not created specialized tabs for nursing homes, prisons, congregate living, but we do have a number of ways right now that individuals can track long-term care facilities. And it is possible that we could consider how we could provide other data that in ways that are useful to the public while protecting privacy. I think that is the balance that we have had throughout this entire pandemic, of being transparent and protecting privacy at the same time. And to the point around vaccine data, I think we all understand the value of tracking that data to ensure that our vaccines are delivered fairly and equitably. And currently, we provide information on Fridays as part of our daily DHHS updates. Some of the important demographic information that the bill describes, such as race and ethnicity, however, is likely to be incomplete right now, in part because of the CDC VAM system we use doesn't make that a required field. The committee has likely seen that on our COVID-19 interactive equity dashboard that has been available since we launched our interactive dashboard, and even prior to that, when we just had a static piece of data on the site, we always had some information about race and ethnicity and equity. But on these tabs right now, on the interactive equity dashboard tab, you can see that race and ethnicity is only available right now for about 61% of cases. And we've been actively working with those that submit specimens for testing to us to improve that rate. It takes a village to create the data that you see here. It takes information from the people who submit the data to make sure that that is clear and accurate. It takes the work that we have within our department and within our vendors to then turn that around and make sure that it provides the sunshine that I think we all are interested in. And to Representative Weber's point early on, we are very focused on how to protect privacy so that there can be no constructive identification, especially by race or ethnicity, as you get down to those smaller geographical regions. Throughout the pandemic, we have used the data that is available to us to build a dynamic and responsive dashboard that meets the needs of state agencies, community organizations, and the public. Creating a specific statute may run the risk of pigeonholing our limited resources, and it may require elements that we're currently unable to share. Again, thinking about things like privacy. There may be other ways, however, that we can continue to evolve what is presented so that it paints a more comprehensive picture. And I'm just going to note that Dave Wieters, who is our Director of Information Services, is also available to answer any of your technical questions about the functionality of the COVID dashboard. But let me just sum up by thinking about the Equity and Health Disparities Legislative Committee that is suggested. And I think we have similar common goals and concerns in this area for redirecting time and energy from other similar ongoing efforts. To begin, I just want to say that we know that health equity means that everyone has a fair and just opportunity to be as healthy as possible. COVID has put a spotlight on communities that have not been equitably served by our healthcare and our public health systems in the past. And the existing cracks in the foundation have really only widened. DHHS has used our data and the lived experience of our partners to focus on health equity and the disproportionate impact of COVID-19 within certain New Hampshire communities. This work has occurred not only within our COVID response team, but throughout the entire department, ensuring that we can better serve both the health and the social service needs of all New Hampshire residents. DHHS has provided leadership to the governor's COVID-19 equity response team and is actively beginning to implement many of the strategies within the governor's COVID-19 initial report and recommendations, that equity response team report and recommendations. We target specific outreach for testing and vaccine for Black and Latinx communities, including our new Americans that live right here in Concord or in Manchester and Nashua. We're committed to a 10% allocation for vaccine for disproportionately impacted populations as identified by community partners and through a database called the COVID-19 Community Vulnerability Index. The Department of Corrections has been a strong partner, and our team has worked closely with counties to investigate and mitigate transmission in county jails and nursing homes. So with regard to both the dashboard and equity strategies, we hope that any legislative efforts would support and not duplicate or redirect the department's current focus on data transparency and our focus on health disparities. DHHS is very open to suggestions and feedback for improvement. The dashboard and all of our work has been an iterative process that has evolved over time, but it's unclear right now if codifying the requirements of the dashboard in statute would actually give us the needed flexibility to be responsive as the pandemic evolves. A new legislative committee may not be necessarily duplicative of existing work, but it may have limits on the lived experience and the diversity of the makeup, of that group. It might be more impactful to create a more permanent version of the equity response team so that broader voices can maybe engaged to improve safety and reduce disparities. So I think I'll wrap up by saying we look forward to working together to achieve the common goals that we all share right now. And I'm happy to answer any questions or to defer to my friend David Wieters, who is far more the technical expert than I am. So thank you, Chair.
And thank you, Ms. Tilley. Representative Soloway.
Thank you, Mr. Chairman. Can you hear me?
We can.
Thank you so much. I'd like to direct a question to Representative Schultz. Representative Schultz, thank you so much for your efforts in this regard. Just to let you folks know that I and other members of this committee sit on the governor's task force on COVID and reopening. We hear from Ms. Tilley at every one of our meetings. We go over the dashboard at every one of our meetings. So I'm very familiar with how that dashboard operates. And it's a genuine value to those of us who are trying to make decisions. I wonder, Representative Schultz, if we look at that dashboard not as a single event, but as one of many events in which the state is attempting to grapple with epidemiologic issues, would you consider rewriting your legislation to create either a commission on information flow out of DHHS and the way it is packaged, or would you consider remanding this to the Oversight Committee on DHHS? I think there's somebody here who can speak to that committee, and ask the chairman of that committee to create a subcommittee on information flow out of DHHS. Thank you, Mr. Chairman. Thank you, Representative Schultz.
I would be interested in doing that. Yes, just to follow up on what he requested the chairman of that group to do. I would be happy to do that. I'm sorry, I walked on you, Representative Schultz. Here you go.
Mr. Chair, that is your prerogative.
Well, thank you.
To your first point, yes, I think I know enough to answer yes to that. To your second point, I don't know nearly as much about that as you do. Now that I know your level of expertise, I wish I had worked with you from the beginning. I just didn't know. I'm glad legislators are involved in this process because we should be. I'm open to amending this any way the committee feels would be of benefit.
Let me jump in again as the chair and say that since all of our work has to be done by March 11th, and what you raise are very, very good points, but require a lot of comparison to what is being done, what could be done, and so on, would it be helpful, and this is your call, that you recommend to us to hold on to this bill and retain it and work on it over the summer and the fall so that what comes out would be very much to everyone's advantage. Would that work for you? Otherwise, this has got to get done no later than March 11th.
I do know Representative Muse was going to speak. I'd hoped he was going to be a co-sponsor of this. I'd like to hear what he says about that as well. I don't have an answer at this moment. I need to think about it.
Good, just floating the idea. Representative Marsh, you're recognized to speak.
Thank you, Mr. Chairman, and thank you, Representative, for bringing this bill to our attention. My question is mostly to Patricia Tilley, because I too agree that we need to be concerned about healthcare disparities. But Patricia Tilley and I and Representative Knurk all serve on the State Health Assessment, State Health Improvement Plan Council. And it is my understanding that that council has significant resources to address healthcare disparities. And are you of the opinion that that section of this bill at least could perhaps be addressed better in that ongoing forum than in a smaller committee just for a single purpose?
Thank you, Representative Marsh, for that question. Thank you. And again, our work at the State Health Assessment and State Health Improvement Plan, what's affectionately known as SHA-SHIP, to your point, absolutely has at its heart to address those disparities throughout the state. Specifically, we have not focused on COVID-related disparities within SHA-SHIP, but it is certainly something that is within the context of that group to look at and to consider. To my earlier point, I think there are a number of different groups that are all interested in better understanding both what the health outcomes were as a result of the pandemic and how that might affect us moving forward as we think about other emergencies that might come in the future.
I thank you for that, and I thank you for all the improvements that you have made to the dashboard over the time that Representative Soloway and I have been serving on the reopening task force and the various briefings that you've given us. I think that you've given us increasingly more data as time goes by, and I truly appreciate that.
Thank you, sir.
The chair recognizes Representative Cannon.
Thank you, Mr. Chair, and thank you, Ms. Tilley, and even Christine. My question has to do with how do we identify the sources of information to be provided for the dashboard? I sit on Somersworth School Board, and we've been trying to build our plan to bring students back to school. And some of our members have acquired information from other towns and even from Somersworth. And when they take a look at the dashboard associated with the school system, it doesn't seem to be up to date with the information that's needed. Even Somersworth data was not up to date. So do we have a regular source of information in each of the towns and cities to provide this information?
Thank you very much, Representative Cannon. You're asking a really important question. And the answer is it's very complex, and there are multiple sources of data that fill each of the different components of those tabs that we see right now on the interactive dashboard. I'm going to start off and talk a little bit specifically around school, and then I will also defer to David Wieters, who's the director of our information services, who will clean up any inaccuracies that I might have. I'm not the technical expert in this space. But let me start off by simply saying in schools, one of the things that we are, I'll actually even back up even further. So one of the things people might want to know is, so how do we know what's the data source for the number of cases that we have? Well, that comes directly from the data that we have from testing. So it is a requirement in the communicable disease statutes that positive tests for COVID-19 are reported to the Department of Health and Human Services. So we receive all of those positive cases, and that's what's reported to us. And that essentially gives us that information about the number of cases that we have. And in that, there is further information. So it will give us the location of that person, their town, their residence, and some other demographic information. To my point earlier about even race and ethnicity is a required aspect of that data. And yet we all know, especially in the volume of work that we've had right now, sometimes things are incomplete when we receive it in. And so I will often use the example even about towns where people, a town may even be incomplete. As many of us live in rural areas, our mailing address may not actually be our town of residence. And so that's an area where we sometimes have some discrepancies. And with further investigation, we can clean that up. With the high volume of cases we've had, sometimes that information, we don't get to that quite in the timely way that we would hope to, as we could possibly, as we did back in the summer when we had far fewer cases. For schools in particular, this is where it gets a little bit trickier because we also need to know whether that child was in person attending school at that time. So if my child is fully remote and is not attending school in person, but is only attending school remotely, they may not show up in that school dashboard because they were not actually putting any other people in that school at risk because they were home fully remote at that time. I'm going to pause and hand it over to David Wieters and for him to provide any additional information that I might have left out.
Well, the chair would have to recognize him for that to happen, and the chair indeed does that. We recognize David Wieters.
Thank you very much. My name is David Wieters. I'm the Information Services Director for DHHS, and I appreciate the opportunity to address this legislature. Thank you, Chair, for recognizing me. So I don't really have additional information other than we are working. So one of the common concerns that we've heard regarding the schools dashboard specifically is understanding the school community versus the COVID community transmission potential at the school. And there are two different perspectives. So I have a student that goes to a school in this wonderful state, and he is a fully remote student. If he were to come down with COVID, he would not be shown up on the COVID transmission schools dashboard. However, you would see him in the community dashboard as a potential community transmission perspective. And so you still would see him there, but understanding the perspective as a parent, I was looking to see, well, he is still a student at the school, so how does he impact that student population as a community member of that school? So we are looking at expanding that dashboard to show active cases of a person that is known to be attending a school, but then is fully remote, so that you would still see the population as the student population or the school population. It could be educator or administrative staff, but for our purposes of understanding community transmission within the school, you would have that alternate filter to say who is attending or actually physically on site at a school that could put my student or educator at risk of getting COVID. So there are two different perspectives. So we certainly acknowledge the perspective of wanting to see that my child is one of many students at the Kearsarge School District, and how is he recognized amongst that? So we continuously, my purpose of this testimony is to say we get that feedback and we continuously evolve our dashboards to meet those needs. And we are working hand in hand with the superintendents within the schools as well as the nurses to continue to convey that information and evolve it. Hopefully that helps clarify the school specific, but if you have any other questions, I'm here to answer as possible.
That helps a bit. Thank you.
The chair recognizes Representative Snow. unmute yourself and address your question to one of the now 3 people.
I think my question was already answered. Thank you, Mr. Chairman.
Thank you, Representative Weber.
Thank you, Mr. Chair, and I have a couple of questions, if I may. I think the first one is for Ms. Tilley, or it just arises out of her testimony. I'm wondering, as one who wrestled mightily with VAMS, both on my own behalf and on behalf of quite a number of other people over time, how it is possible that VAMS only captures 61% of ethnicity when you cannot get the website to move unless you appropriately enter an ethnicity. And it's unclear, even to those of us who have a great deal of book learning, at least, that you had to not only highlight your ethnicity, you had to move it via not arrows, but little teeny tiny caret signs over to a blank box in order to advance the program at all. So how is it possible that only 61% of people are showing up as identifying with one ethnicity or another?
Thank you, Representative Weber. So I think I was unclear in my testimony. That 61% is actually in reference to the data that we show right now on our equity dashboard, which is around active cases. So in that case, it is the data that we receive from those who order the testing or put forward that data through us, that it may not be fully complete. So that's where that 61% number comes from. So I apologize for not being clear about that in my testimony. Regarding VAMS, and again, if with the chair's permission, David Wieters can speak a little bit more in detail about the ways in which that data may come through. And I agree, it was a complex task to do that sort of moving over of the race and ethnicity.
Very easy as soon as you knew how. May I have a follow-up, Mr. Chair?
Yes, you may.
It's actually a whole new question, but
you may have a whole new question.
Thank you. My question, I'm not sure which one of these it's for, is I notice that we report data regularly on towns, and when we get down to 1 to 4, under 5, we say 1 to 4 because we don't want to highlight too specifically who may or may not be in the spotlight in a particular town, particularly small towns. And it is a mystery to me that why is it that we can report data on the town of Roxbury, population 229, in the aggregate, of course, when we cannot, and we cannot report data in the aggregate on the 424 public servants who are members of the legislature?
Thank you for that. I'm sort of processing how I can answer that right now. I can speak to the town. Again, we are working closely on constructive identification, and you're correct. We have a process by which we do not respond. We do not provide detailed information, when the number is below 5, for lots of reasons. One, that may be an unstable number, but really in this case, it is more likely so that you cannot do that constructive identification. In general, we do not provide clustered information about particular clusters unless there is a risk to the public. So that is why I think I'll just end my statement there, and we can follow up offline for additional information.
Thank you. And thank you, Mr. Chairman. I'm all set.
Good. Anyone else in the committee for the Gang of 3? Seeing none, I call Representative David Muse, Rockingham 29.
Thank you, Mr. Chairman and members of the committee. I'm going to come at this a little bit different than the way we've heard this come at up until this point. Part of my professional background is I'm a former partner in the customer experience practice of Aon Hewitt. And one of the things that I've had experience with over the years is actually creating dashboards and applications that sit on top of complex database systems. And one of the things I think that's really important to keep in mind is that my personal expertise does not have to do with public health. I think you have members of the committee who have a huge amount of experience in that area. That is not my thing. But what I'm trained to do is I'm trained to recognize an expert system that's posing as public information. And so what I mean by that is that the tendency of people who are experts in any field is to create informational resources that are useful to them and to other people in their field. And one of the things that I think has been left behind in this process has been the fact that there are also school administrators, teachers, parents, citizens, everyday people who are concerned about this information, who are going to this dashboard and these other resources and really trying to get answers to simple questions. One that I get all the time is, how many active cases are there in Portsmouth? So I actually can't get an answer to that question on the dashboard. What I have to do is I have to kind of look underneath the graphic of the state of New Hampshire on the DHHS COVID website, and tucked in underneath there are two links. One to a PDF file that has a map of the state and all the communities with the number of active cases listed beside it. The other is an Excel file. I think I'm the only person in my community who's managed to find that so far, because I keep getting asked for it over and over and over again. And what that points out is the fact that we have one of the problems that we have with a lot of the resources on this site is a fair amount of fragmentation. So while there are critical resources that are aggregated on what we call the dashboard, there's a lot of other important information that's not included on the dashboard. And so things like cases in communities are one good example. And something that's actually from the purpose of a schools dashboard, you would think would be very important too. Another area where I'll echo Representative Schultz's observation is it can be very frustrating seeing an article in the newspaper that talks about active COVID cases in a school in your district as a state representative, and not those cases appear on the dashboard for 4 or 5 days, sometimes until 4 or 5 days later. And I understand that there are all kinds of reasons why that's happening, but the whole idea of having a dashboard is to enable people to make what the governor calls data-driven decisions. And when the data is not up to date, when it doesn't represent the true status of things like community spread in a community, then there's a question about how useful it actually is. And I'll give you an example. In the schools dashboard in particular, on about the middle of January, there were days for the city of Manchester when the dashboard was showing no active cases at all in the Manchester school system. However, we were getting information that there were a ton of active cases among children 18 and under in the city of Manchester. So the dashboard, if you were to go solely from the dashboard and you were looking at the number of cases that are accounted for in the schools, you would get the impression that COVID has ceased to exist in the Manchester school system. When the reality is that as soon as we start sending kids back to school, we're going to have cases. And that's exactly what's happened, not only in Manchester, but in a bunch of other communities. So one question is this data-driven dashboard really giving us the information that we need in order to be able to make decisions like this? Another area where I'll kind of echo what Representative Schultz has said is the information around vaccinations right now is a huge gap. Once a week, there's a vaccine allocation summary that gets appended to DHHS's daily summary. And essentially, it's one of the most cryptic things you'll ever see. I'm sure that there are members of the committee who can look at it and tell you exactly how to read it and exactly what it is. But when I look at it as a citizen, I'm wondering, so how many people in New Hampshire have actually gotten the first dose? What percentage of people have been completely vaccinated? How much vaccine that the state has received has actually been put into arms? Is it like half of it? Is it 3/4 of it? Is it almost all of it? And it's very, very, very difficult to tell that from the resources that we have. And there's also no information on vaccine equity. So the governor has decided that it's important enough to reserve 10% of the doses that are allocated in phase 1B for people who are in communities that are disproportionately affected. But we have no information about how much of that vaccine has actually gone into the arms of people in that disaffected community. So it's one thing to allocate the doses, and that's a nice thought, and it's something we absolutely should be doing. But the other part of it is do we have the data that allows us to understand whether or not that is actually happening? And right now, the data may be collected. I don't know. I don't have visibility into that. But what I do know is that when I go to the resources that the state of New Hampshire has designed, I can't find the answer to questions like that. And I think that it's really critical that we do have answers to questions like that. And with that, I'll stop. And if anyone has any questions, I'd be happy to take them.
Seeing none, Laura Condon has signed up to speak in opposition to the bill, and we will get to her as soon as I call on Representative Shapiro.
Thank you very much, Mr. Chairman, and thank you, Representative Muse. So we have a bill before us that does certain things, and then we've had a lot of testimony with various levels of critique about the job that the dashboard is doing currently. So I would ask you, given your particular critique of some of the shortcomings, what in this bill or what possibly in an amended bill would address some of those shortcomings?
Well, first of all, I want to say that I do agree with the study commission. I think that is something it's absolutely essential when we're past this to be able to look back on it and to learn from our experience and to make sure that we get that down so that when the next pandemic comes along and it's inevitable that one will, we have that information. We've done the work. It's wonderful that we were able to create a resource on the fly, and I know that there are people who are working very hard to continuously improve that resource. So one of the things that I would say is, to me, one of the most critical part of the bill is actually looking at the study commission. I have reservations about retaining the bill as a whole because hopefully everybody's going to be vaccinated, and it might be by the time that a study committee is actually able to meet, to do this. So I question whether, how much we'd be able to get accomplished. If there was one thing that I would pick to put in the dashboard that's not there now, it's much better information on vaccinations. I wish we had better information as we were dealing with the long-term care crisis in our nursing homes. 75% of the deaths in our state have occurred in nursing homes, and the information on the nursing home situation is very fragmented. And again, some information is available on the dashboard, but the weekly case updates are only done once a week in PDF form, appended to a daily summary. So the information has been kind of all over the place, and it's not easy to get a full picture of what the situation is. What I would like to see us do is I'd like to see us sort of learn from that and say, okay, how can we not repeat the mistake of not having done that earlier with long-term care, and how can we accelerate what can, at this critical point for vaccination, how can we make sure that that better information on vaccinations is available on the dashboard? That would be the number one priority I would suggest.
Thank you.
Thank you.
Mr. Chairman, you're muted.
Chair would now like to call on Laura Condon.
Good afternoon.
Good afternoon.
Oh, good, you can hear me.
I can.
Well, good afternoon, Mr. Chairman and committee members. My name is Laura Condon. I'm from Bedford. I'm a volunteer New Hampshire Director of Advocacy with the National Vaccine Information Center, and I speak today in opposition to House Bill 492. But first, I would like to say that I thank Representative Schultz for her efforts on this bill and specifically for bringing forth constituent concerns. I think that is one of the greatest services that you as state reps provide, is being our voices for those members of the community. And for that, I much appreciate your efforts. But I do know while we are currently experiencing a COVID-19 pandemic and there are emergency orders that have been issued to provide for emergency actions, this bill proposes to put certain reporting requirements into law as a permanent feature. This would not allow for modification of action and reporting as the pandemic weakens and this becomes an endemic illness more typical of influenza, for which we do not have these types of extensive reporting requirements as are proposed here. I would say that DHHS has done a good job of providing COVID-19 information and details and updating it regularly on their COVID website and being responsive to public concerns about any sort of inadequacies of that data or requests for additional information. And I think leaving that data reporting decisions to the department allows for the flexibility that is needed to report what is needed, what is useful, and when it's needed and when it's useful. There is a call for specific data here that concerns me, and I would caution against the section calling for tracking of vaccination metrics by age, race, town, and eligibility category. It's concerning for a number of reasons. In particular, would involve the collection and sorting of personal information, and there are obvious privacy and security concerns. The CDC and DHHS have already made recommendations on who might want to get a COVID vaccine. We do know there's categories A1 and B and such. Not everyone can safely get a COVID shot, and not everyone wants one. These shots are a treatment offered to minimize symptoms for those at greatest risk. They have not been shown to prevent infection or reduce the spread of infection. Treatment options are important to have. It's never one size fits all. Reporting of vaccination rates to the public broken out by various locations and demographics is not particularly useful to the public. Historically, the purposes of such collection and posting of data is to coerce individuals to submit to vaccination. These COVID injections remain in the experimental phase under emergency use authorization and are not FDA licensed, and this fact should be recognized and appreciated. Were this data to be compiled and presented, it would be important to also include some of the data on the injuries and deaths being reported and a link to the VAERS reporting system. DHHS already knows how many COVID shots have been received in the state and how many have been injected. Aggregate vaccination rates are typically published information by DHHS without a statutory requirement to do so. I don't believe that it's appropriate at this time to be permanently collecting, sorting, and reporting data to the extent that's called for in this bill. Although again, I do appreciate very much Representative Schultz, actions in bringing forth constituent concerns, but I do ask that this bill be appropriately considered for an ITL recommendation. Thank you very much for the opportunity to speak.
Would you take any questions if there are any?
Certainly, if there are.
Well, thank you for being willing. You get extra points for that.
Thank you.
You're welcome. Well, that's it, folks. And we have no one else signed up to speak. And so really the opportunity I like to give is to the bill sponsor to say, Are we ready? And when we exec it, is it good to go as it is? Do you wish to make changes? And if you do, just remember they got to be done on the fast.
Thank you, Mr. Chair. I will say I have the time and inclination to improve this bill. I think the feedback I gained from the other testimony and from the questions and comments from the committee, I think that it should be amended. Open to doing that in a way that the majority of you would like, and I will be calling many of you. I did also send an email, so if any of you would like specifically to make sure that I call you, you can reply to that email. And I just thank you for your patience. You are the experts, and saying anything more would just prolong this. And I appreciate your time.
And we'll be looking forward to what you present to us. So thank you for coming.
Thank you.
And with that, I close the hearing on Bill 592. Representative Soloway has asked the chair for a brief point of personal privilege. And so the chair calls on Representative Soloway. The chair also calls on the representative to unmute.
There. Is
Done.
that better?
Much better.
Okay. Thank you for the opportunity to speak. I'd like to speak under unanimous consent for just a few minutes. I want to put our current discussions of a number of bills in historical perspective. Over 20 years ago, there was a book published by a science writer named Laurie Garrett. That book was called The Coming Plague. And in it, Laurie Garrett, who is just a superb science journalist, reminded us that we are in the midst, at that time in the late 20th century, now in the 21st century, in the midst of not a disease, but a series of waves of disease that have assaulted us as a species for quite a long time. You can go back to the turn of the 20th century. You can go back to the Spanish flu. You can take a look at tuberculosis through the 1940s until we invented the mycins. Some of you may even be old enough to remember polio coming through New England in the 1950s. And if you think through your own lived experience and you think through the advent of HIV, HPV, the threats of SARS, sudden acute respiratory syndrome, the threat of Ebola coming, if you think through the advent of MERS, Middle East Respiratory Syndrome, and now here we are wrestling with a whole new, not a coronavirus, but a family of coronaviruses that are mutating, and they're mutating, dare I say, faster than we can develop effective vaccines to deal with them. And what is lurking on the horizon that you probably don't know about is a new virus that has shown up in Asia, Nipah virus, a new strain of avian influenza that has shown up, a renewed strain of Middle East respiratory syndrome. All of this is coming our way. So Laurie Garrett, in The Coming Plague, alerted us to the fact that we were seeing waves of virus, waves of bacteria that we probably had not seen before. Not only that, if you look out there, you may be aware that here in this country, we had an epidemic over the last couple of years of whooping cough, which we hadn't seen in decades. And You will be pleased to know that Ebola is back. We have an outbreak in the Democratic Republic of the Congo. That's new this week. So you have to see that. Now, I need to tell you that Laurie Garrett, as I mentioned, is a brilliant science writer, and she wrote a follow-up book. And the follow-up book was called Betrayal of Trust. And in it, rather than simply looking at the advent of these diseases, she looked at our public health efforts around the world to contain these diseases. And what she said was in this book, we have trusted CDC, WHO, national governments, state governments, local governments to protect human populations from these diseases, and that trust has been betrayed. We have not been successful. We have not built the systems to control the arrival of these diseases. And my friends, here we sit in the middle of a COVID pandemic. And you know that before this is over, we will have 500,000 dead from COVID or COVID-associated illness in this country. It's here, it's now. You have lived in self-quarantine for a year. And the question becomes, what do we do now? Now, I want to tell you that I mistrust government. And I know that's an odd sentiment for everybody on this committee. That's said tongue-in-cheek. I value my privacy. I value my right to make decisions about my own health. I have no use for government intervening in the relationship between patient and practitioner. I believe that that is sacred on all counts. I am a wary watcher of immunizations and public health interventions generally. If you feel that I am speaking without expertise, let me tell you that the first volume on preventive medicine ever published for healthcare professionals, called A Course Book in Healthcare Delivery, was written by me. The first volume on healthcare delivery systems for healthcare professionals, Introduction to Healthcare Systems, was written by me. 2 further volumes on epidemiology were written by me. I've been there. I understand public health. I understand how it works. So now, my friends, I have to balance my doubts and mistrusts about government intervention in my life, the lives of my constituents. I have to balance that with what I see as a looming public health threat. And I have to ask, is this a time when we need to suspend our doubts? And when we talk about permitting pharmacists to expand the numbers of health professionals to deal with health threats, when we talk about entering data into databases as to who has been vaccinated and who has not, I'm at the point where in order to make a decision on all of these, I now must fall on the side of public health intervention. It's that looming, it's that dangerous. We need to make a very considered set of decisions. And I have to suspend my fears and doubts and my protections for my own privacy and that of my constituents, my own protections for the sacredness of the practitioner-patient relationship. And I have to say, no, now is the time when we are all together and we must make our commitments to the health of the community as public health. Thank you very much for listening. I'm sorry to take so long, but it was terribly important.
Thank you, my friend. You're always worth listening to.
Thank you.
I'm going to open now an exec session on House Bill 617. That's not one of the ones that's on the list, but this should go real fast. And as you know, one of the things we try to do here is come to a good understanding. We try to get good work done. And sometimes, as I've been instructed, the way forward is not necessarily by legislation. It could be by a remonstrance to a department. So we had 617 before us about food safety training for childcare workers in communities. And I had a wonderful chat with Representative Jan Schmidt, who you'll remember presented the bill to us. And more importantly, she's had a wonderful conversation with the good folks over at DHHS. Fanfare is appropriate. And her suggestion to us is that the bill should be ITL'd. And as one who ITL'd or recommended ITL of one of my bills to this committee recently, a year or two ago, we're happy to do that. So she suggests on this bill that it is not necessary. What she wanted to have happen is happening now. And so therefore the bill is moot. If there is no discussion on that, Representative Weber.
Having also received a communication from Representative Schmidt, I would move ITL on 617, and I would, if there is a second, like to speak to my motion.
I've
Representative Marsh
actually I have already moved it and I've written the blurb and disseminated the blurb pursuant to my conversation. But if you would like to second it, Representative Weber, I'd appreciate that. Would you?
No need.
Was that yes?
I said no need. It's a little unusual for the chair to be moving the bill, but it's
Understood.
perfectly acceptable.
Thank you. Do we have a second?
Second.
All right, Representative Marsh. Now, anybody wish to discuss it further? Seeing no further discussion, then when she is ready, the clerk may call the roll.
But I also remind the members that they will have to turn their videos on in order to vote.
Turn on your video.
And up here, so.
Wait, we got.
Betty.
Gotta get Betty on. There we are.
Okay, we're all here. Okay, the motion is ITL on Bill 6 HB 617. Representative Marsh.
Votes yes.
Representative McMahon.
Yes.
Representative Nelson.
Yes.
Representative Acton.
Yes.
Representative Gay.
Yes.
Representative Cushman.
Yes.
Representative Folsom, yes. Representative Kelsey.
Yes.
Representative King.
Yes.
Representative Kofalt.
Yes.
Representative Weber.
Yes.
Representative McKay.
Yes.
Representative Snow. Representative Snow.
Yes.
Thank you. Representative Knirk.
Yes.
Representative Soloway. Representative Soloway. You need to unmute. Representative Soloway.
Yes.
Thank you. Thank you. Representative Cannon.
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro.
Yes.
Representative Woods.
Yes.
Representative Merchant.
Yes.
And Representative Pearson.
Yes.
Okay, it is 21-0.
I trust there's no objection to consent. Seeing none. In our exec session here, the next one under consideration is 604. expanding the New Hampshire Vaccine Association to include adult vaccines. And may I have a motion on the amendment first? I'm reading my notes here. Representative Knurk. Yeah, go ahead.
Thank you very much. Yes, I would like to move amendment 2021-0230H.
Do we have a second?
Second.
Representative Mackay. Okay, please speak to the amendment.
Thank you very much. Well, there's really a lot to say about the bill itself, but I'll confine myself here to the amendment. It's important to note that although no representatives of pharmacies testified at either the 2020 hearing or the 2021 hearing, sorry?
Representatives, thank you. Go ahead.
Yeah.
Go ahead,
Or
Representative.
the 2021 hearing, during this year, Representative Merchant kindly pointed out that the reimbursement to pharmacies through the pharmacy benefit manager was really not well captured enough in the bill and the amendment that I introduced in the hearing. So as a result, a few days later, Representative Merchant, Tyler Brannon of the New Hampshire Insurance Department, and I met together to craft Amendment 2021-0230H, which is identical to the amendment that I introduced at the hearing, with the exception of some new language in the amendment on page 2 from lines 17 through 35, which would protect the pharmacies by ensuring that they would be reimbursed for administering an injection at a rate similar to medical providers. We used language suggested by Tyler Brannon of the commercially reasonable value, which is available from the New Hampshire Insurance Department for every CPT code. The amendment also protects the insurers from being billed twice for a vaccine, since they've already paid for it once in the assessment. And then language was added, again at Tyler Brannon's suggestion, to provide for dispute resolution between the insurer and the provider using the same mechanism as the balanced billing statute. Subsequently, Representative Merchant informed me that the pharmacies were still not satisfied. So 8 days ago, he nicely convened a meeting of all of the stakeholders, including the pharmacies, to develop a new amendment. During this meeting, it became clear to me that the chain pharmacies really simply don't want to participate in this program. So we crafted another amendment that divided the providers into either participating or non-participating, using reimbursement ideas and language from the pharmacy representatives. And this really was a pretty big compromise with the pharmacies, as doing this actually lessens the savings of the adult program by decreasing the size of the pool, because as Representative Merchant said earlier today, the pharmacies are doing about 30% of the adult vaccines. So that final language was circulated to the parties involved that night, asking for a response within a day, but none of the pharmacy representatives responded over the next 2 days. So in the interest of time, I went ahead and submitted that amendment. And then a few days later, Representative Merchant and I had our daily telephone call, and he informed me the pharmacies were still not satisfied. And subsequently, the insurers noted some concerns that the compromise gave away too much. So I'm actually kind of bringing forth the Goldilocks amendment. The first one was a little too cold, the last one a little too hot, but Amendment 0230, for right now at least, is just right. Now, it's important to realize that Department of Health and Human Services, the New Hampshire Vaccine Association, America's Health Insurance Plans, New Futures, and I revised multiple parts of the 2020 bill over the course of the 1.5 months this fall to develop the 2021 bill. We still have 3 more months to fine-tune a new amendment, if needed, regarding pharmacy participation on this bill. That'll be as it goes through the second House committee and through the Senate before the Senate needs to act in early June. We remain open to continue to negotiate that degree in terms of the pharmacy's participation in the program as we go forward. But such negotiations do not require retaining the bill, as this is really the only issue that still needs to be resolved. And delaying it, particularly for those freshmen who may not understand this, delays its implementation for a full year, because the work's done in the summer and it doesn't even come into consideration until next January. We really should be able to achieve this final language, if necessary, before it even gets to the second committee of the House. Additional amendments are frequently brought forth to a bill as it goes through the subsequent committees. So Bottom line is, I urge you to vote to accept Amendment 023H, 023OH, and then to vote OTPA so we can move this bill on to the next committee. And again, I'll continue to work with the pharmacy to finally come up with language that they will be happy with, and which will represent significant compromises from the other parties, but which hopefully will give us at least a 70% of the loaf instead of a full loaf, if you will. Thank you very much.
Will you take questions on your amendment?
Of course.
We just got to find some. Representative Merchant.
Thank you. Thank you, Mr. Chairman. And thank you, Representative, for taking my question. In regards to looking at this, what it's requiring is for the pharmacy community to utilize a system created for the medical office community and not for the pharmacy community. I think the concern that's still there is that we're taking a square peg and put it in a round hole. It was not, so people understand, the medical community now participates in the Vaccine for Children's program. So therefore, by adding adult vaccines onto an existing program is just building on something already in existence. By taking something that is outside of normal operations for a pharmacy, regardless of the reimbursement model, it still makes it difficult and cumbersome for the pharmacy community to utilize. I looked at the Immunize Colorado, and they cited also that a major obstacle for the pharmacy community to participate in a program like this was the financial burden, but also the administrative burden. That you're going outside of a well-oiled supply chain that works very well, and then trying to have them utilize a state program. And we can look to COVID. People now looking to the pharmacy community because the system they utilize is very efficient and very effective. So regardless of the reimbursement model, the concern that's there is the system that we're going to require the pharmacy community to utilize doesn't work. It doesn't work within the pharmacy community itself. And I can tell you from personal experience, having worked with that system, the delays in getting vaccines, you cannot transfer a vaccine from one place to another. You have to report the temperature in the refrigerators, which is redundancy and so forth. I still see what I'm trying to get to, Representative Knirk. As much as I look at this amendment going in the right direction, it's not there. I did send out to the committee for their review just shortly another amendment, which we talked about, which would carve out the pharmacy community today, which is 66% of the loaf, work with the pharmacy community going forward, and then build on the rest of the, so that we can capture the full loaf. But I think without the pharmacy community buy-in and support, my concern is that throughout the country, pharmacies do not participate in state-run programs unless it's for the uninsured. So I just want to alert people that I want to say thank you, Representative Knirk, for what you're doing with the amendment. I think fundamentally, it doesn't really solve the underlying problem, and that is we have a system that was not created for pharmacy. We're asking them to utilize.
May I respond?
You may.
Fair enough. I was actually going to address some of those issues, but I thought they were more germane to the issue of passing the bill itself rather than the amendment. But I'll go ahead and address them here. First, as I noted, I had an amendment I brought forth which would carve out the pharmacists, and I have seen Representative Merchant's amendment. The difficulty with that is that it requires shifting to a retrospective assessment, and the current assessment is a prospective assessment. This program has been in place for over 15 years, working extremely well. And with that in mind, trying to completely change it over to a different system just didn't make sense. And the amendment that we came up with, that I thought the pharmacists would be happy with because they were at the table when we developed it, really gave away a lot and did allow them to be non-participating if they wished to do so. There were still some questions from the pharmacy community about some of the issues about reimbursement, which could conceivably just be simply stripped from that amendment, and they would just be able to either participate or not. And that would work with the current system far better than would the Representative Merchant's amendment, which would be, reasonable if we were starting from scratch with a new system, but not when we already have an existing system. If you will, if you wish, I could go ahead and address these other questions about the supply chain and what the pharmacist burden would be at this point in time, and perhaps I should, because it was brought up. It's important to realize that the comment that no chain drugstores, because you all got a letter from the lobbyist for the Coalition for New Hampshire Chain Drugstores, I think it was just yesterday or day before. And the problem is it reflects a lack of understanding how the program works. He said that the chain drugstores couldn't participate in a meaningful way. Well, they certainly can, and we want them to. He talked about concerns about how the state stores and distributes vaccines, but that's not a real concern. The state does not store the vaccines. The vaccines are shipped directly to the provider from McKesson, who's the federal distributor, and it is not at all like the trouble-plagued COVID vaccine supply chain. It is an entirely different issue. The current system really works exceptionally well. The small practice that I worked in Conway, as I spoke to one of our pediatricians about this, they have been extremely happy with the program. They have never, ever had a problem with supply chain problems. The comment was made in that letter and also by Representative Merchant that chain drugstores aren't doing the, for example, in this state, the Vaccines for Children program. But that's not really surprising because the pharmacies are not allowed to vaccinate children in New Hampshire except for flu. So they wouldn't be able to participate in it, even if they chose to, at least at this point in time. As far as the burdensome requirements for storage of federally supplied vaccines, it's important to realize that those CDC requirements are actually just simply best practices to assure safe storage of vaccines so that they're safe to use and they're effective when they're given. Because poor storage can lead to either complete loss of thousands of dollars of vaccines or a loss of potency of vaccines, which could then be unknowingly still be injected. I would say that if the pharmacies aren't following those best practices, they maybe should. And I would also again note that the small practice I worked in Conway with only 2 pediatricians handles it just fine. They don't have any trouble. So the other thing was about moving vaccines from one place to another. Though that can be done, I confirmed that with Dr. Beth Daly, Chief of Infectious Disease Bureau. They're the ones that administer this program. She stated that in the current program, providers can transfer vaccines as long as they document the transfer. So the point is, I do appreciate that we have not reached a final conclusion. I mean, that's obvious, guys. Everybody knows that because Rep. Merchant and I are talking about this, and we clearly aren't agreeing. But this is not a burden which should take this bill and require it to either die or be retained and go through some process this summer and be delayed by a whole year. We can accept this amendment. As I said, I did a lot of rewrite on this in the fall over a month and a half, multiple meetings with stakeholders, and we can do probably in the next 2 weeks, because I think Rep. Merchant and I have really at this point pretty well identified some of the issues. And I think we can fine tune a couple of issues now and have an amendment before it even gets to the second committee that we probably would agree on. Again, I know that New Hampshire Vaccine Association, New Futures, DHHS, they really don't want to have this program diluted and have it with only 66% of participation, but everybody has to make compromises, and they may need to compromise on that to satisfy the desires of the pharmacy community to just keep running theirs separately and doing their own negotiations. And I certainly am comfortable with making those kinds of compromises. But today, if we decide not to, approve this, it just either dies or gets retained and then has to sit around for another whole year. As Charlie McMahon likes to say, we need to get this done while we're still young. We can get this out of our committee, get it to the next committee where they can, where Rep. Merchant and I will continue to work with those other stakeholders and get some final language. And if we never can get there, it'll get retained or ITL'd in the next committee or in the Senate. And, Gary, I want to keep working with you. We are still friends, and we talk every day usually.
If I can say, I want to say this to everyone here. I want to recognize the work that the sponsors put into this bill, and I'm not trying to
to make it difficult for him or anyone else. But I also, at the same time, if I know something's got a flaw in it, and I let it go forward without dealing with that flaw, then my concern is we have the potential to create legislation that we could possibly cause a lot of issues in the settings for access to vaccines. We just talked about how important the access point is. Just to give you a heads up, I talked to a board member in the state of Vermont, because Vermont also has an adult program. Not one pharmacy, folks, participates in the program for children or for the adult program. Number two, I looked at Alaska. I looked at all the registered providers they have on Alaska on the website. You can go there and I'll send it to you. There's not one pharmacy, folks, that's in it. So I'm just cautioning people is that the pharmacy community is a very major component of access to vaccines. And there's got to be a reason in the other states that pharmacies have not participated in the program. Number two, as far as looking at things retrospectively versus prospectively, we could break it apart and saying if it's a children, it's done under the current model. But this is a new opportunity for adults and saying, going forward to the Department of Health and Human Services, we build a different model for the adults. So therefore, the insurance companies are basically utilizing two different systems in order to accommodate that. And I think what I'm saying to my friend on my own side of the aisle is that I don't want to work with you, but I just think that this bill is not ready for prime time. And I think to move it forward, even out of the committee, until we have buy-in from the pharmacy community and deal with their concerns, which I think are significant, it's not a logical thing to do. So I would vote to retain the bill versus to pass the amendment, but I will pass the amendment because it's better than what the bill has, but I would definitely vote against the bill.
Representative Snow. You were unmuted. Now you muted yourself.
Oh, my buttons don't work right
I know
in a lot
that.
of ways.
It comes with age.
Thank you.
You're
If I could
welcome.
ask one of the two of you, probably Representative Knirk would be the best one to ask. He's basically saying that he agrees the bill right now is not ready for prime time, but he thinks he can work on it while it goes through another committee. And at that point, we can still vote to retain it if it's not ready. But at this point, I say we ought to move it along and pass it, because one of the things, if we can get it through this year, that saves the state $4 million, which we're going to lose if we delay it until next year. So I would ask that we do what we can to move it along, at least at this point, and commit ourselves to try to work out a compromise that meets everybody's needs. Thank you. Am I correct in that assumption?
Could I have a point of order, Mr. Chairman?
Yes, you can.
Thank you. It is correct that if we move it forward, the bill.
You muted yourself.
Oh, sorry.
Those buttons are tricky.
I'm sorry.
They are.
I'm
correct.
conscious of having intruded a dog into the frame and then said a word into an unmuted microphone earlier,
that
for which I
bothers us.
apologize to the entire committee. And so I'm trying to err on the other side. My point of order was that, yes, if it is moved on to another committee, it can then be retained, but it will not be retained by the Health and Human Services Committee.
That's
It will
correct.
be retained by the Finance Committee. And if you think that the Finance Committee is going to devote itself to the finer points that we're talking about here, you probably really ought to think again. I have a great regard for them, but that's not their forte.
Would this Representative Weber go to Finance or Finance Division 3?
It would undoubtedly go to Division 3 because everything in finance goes to a division. I simply asked the clerk where it was going in hopes that it would go to Commerce, which might have been a much more helpful place for it to go on issues of both insurance payments and business models, because that's what Commerce does. It does not have a huge amount of health content of the sort that this committee deals with, but that is water that's gone both under the bridge and over the dam. I'm going to say that I have listened very carefully to both of my esteemed colleagues, and I esteem both of them very much. But I've also done a great deal of negotiation and mediation in my life. And I think the likelihood that this is going to get resolved in the next 2 weeks is very, very slim. That's just my observation. And it is a concern of mine. And I am conscious of a growing concern arising out of the concerns of New Futures about a number of the pharmacy bills, all of which are interrelated in interesting ways.
Yeah.
But I'm becoming more concerned about the interrelation and getting it right. So that's as far as I've gone in my thinking so far, and what I'm going to do about it is another question. But
in your experience,
and that was beyond a point of order, and I'm sorry for having exceeded what I was recognized for. But
we're going to ask soon anyway. In your experience, Representative Weber, when things come out of the House and go over to the Senate, there would be another chance to amend this. Then, of course, it would have to go to a committee of conference. But we're not done when it leaves the House. Is that correct?
That is absolutely correct. I will also offer my observation that the Senate often does not go into the depth that House committees do because they don't have the time and the energy, and that they are far more receptive, depending on the issue, on the input of lobbyists than on the input of, say, a broad coalition of expertise.
Who else would like to speak? Remember, this is an exec session. It doesn't have to end in a question, but it could. Representative Knurk.
Only if no one else. Okay, then I will. There was just, actually, I do have a question. And that is, after it, if it does pass through here, and it gets through the House, could it be vacated to go to from finance and go to commerce? That's the question. The other one is just a point, and that's the pharmacies, even under the amendment 0230, pharmacies can still choose not to participate in the current program. It's not mandatory, but nearly everyone participates because it works so well. And so a pharmacy still doesn't have to participate, even under this bill and the amendment as it is sitting there. So they could choose to all say, we don't want to play. But I would also say, I vowed that I would not say, oh, gee, got it through. I would continue to work with Rep. Merchant until we really got something that satisfied everybody and where everybody gave a little bit. And I think that well, I guess I'm more optimistic than Representative Weber. I think we're so close, and I can already see a couple of the solutions of just simply removing all the language about the reimbursements that is in the other amendment, which I didn't burden you all with because it was too much, and just allow the participating and the non-participating and be totally silent on the rest and just let those market forces of the PBMs and the pharmacies manage that. And I think that was really where the pharmacies still had their concern. And then it achieves just what Representative Merchant wanted, and that is that they don't have to participate. They aren't affected. And so I think
let's ask him.
I know my other people that are working with on the other side are not going to be happy with me for saying that because they're going to be giving up a lot, but that's the nature of compromise. And so I'd vow to work on that. I would not let it drop.
Representative Merchant, would you care to respond if you wish?
Yes.
Could I just address the referral issue first?
Sure.
Yeah, go ahead.
It can't be referred to a third committee because we have deadlines.
Oh, I didn't mean third. I meant in place of.
I don't think that there is
that's fine.
way to do that at this point.
Okay.
Representative Merchant.
Thank you, Mr. Chairman. In regards to the pharmacy, they can voluntarily participate or not participate. The challenge, though, if they do, part of the reason why we're trying to use the state program is the state can buy the vaccine for 30 to 40% below the fair market value. So if we do that for a pharmacy, what we're asking them to do is to submit a claim to the insurance company at 30 to 40% below the cost. So I go back to the same thing, is that why would a business bill into the business model something that's going to bill out at 30 to 40% of what they could buy it at and take a loss on the vaccine and then only have, if you will, the administrative fee? Again, one of the things, not to conflate things, but it's part of it, at least in a provider's office, a provider can bill for an office visit. A pharmacy cannot. So it's not just a reimbursement model, that's part of it, but it's also the burdensome. So we're asking them to increase their potentially cost of doing business while we decrease their revenue stream coming in to offset and maintain a business model. My concern fundamentally is the pharmacy community really wants to work to make this thing happen. We just need to sit down around the table with all of us and figure out how to make it happen. And I look at other states throughout the country that have not embraced this, and the pharmacy community is not part of it. And my concern to this committee is that if we lose the pharmacy community, which is a possibility, without getting their buy-in and support, then we're taking dollars and saving dollars, but we're taking access points that patients have utilized it conveniently and so forth. So it's a trade-off in saying we can save a lot of money, but then if we don't have higher vaccination rates, and we're trying to do everything in our state to increase vaccination rates, not decrease vaccination rates. We know that they're low. We need to find more ways to get vaccines into patients' arms for all the reasons that you do it, and not finding ways to just save money. So we have to balance the issue of trying to save money with access and be ensure that patients at the end of the day do in fact get the vaccines that they need, not just to save money.
Representative Knurk.
Yeah, I think, first off, the issue is that if we say, hey, you can either participate or not, if, first of all, the pharmacies may have very good, cheap supply chains too, and if they can buy the vaccine at a cheaper rate, they're still going to negotiate with the insurance company for the rate they're going to get paid. That's their business, just like they do now. But the thing is, if they can't get that, they might choose to use the state program. It's like any other business decision. You weigh not just your costs, but your convenience. You may say, gosh, I can get it on Amazon $2 cheaper than the store down the street, but I can go down the store down the street this afternoon and it's in my hand. And you make that decision that value to you is worth paying that extra couple of bucks. Here, because it drives traffic into the store and there are other things, they may say, yeah, I lose $1 or $2 on it, but it's on a particular vaccine, but I want to do that because it helps me in my bottom line. That's a choice you make, and they can. The goal of what I was getting at was it would be a choice. It'd be their choice, and so I'd be comfortable with that. It is interesting to note, though, the comment about increasing vaccine rates. It is. I get my flu shots at the pharmacy because I do like it. I do like the accessibility. I can do it when I'm getting groceries. It's kind of nice. But it's interesting. I went back and dug up the data on the adult flu shots because that's about the only thing we have where we have old enough data to see what the trends are. And in the period, the 3 years prior to us allowing pharmacists to do vaccines for flu for adults, the percentage of adults 18 and older getting flu vaccine in New Hampshire was 42%. I didn't count the year of transition because that'll be fluky. But in the 8 years following allowing pharmacists to do it, it was 44%, with a variation between 38% and 49%, which means that we didn't actually see an increased rate of vaccination in the state. We just saw a different point of service. Now, again, that doesn't discount that. I get mine there. I think it is a convenience thing, and I would agree with it. Again, what I get back to is if we change it to the amendment I didn't bring forward because the pharmacist didn't like it, but I think we could work on that and get rid of that other language so they have total flexibility, the same they have now in terms of negotiating with the PBMs and the insurers. I mean, between the PBMs and insurers. If we did that, they've got just what they have right now. We would not change anything for them. But if a small independent pharmacy, if they wish to participate, they could hop in and participate. If they didn't wish to, they wouldn't. We could also go to just say no pharmacies, but it wouldn't give the independents a choice to participate because they haven't got that same large supply chain as CVS might have. Again, these are not compromises I wanted to make on this because we wanted to keep the program big and robust. But if we have to, I would be willing to do that, knowing that the people I've been working with will be unhappy with me, but knowing that it's something which is the art of compromise. So again, since I think we're so close with just that little bit of a language thing, because that was the major glitch, again, answer to Representative Merchant, it isn't, I agree, it's not just reimbursement, but they have the perfect choice to either participate or not. They can keep things exactly as they currently are by being non-participating and the amendment, a new amendment being mute on the question of reimbursement. Just letting it say.
Representative Knurk.
Yes, sir.
If pharmacist people representatives were willing, would you do some all-nighters on this? Because it's got to get out the door on March 11th at the latest from Finance 3.
Oh, yeah. Well, I mean, as I said, we met a week ago, well, 8 days ago. I thought we had reached a conclusion because on the phone, on the call, the language I adopted, a lot of it came from Ann Fellows, who was one of the pharmacy representatives for one of the chains. And I thought that we had something we agreed on. Unfortunately, nobody got back to me. And so I submitted that amendment as it was. And then I got information that people were still unhappy with it. If we can negotiate in good faith where we just communicate back and forth, we can get that done. And I think we really can. I guess I'm a big optimist. I'm sorry, but I'm an optimist. It's the only way to survive as a spine surgeon. You got to be an optimist,
Representative Merchant, I was about to ask Representative Soloway what Solomon would do in a case like this. Or to quote somebody on a cop show, ladies, you're both pretty. I love you both. Representative Merchant, do you think that you, with some representatives, could do an intensive work with Representative Knurk? And if at the end, you can always say to Finance Division 3, kill this sucker.
Right.
Do you think you could deliver some folks to this meeting?
Let me ask this question, Mr. Chairman. When I look at the calendar, what are we looking at?
Out the door today from this committee, over to Finance Division 3, out their door no later than March 11th.
I concern myself with it going to finance and working on it there because the people in finance don't have the expertise and the knowledge. So I'm really kind of reluctant to let it go out of the committee. This committee really is the one.
Well, it's going out of the committee. It will be going out of the committee no matter how it goes out,
right? Unless
we kill it.
I don't want to kill the bill. I'd rather retain the bill and let us work on the bill and get all the parties around the table. I think one of the things we talked about before is the offer on the table to carve out pharmacies, at least temporarily for a year, while we build on certain things, was a fair thing to accomplish. And at that point in time, what I heard from Representative Knurk in his conversation with the vaccine program, that was not acceptable to them. So
no, actually, may I clarify? No, actually not true, because it's going to be 2 years before this program would be stood up anyway. There's going to be a lot of preliminary work. There's working rules to begin with, but we could even have time probably for another statutory bite at it next year. But I don't really think we would need that. I think the bottom line is, Gary and I could, we did work on it that Monday. We did have all the stakeholders. I mean, we don't need to process it in the committee as much as Gary and I got to get to work and really get to work with these stakeholders and just get to the point where everybody can shake their hand and we don't do that in COVID anymore, shake their head on Zoom and say, okay, we're good to go. And then again, if we can't, we just have to say, okay, this is no good and not let it go. I don't, if we retain it, it's not the end of the world. It's just, again, we lost $4 million last year because it died a COVID death over in the Senate because we passed it out of the House. If we delay it again, we lose another $4 million. We got all excited in that recent thing where we're going to get $3.3 million over 5 years in that settlement about the opioid stuff. Well, this is $4 million a year. That's not chicken feed, and I'd like to just get this bill going. I think we can get it. I personally do.
All right. I would like to say that unless anybody really feels an existential need to speak, we have the topic here. Either we vote the amendment in the bill up and over to Finance 3, or we don't. And if we don't, then I believe we can look at another motion. And I would really, unless anybody can convince me, I would like to call the question.
Yes.
And the question actually is on the amendment.
Yes.
Made by Knurk and seconded by McKay for amendment 0230H. And would the clerk please call the roll? And it is to accept the amendment. So a yes means accept the amendment, a no means we don't.
Okay, if everybody could unmute, that would be great. Representative Marsh.
On the amendment?
One second, please. We need to see Representative McMahon's face.
Yes, sorry.
It's okay. We're learning. We're all learning. We'll get it down and then we can all meet in person.
Thank you. And unmute, please.
Unmute, everybody. And Representative
apologies.
Kofalt and
Thank you.
Cushman.
I've got them all.
Unmute and Mackay and Shapiro and Nikki Kelsey, and we're good.
Okay. Okay.
Go.
Representative Marsh.
On the amendment, I
On the
vote
amendment.
yes.
Yes.
Representative McMahon.
Yes, on the amendment.
Representative Nelson.
Yes.
Representative Acton.
Yes.
Representative Gay.
Yes.
Representative Cushman.
Yes.
Representative Folsom, yes. Representative Kelsey.
On the amendment, yes.
Representative King.
Amendment, yes.
Representative Kofalt.
No.
Representative Weber.
Yes.
Representative McKay.
Yes.
Representative Snow.
Yes.
Representative Knurk.
Yes.
Representative Soloway.
Yes.
Representative Cannon.
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro.
Yes.
Representative Woods.
Yes.
Representative Merchant.
Yes, on the amendment.
And Representative Pearson.
Yes.
And that is a 20-1 vote to accept the amendment.
And now I need a motion, and the courtesy is to the sponsor of the bill for 604 FN as amended. Representative Knurk, you have a motion.
Yes, I would like to please move H ought to pass with amendment, sorry, HB 604 ought to pass with amendment 2021-0230H.
Do we have a second?
Second.
And Mackay second. Okay, now we can discuss, but please let's not make it terribly long.
May I speak to the motion?
You may
Yes.
speak to the motion, yes.
Yes.
And then
And
Representative
much of
Shapiro.
what I was going to say, I've already said because I kind of moved it
You
over
said
to
it,
our
right.
discussion of the amendment. So I just want to remind, the goal of this bill then is really to expand our currently successful pediatric vaccine bulk purchasing program to the adult population. The bill enables the insurers to band together so that they can bulk purchase the adult vaccines. The only reason the DHHS has to get involved is to allow the insurers to access the very low cost federally discounted rate through the CDC, as that's only available to governmental units. To remind you, the pediatric program has worked well for over 15 years, allowing us to purchase annually $38 million of vaccines for $28 million for a savings of $10 million annually. And the study by New Hampshire Insurance Department about the extension just for the adults showed that the expansion to adults will save an additional $4 million over the claims paid costs of vaccines for that group. In addition to saving money, it will help finance vaccines to the uninsured. Now, the extension to this program is actually revenue neutral. When you look at the fiscal note, it looks like it's going to cost $366,000. But it's revenue neutral because all those administrative costs are recovered dollar for dollar in the assessment on the insurers to fully cover the cost of the program. The overall bill itself is actually revenue positive for the state because as part of getting the insurers to come on board for this, they have agreed to absorb the assessment for the administrative costs for the pediatric program, which were left out in the pediatric bill, and that's about $500,000 a year. So what we end up getting is a savings to the state's budget of $500,000 a year because those DHH costs get absorbed by the insurers. And in so doing, we get the $4 million of savings on the vaccines. Now, the important thing you realize is the insurers don't get to pocket that money. It doesn't go to their bottom line because insurers are required by the medical loss ratio calculations to continue to spend a certain percentage of their premiums on medical care. The reduction in vaccine costs, which are medical costs, will lead to either premium reductions, which is of course never likely, or more likely lower premium increases in the future in order to maintain that medical loss ratio. And I do need, before voting, to clarify a few non-factual statements that came up in the hearing and subsequent. There was confusion during the testimony on the bill regarding the savings calculated by the New Hampshire Insurance Department. A statement was made that that was a comparison between the list price and the federal discount rate. That is not true. I sent it out to you again so you could look at it, and Tyler Brandon sent it to you as well. It's the difference between the actual claims paid by the insurance companies. In other words, it's already their discounted rate, and the federally discounted rate. So the $4 million are real savings. And to remember, this bill does not mandate vaccines. It has nothing to do with the decision to vaccinate. That's between the patient and provider. It's only about paying. We already talked about some of those inaccuracies from the letter that we got a day or two ago. And so I'm just kind of scanning down what I made a list of things. I think I covered most all of those. Yes, I did cover all those. Again, basically we can move the vaccines as needed to handle shortages. The requirements for storage are the state of the art. And again, if we do decide to move on, first of all, it's already voluntary according to the amendment we just passed. But if we want to make it even clearer and cleaner that the pharmacists are carved out, we can do that and still keep the retrospective assessment. And I would be happy to continue to work on that. So again, bottom line, we lost $4 million last year due to COVID killing the bill. If we retain it, we lose another $4 million. Obviously, if we ITL it, we lose $4 million in perpetuity. In any case, but the DHHS, NHVA, American Health Insurance Plans, New Futures, and I will solidly commit that we will continue to work with Representative Merchant and the other pharmacists to negotiate the degree in terms of the pharmacy's participation as we go in the other committees. And I really do believe we'll reach an agreement. I guess I'm a Pollyanna. And because we often bring forth amendments to bills as it goes through subsequent committees, that's not an unusual thing. And again, there's plenty of time because this would not even be operational until 2023 with rulemaking and even more statutory work if need to. So I just urge you to vote this bill, OTPA, to move it out to the second committee while we continue to fine tune the language and make that progress toward annually saving $4 million for insurers and $500,000 for the state, rather than delay for another year. We really have plenty of time.
Thank you, Representative Knurk. The chair calls on Representative Shapiro.
Thank you, Mr. Chairman. I don't have much to say, but I will say that for so many years, I've heard so many of us talk about our frustration with lowering healthcare costs relative to the effectiveness of our healthcare system. And people blame each other, and people have different ideological points of view, but nevertheless, it seems intractable, endless frustration about healthcare costs. And I would say that after this afternoon, I understand why. So I am going to cast my vote to save a few dollars in healthcare costs and put my faith in the optimism of Representative Knurk that an agreement can be reached and this can actually happen and we can save $2 to $4 million in this next year.
Thank you. Representative Folsom.
Yes, just a clarification. I did not get who was the second on the amendment.
McKay.
And I just want to...
Actually, it's Mackay, but it's McKay. Yeah.
Yeah, I know who you're talking about. And I did not have a second on the amendment. I know Representative Knurk made the motion, but I don't remember hearing a second.
Also Mackay.
It was also, okay. Thank you very much.
Plus, Jerry, we know where you live. And if you are not doing full, complete due diligence to help, we're coming for you, brother.
No problem.
I know
I
that.
you know, sir, as I say, Gary and I, we've been friends for 4 years. We will work on this, and I know I will make some of the people on the
Yes,
that
you
I on
will.
the other side unhappy because I want to make this come to fruition, even if we only get 66%.
Yes, you will. Representative Merchant.
Thank you, Mr. Chairman. In regards to the amendment, it does go in the right direction, although it doesn't get to where things I think have to get to. I would say this. I've heard from PBMs time and time again how much money they're saving the healthcare industry. I have yet to see my premiums on my drug benefit go down, no matter how much money they get back from manufacturers and rebates. So if you think I'm a little bit jaded and pessimistic about not being quite as optimistic as my colleague, that's where I am, because in this industry, everyone talks about how they're going to bring down the cost of healthcare. I have yet to see it happen. So that's part of my concern. Number two, this bill doesn't take into effect until 2023. So therefore, if you delay it a year on retaining it, we haven't really delayed it. So we could work on this bill over the time, still have it effective date on 2023 without losing any steam on the dollars we're trying to save. That's there. And if I know the pharmacy community has grave concerns about this bill, and they have become a major player in giving vaccinations to patients, would I then hit the big yellow caution button, put my foot on the brake and take my foot off the gas and give the parties a fair time and not work under the gun to work and hammer out something that's works for everybody in a reasonable period of time, and not trying to do it under the pressure we're all under today and make something work. So my recommendation to the committee is to not vote for the bill, even though it's been amended, and again, go back and to retain it and let the parties come together in a reasonable period of time, logically and thoughtfully, figure out how to make this thing work.
May I just make a clarification? Just because it's a point of information issue about that.
It's got to be really brief.
It is. The effective date is actually when it's
22.
passed. No, it's upon passage. The reason for that is that allows them to start the setup. If the act takes effect upon passage, the idea is that allows them to start setting it up. The bill was 2022. The amendment makes it upon passage. That was modeled after how things went, for example, with the therapeutic cannabis program. We passed that in 2013, but it was not until 2016 that all the pieces were in place. This requires a number of things that have to be done in a stepwise sequential fashion. So with the drafting attorney, we said effective immediately, which enables DHHS and NHVA to start their work. But the issue is that they have to first enroll people. That's the DHHS part. Then the NHVA has to make the assessment, which occurs in the spring. They gather it up by June. Then they pay it off to DHHS, who then goes to purchase the vaccines, which are for the next year. So the reason I keep saying 2023 is that's not the effective date. It's simply that's how long it will take if we pass it in 2021 before the program is functional. So if we do retain it, it will move it back to 2024. So it really will move it a year. So sorry about that, but I wanted to be clear that where those numbers come from.
Representative Knurk and Representative Merchant. One will write the positive blurb, one will write the negative blurb. Who is going to be whom? We will see in a few minutes. But first, we call on Representative March.
Thank you, everybody. I have to say that I have found this debate confusing. It is not clear to me whether we're going to actually save money for patients in the state of New Hampshire. It is not clear to me whether we may save the department money and then offset that with higher health insurance costs. It is distinctly unclear, but I can say one thing for certain. I'm not in the habit of voting bills out of this committee until we feel like we have a good bill. We have a reputation for passing really good bills out of this committee. And at this point in time, I'm afraid that I am not convinced that we're handing a good product to the next committee. And I don't want to basically expect them to fix our problems for us.
Representative Merchant, you have your hand up.
I didn't lower it from the last time. Sorry.
Okay. Hey, now this is the moment we've all been waiting for. And the motion is ought to pass with the amendment that we've cited. And Representative Knirk and Representative McKay or Mackay. And the clerk, when she's ready, please call the roll.
Okay. Motion to pass as amended 604. Representative Marsh,
Votes no.
Representative McMahon,
No.
Representative Nelson,
No.
Representative Acton,
No.
Representative Gay,
No.
Representative Cushman,
No.
Representative Folsom, no. Representative Kelsey,
No.
Representative King,
No.
Representative Kofalt,
No.
Representative Weber,
No.
Representative McKay,
Yes.
Representative Snow,
Unmute and vote, please, Representative Snow.
It doesn't work. Yes, sorry.
Representative Knirk,
Yes.
Representative Soloway, Representative Soloway,
He is out of the room.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Merchant,
No.
Representative Pearson,
I love you both, but no.
and I do not see Representative Soloway coming back. He'll be absent.
And they have to be in the room when the question was put, so
Mhm.
they can't come in halfway through.
Cannot.
Okay, thank you. Okay. It is 13 noes, 7 yeses, and 1 absent. So it does not pass.
Representative Weber, please hope the current chair, who's still learning his job, is a subsequent motion in order at this point?
A subsequent motion is necessary at this point because we have not resolved anything.
Yeah. Can I make a motion, Mr. Chairman?
Yes, you may.
May I motion to retain the bill?
May I
Do we have
second
a
it?
second? Yes,
May
my
I?
my friend. Yes, you
Because
may.
we're going to be working hard together this summer.
That is going to be, that's just.
Jerry, I know where you live.
That's okay, man. And I know where you live too.
I
So we'll
think
be working
that's,
on Zoom over the summer.
I think so.
and there's 19 people who are going to hold you to it.
Yes.
I hope there's no more discussion.
Hey, Miss Representative Soloway is still not here.
No,
Is
he's-
Representative Nelson present? Oh, there he is. Okay.
Yeah.
Sorry, I couldn't see you. Okay. This is, shall 604 as FN as amended be retained? Representative Marsh,
Votes yes.
Representative McMahon,
Yes.
Representative Nelson,
Yes.
Representative Acton,
Yes.
Representative Gay,
Yes.
Representative Cushman,
Yes.
Representative Folsom, yes. Representative Kelsey,
Yes.
Representative King,
Yes.
Representative Kofalt,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Snow,
Yes.
Representative Knirk,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Merchant,
Yes.
Representative Pearson.
Yes.
Okay, that is 20-0 and 1 absent.
Consent.
It's not on the calendar.
It's not on the calendar.
No, not on the calendar.
Now-
it's on Gary and Jerry's calendar.
Yes.
Okay, sorry.
Now, before we move on to something that is going to be totally non-controversial, that being the protective order for adults, I demand we take a 10-minute break.
Yes.
Thank you.
There was still a lot. Investigators never found the murder weapon and couldn't even positively identify photos as the driver of the Tacoma in the surveillance footage. But they believe they had enough circumstances.
Hi, Jim, it's Lucy. Could you just give me a quick call? I'm trying to get hold of you before we go back into session. It's nothing major. I just want to clarify something. Thanks.
Representative Weber, I just want to let you know your microphone is on.
Thank you. I appreciate it.
Hi, you just called me and I missed the call.
It was an accident. I'm terribly sorry. I was actually trying to get hold of Jim and I was fired. I'm apparently having all kinds of difficulties with technology today.
You have a friend here on that one and other things too.
Well, thank you very much and I appreciate you returning the call.
You're welcome.
Sorry. Bye-bye.
Bye. Mark Pearson here. I just want to double check it on 246, which is what we're doing next. You're down to move ITL?
Yes.
Okay, good. Just wanted to check. Thank you.
And I will remind the chairman, as somebody
Yes.
just reminded me, that he is also unmuted.
He's unmuted.
Yeah. Yeah, watch what you say because we can hear you.
Yes. I don't think he can hear us because he doesn't have his headsets on.
Yeah, exactly.
Um,
Mark, you're up. Nope, he's not hearing. Yes. Yeah, Mark, you're unmuted.
No.
Just so you know that we're hearing everything you say.
Well,
so.
I was about to say some things about you, and so thank you for that. I do appreciate that. I'm having a
Feel
bad...
free, my friend. Just because we aren't next to each other, we can't hug each other. Okay, tough noogies. No elbows either.
I know.
I guess you don't miss sitting next to me anymore, Jerry.
Oh, yes, I do, because we had a hell of a good time.
That was
we always got in trouble with Frank.
You know, when I was in radio, one of the first things they banged into our head is every mic is a live mic. And every one of my teachers had some horror stories as to how they learned that one the hard way. While we are waiting to 3:30 hour to arrive, we will be meeting next Tuesday, not Monday, next Tuesday. And I should have sent you a list of the bills we will be having hearings on and some of the ones I hope we might be able to exec. So that's next Tuesday. It's going to be a busy week. Tuesday for us, and then Wednesday, Thursday for the entire house. But we're up to it, so there it is. All right, it is now not quite. I promised 3:30.
Well, Mark, that's why they pay us the big bucks so we can get all this stuff done.
Yeah.
No, Tuesday, Wednesday, Thursday is a normal week.
Exactly.
Yes, you newbies.
Although we normally start at 10 rather than 9, but that is a normal week. We usually have either 2 committee days and 1 session day, or 2 session days and 1 committee day, depending on how close we are to a deadline. So it's not unimaginable. It's the other Zooms that all of us have endlessly that then make our weeks seem far longer. And the other thing that I notice is that we used to have an actual rhythm to the week, because you did here exec on Tuesday, reports on Wednesday, scheduling on Wednesday, session on Thursday, and repeat next week. Now there really isn't any rhythm to anything. We just have Zoom meetings all the time. So I find that infinitely more exhausting. And
So do
I
I can't
very
plan.
much appreciate the kindness of everybody, recognizing the difficulties that everybody else is working under. I appreciate that very much.
It looks like we will only have to have one meeting in March, first week of March, and one meeting in the week before the 11th. We're moving things along fairly well. Everybody's had their say, but they're not taking too much time. And so I don't think one of those weeks we will need to meet twice. So let's keep at this. Well, now I open the exec session on House Bill 246, establishing a protective order for vulnerable adults, introduced to us by Representative Rennie Cushing. And the chair calls on Representative King for a motion.
Unmute.
I can't see him on the screen anywhere.
Sorry about that.
There we are. It's okay. Representative King for a motion.
That was a good practice run.
It was.
Thank you, Mr. Chairman. Similar to what Representative Marsh said on HB 604, I'd like to see good bills come out of our committee. And as much as I'd like to see the elderly protected, I just don't think HB 246 is going to be that bill. So I'd like the motion that we move HB 246 to ITL.
And someone had asked me, Representative Betty Gay had asked if she could second that. And if you still would like to, you need to unmute and say so.
I second the motion.
Thank you. Now we may discuss it. And Representative King, because you made the motion, you may continue to discuss it if you wish.
Yes, this bill, in my opinion, is it's missing a few. I think the language is just it's lacking a lot, and the biggest one is really the due process part, and I think somebody that is wrongly accused could go a long way down the road of having possessions taken away from them. And as some people have mentioned, firearms would be some of those possessions. And there's really no recourse for that person that's wrongly accused. So I really think that this bill needs to really do a better job with identifying due process.
Thank you. Representative Weber.
Thank you. The bill, and I'm incredibly saddened by this bill because it has had an enormous amount of work from an enormous amount of people, and the intent and the effect would have been to protect people who are desperately in need of protection. And their due process protections that are in the bill comport with due process as we already know it. I think that the very remote possibility that somebody might have a firearm removed inappropriately can be rectified very quickly. The very real, and let me say that those people are not people who are actually in this proceeding being accused of a criminal event. So they're not accused. There are allegations, but this is a civil proceeding. It's not a criminal proceeding. But what I really want to say is that the amount of misinformation and fear mongering that has been generated about this bill really, really saddens me, because the effect is that vulnerable adults who are being ripped off or exploited or harmed is very real. And the means to quickly resolve that from them are in this bill, and they will go on suffering. And yeah, a couple of people who may have been, I think I'll just leave it there. They will continue to suffer, and a very small theoretical potential section of the population has triumphed over a very large segment of needy people, and I think that's wrong. Thank you.
Thank you, Representative. Representative Snow. Wow,
Thank you,
look at how he's really learning how to do that. Isn't that great?
Well, the buttons don't cooperate with me. I apologize for that.
Oh, you got it that time. You nailed it.
Thank you. I share Representative Weber. I mean, I do understand that some people are concerned about due process, but really all the due process arguments I've heard about is the ability to confiscate firearms or limit access to firearms. And really, when you look at the number of elders that are really impacted by somebody threatening them with a gun, it's rather low. It's realistic, and the consequences could be very serious. But the majority of things that will be dealt with under this is the financial exploitation, the taking of property, the misuse of property, the transferring of property, selling cars on people and doing that sort of thing. And neglect is the biggest form of abuse, where people just aren't properly cared for, aren't fed, are left in very unsanitary situations, none of which is in any way probably impacted by the possession of firearms in any way. So I sent out a proposed amendment to this to all the members of the committee on the 7th of February. And I'd like you just to consider this to see if this is a protected action. If we said on page 2, line 19 and 20, and again on page 11, line 22, if we made this statement, any protective action taken under this statute to protect seniors and vulnerable adults from abuse, neglect, or exploitation shall not include an order to confiscate or limit access to firearms for a person named in the complaint. Now, I don't like that because I don't think it's really a gun grab bill, but this at least eliminates any possibility of people calling it a gun grab bill, and would still give us a course of action in the majority of cases to take some action to protect very vulnerable people early. Not just the elderly too, but there are individuals with developmental disabilities and others that often get taken very great advantage of. So I don't know how people feel about that. I wish we could pass it without saying that, but we tried to remove every mention of firearms in the last bill. And that wasn't good enough, because at least one of the representatives, who is a charter member of the gun lobby, said that because it comes under the jurisdiction of the district court, that court person could still confiscate weapons. So I felt that at least if he was acting under the terms of this statute, this would prohibit him from giving such an order unless he was going to take additional criminal charges under another statute to accomplish it. So, to me, I think possibly this would be a way of saving the bill. I don't know how other people feel about it. I didn't submit it to OLS for a formal amendment because it seemed a little controversial for the way everybody in this committee really talked about it. But I do know that I can't remember, one of the other members of this committee said, what if we just excluded firearms? And that got me thinking about it. It would still protect most of the people we're most worried about, but would leave some people still a little bit at risk. And if it turns out that later on we discover we should have included that, it would be very easy to remove it. But let's put it in now and get the bill passed.
You did not introduce this through OLS as a formal amendment coming to us, did you? You did. I want to be 100% sure. Okay.
I didn't, well, I sent it out to everybody and asked them to think about it and so forth, but I didn't think it was appropriate to have a discussion online because we weren't officially in the committee. And I know how the rest of you felt about me putting in this amendment. I think if you feel that it would save the bill and would satisfy some people's due process concerns, let's submit it and see what happens. But if not, and I did, when I wrote it, I said, I wrote it, any protective action taken on HB 246, and I realized that you'd have to take out HB 246 and put in this statute. But other than that, I think the wording is relatively simple. And if, you know, I've read the bill a number of times, and I think these are the only two places you really have to put it in order to have that.
I think I can speak to that, Representative Snow, in a number of discussions, each of which was quite 91A legal. We feel that even if it were stipulated that this has nothing to do with guns and guns are forbidden subject in this, we have other trouble with the bill. So even if your amendment came forward, which we appreciate the graciousness of it, I do anyway, it wouldn't have made any difference on how we'll vote.
In what way? I do not understand.
We have other problems with the bill. Even if it was written into the bill, your amendment, we would still have other problems with the bill. So that's why we didn't salute it. It didn't fix the problem.
What are the, I don't understand the other problems. What would
well,
they do?
let me call on a few other folks, and if they don't outline them, I will, but I'd like to call on them. Representative Kofalt, please.
Thank you, Mr. Chairman. So yeah, I am actually the one who had asked one of the people giving testimony about whether or not they would be comfortable taking or inserting language that would specifically exclude firearms confiscation. And I found it rather interesting that the answer to that was not an affirmative yes at the time. I actually think that the genesis of this bill several sessions ago, in which firearms were mentioned some 20 times or so, or perhaps more, is fairly revealing. I think that even if this were to exclude firearms confiscation, it is still problematic insofar as it does exclude due process. And there are implications, even if we were to insert language. I have learned that there still would be implications for firearms ownership, which is that, you know, someone who is accused under this statute, whether rightly or wrongly, would go on a list that is checked as part of the background check process when a firearms purchase occurs. So there are fundamental issues with this premise of bypassing due process. Whether the bill says that firearms seizure will be excluded or not, the concern is still very much there. And I guess I would just underscore the fact that the right to keep and bear arms is a constitutional right. It is specifically called out in the Constitution for a reason, just as free speech and free exercise of religion. And so it really goes far beyond what might, you know, some people may prefer to see it as something more like driving, which is actually categorized as a privilege, not as a right under the law. So, you know, I believe that whether this is amended as Representative Snow is suggesting or not, I still think that it is not a good bill. I do not think we should I do not think we should move it forward. So I will be voting to ITL.
Thank you, Representative. Representative Shapiro.
Yes, thank you, Mr. Chairman. Almost everybody who I've heard talk against this bill has started off with, I know this is a well-intentioned bill, but, and in my view, this bill has been permanently stained since it did include firearms confiscation a few years ago. And there's no way to get beyond that at this point. So I would challenge people who are voting against this bill, because I don't think that we can find an amendment that is going to convince people to vote for this bill. But I would challenge people, perhaps in this conversation, to talk about their ideas about how we could start over and what we could do to address the problem, which is the exploitation and abuse of elderly and disabled people who are not able to fend for themselves. If not this bill, what ideas? How do we proceed?
Thank you.
I would agree. Oh, excuse me, Mr. Chairman.
Representative Gay, we're going to let everybody have a go and then we'll go to
Okay.
round two. Representative Gay.
Thank you, Mr. Chairman. And I definitely agree with Representative Shapiro and Representative Snow and Representative Lucy, what's your last name? There's a crying need for protection. And I went through with a friend who had developed Alzheimer's and we went to court and nothing good happened. And so I think we do need a totally new bill. There's a definitely crying need for one, but this bill was way too much like the one before. And I also agree that always want, let's see, what do you call it when they have hearings and you're not invited and it's all about you? Anybody think of that word?
Ex parte?
Ex parte.
Yes.
Yeah.
Yes, I absolutely don't like ex parte, and yet there must be some way to protect people's bank accounts when somebody is stealing them. So that's a much more complex thing to be dealt with. It does need to be dealt with. This bill does not offer the protections that we really need, but we really need that bill. So I'm hoping that we follow Representative Shapiro's recommendation that a lot of heads get together and write the bill that we need.
Representative Marsh.
Thank you, Mr. Chairman, and thank you everyone for your comments. I agree with Representative Shapiro that there is a need to protect elderly people, particularly from financial exploitation and other sorts of exploitation. And I will call his attention to existing law. RSA 631-9 is entitled Financial Exploitation of an Elderly, Disabled, or Impaired Adult. And I would suggest that if this existing statute is unsatisfactory, we amend the existing statute and not write an entirely new section of law to solve a problem that we already have a statute in place to attempt to solve.
Thank you. Chair calls on himself. We also have RSA 631-8 and 631-10. In the bill itself, on page 3, line 29, it speaks about not being bound by technical rules of evidence. There's a number of these little flaws, and why? And my final point is on February 8th, page A4 of the New Hampshire Union Leader, woman charged with stealing identity of adult acquaintance. I thought they couldn't charge her because this bill hasn't passed. This is an individual who 8 felony counts of identity fraud and theft by unauthorized taking. Elder abuse is here, and this person could have 30 years in the state prison and $4,000 fine for each of the charges. Now, that sounds like we have some things on the books with teeth. So the first thing people wanting a bill on this have to convince me is what is missing from the existing law. Because that person, that 56-year-old Pelham woman who may be going to jail for the rest of her natural life, committed some crimes against laws that are already on the books. One final point. In my 46 years as a clergyman, I have had 4 cases of adults who have been exploited, elder abuse. I also have had 2 cases of individuals who are improperly and unjustly accused. And after their lives were made a shambles, after a lot of money had to be spent, after they lost their job, after their reputation was ruined, the finding was, oh, they didn't do it. We caught the person who really did. So while I very much weep for those people who are abused, I very much weep for those who have their lives ruined by a bill that is not as tight and precise as it should be. So I'm very clearly voting against this bill. And I would say the burden is on those who think that the laws we have on the books are insufficient to show us why and how. What is missing? It wasn't missing for that woman in Pelham. What is missing? And then show us some ways we can fix what we have and do it in a way that doesn't violate the civil rights of others. Representative Shapiro.
I would just say that I think the difference between someone being charged after the fact is that this bill was created for prevention rather than accountability afterwards. And the idea of taking immediate action to prevent abuse happening in the moment creates some real trade-offs or conflicts with due process. And I understand that, and I understand that's a hard pill to swallow, but many, many things we do in this country, in this democracy, involve trade-offs of the greater good versus the individual good, or one person's rights versus the others. And that's the thing that we're here trying to think intelligently about and create a good bill for. So I understand what you're saying, but I think the difference is that this bill would address protecting somebody in the moment versus accountability after the fact.
Thank you. Anyone else wish to comment? Seeing none, we
Oh, wait,
have.
I wanted to
Yes,
comment.
that's right. You get a second go. I'm sorry, Representative Snow.
I'm sorry.
That's right. No.
I'm really sorry. I read almost every one of the hundreds of responses we got to this bill, all of which, maybe 2 or 3 defended the bill. All the rest were saying how due process against people who might lose their guns was the point of the thing. But what about the due process of this elderly woman that has seen her relatives siphoning off her money? Okay, so you go to court and you make a charge against her. In the meantime, this woman is still subject to the influence of these relatives who are stealing from her. There's no immediate action that can be taken to stop it. I, as a social worker, used to have to go into homes, and I saw people lying in a bed in their own filth that had not been fed in days. And you can make a charge, but nothing immediately happens to stop this from going on in the meantime. And we can talk about due process, but under the way the bill goes, there is a bit of an ex parte, but I don't know where that applies, other than I don't see why, if you were told to no longer steal money from your grandmother, that would in any way come into being when you go in to purchase a gun, because we're not talking about guns or anything to do with it. I don't know if even anybody that has a restraining order placed against them by a relative, and you could do that as well, but that's a court thing and offers no immediate satisfaction. In fact, sometimes it takes so long that something happens in the interim. But I guess I'm concerned that we are very concerned about a few people's due process rights. I know the ex parte thing isn't good, but you can ask for, and you have a right in this bill, to ask for an expedited hearing. The longest that can go is 3 days. And the only thing that I know that really defends against is having your guns returned. But we're not taking their guns away anymore. We're simply saying you can't continue to do this right away. Later on, you can challenge that, whether or not you were doing it or not doing it. And I don't know why being accused of something and found innocent on things like this that we would now include in this bill. Exploitation, neglect, and that borders on abuse. I think you'll agree some of the things that I've seen over the years are clearly abusive, but they don't involve beating someone up or threatening them with a gun. But I think we haven't done enough. I think we could look at some of those other bills, but what that would require is taking those bills and building some immediate protective action in. You know, if you had the abuse bill, I don't know how long it was between the time that woman was charged and when she ended up in court, but I'll bet it was quite a while.
It was 2 years, sir.
Yeah.
It makes your
So
point.
a lot
on
can
this.
happen in that 2 years,
Yes, sir.
whereas a bill like this would say, okay, immediately you need to stop. Now, they also are free to bring some other charges in if it turns out it's more serious than you immediately thought. And they do have a right under any of these things, if your name appears on a complaint brought by someone, you can request an ex parte hearing and, an expedited hearing is what I meant to say. And that gets wiped away, but it still gives people a ability to develop a plan with increased knowledge to keep that person protected. And that's what I'm basically hoping this bill would provide. Now, it may be that down the road, we can take one of those other bills, as I think you suggested, and build some things into that to give a more immediate response. But in the meantime, I don't know who would really be hurt by putting this in. It's easy enough to take it off the books, but right now there's no immediate protection for people who are being abused in this way by other people, either in their family or, people that are hired to come in as temporary help. And I think we've all heard horror stories about things like that. Anyway, I guess I'm just, I think I've seen enough things in my career to know that I'm very bothered by the way some very vulnerable people are treated, and people are much more concerned about the due process of the person committing these acts than they are the due process of the person that's the victim. And I think they deserve some immediate response to protect them if they're in a situation where they're at great risk. So that's my only argument against it. And if I'm the only one that feels that way, it sounds to me like at least Representative Shapiro shares my concern, but he's in the same profession I'm in. So he's seen a lot of the same things I've seen over the years. And I think you have, Mr. Chairman, in your
Yes,
role.
sir, I have. Yes, I have. And let me take my second round turn here. I too would very much like something that's immediate. And that's why that 2 years before justice was served for that poor woman in Pelham, yeah, we have to do something better. But I find it ironic because the very people who taught me we have to have the rights of the accused upheld is not my people on the political right. And if I could even stipulate this bill has nothing to do with guns. And I try to say that to the hundreds of people who email me about the gun grab this bill is. And no, it's not. It might incidentally be so in a few cases. This is not the bill from a few years ago. But it still troubles me that the rights of the innocent may be inappropriately trampled on. And as I say, I learned that from my liberal friends over the years. So there's got to be a better way, I think, to do expedited things so that the putting people at risk, harming vulnerable people is stopped, not 2 years later, but immediately, and still uphold the rights of somebody accused who might actually be innocent. So that's my plea anyway. Representative Weber.
Thank you, and thank you for letting me have my second round. And I will address only a couple of things. The statutes that you're citing in the 600 range are criminal statutes. They don't happen quickly because we do liberal or conservative are pretty careful of the rights of the accused because we are bringing the entire force of the state against an individual. So we cannot take the criminal statutes and make them quick. That's item number one. Item number two is if you are concerned about removing firearms, somebody who is charged under the criminal law is more likely to have their firearms taken away than somebody who is caught up in a civil proceeding. The third thing is I'm just going to point out that it is horrible to be accused wrongly, and it should not happen, but it certainly happened to two people that Representative Pearson knew without the benefit of this statute. That's going to go on happening. And the other thing that is going to go on happening is that the rights of innocent people are going to be infringed upon every single day going forward. It's just going to be the rights of our vulnerable people, our more vulnerable populations. And I just think that's a terrible shame. And I certainly will be glad to work going forward on other ways of dealing with this, but there are not a lot of other options to work quickly through, to address quickly a problem that needs to address quickly, and it can't be done through the criminal justice system. And that's, I will try very hard not to say anything else at this point, and I thank you.
If I could, perhaps one other area we could explore. Currently, if you're under the age of 18 and you're being abused, there is a state office that can walk in and without, if they determine that this child is very much at risk, they can be removed or other actions can be taken and people can be forced. In the end, it could end up in court, but in the meantime, some protective actions can be taken to make sure that child is safe. I am simply saying, I saw this bill as doing the same thing for elders and vulnerable people. If we rework it, then I think, but we got to think in terms, we were willing to protect children, but older people with Alzheimer's disease or other kinds of physical disabilities, we seem to think they're grown up, they should be able to take care of themselves. And the truth is they can't. And it's wrong to hold the rights of people who think they can own guns. And I have no problem with people owning guns. My father was a gun collector. My son collects guns. I mean, I'm not against gun owners. I'm just saying that at times, I think you can recall a couple of incidences that recently happened. There was a man that walked into Mary Hitchcock Hospital, into the intensive care unit and shot his mother. We had a young man that went to a police or a supervised visitation at the YWCA, shot his son and shot himself. And so at times this comes in, so guns do, but I'm not willing to give up all the protections for older people merely because some people are so concerned that maybe their right to own a gun or buy a gun or whatever else it is are being infringed upon, because it would almost never happen.
Nor am I, Representative Snow, and I would remind you, you did not ask to speak, and this is your third round. So now Representative Gay has been called on again.
Okay, thank you. Sorry.
That's okay, buddy.
Thank you, Mr. Chairman. I'm not being an attorney. I'm very basic at what I would love to see what Representative Snow is talking about. Take the child protection laws and rewrite them, or don't rewrite them, just substitute vulnerable people where you have child. I'm sorry, my computer keeps acting funny, so that's why I'm not showing anymore. Also, when somebody has a DUI, they're supposed to have a hearing in 3 days, but they don't wait for 3 days to arrest them or stop them. And I understand injunctions can be made under other legal, situations so that you could free. I want to see a bill, a law that says you can freeze someone's assets so somebody else can't take them an elderly person or a person who's sick, and this other person that we all have horror stories of being robbed by somebody who pretends to be their friend. I can't believe we can't come up applying laws that are applicable to other bad situations. We really need to do this, and they do need to be immediate. And we have we already know about immediate reactions to children that we think are in dangerous situations, immediate situations for somebody stop driving drunk or under the influence. There has to be a way to write some good laws, and we need to do it soon.
Thank you, Representative Gay. Representative Shapiro.
Yes, I hope I can count myself as one of those liberal friends who's maybe influenced you about the rights of victims. I hope.
You are a liberal and you are my friend, so I guess so.
But what I would say about the criminal justice system is that it's inspiring to me anyway, and it's imperfect. And so, especially in recent years with advances in DNA technology, we've had a lot of exonerations where people were proven to not have committed crimes that we thought they did. And a lot of them have served a lot of time in prison. And I know you're looking to avoid those kinds of miscarriages, lesser miscarriages in this kind of situation. But I would say that we find someone who was convicted of murder and spends years and years in prison. And when we realize that he is innocent or she is innocent, we let them go, but we don't repeal the laws about murder. And so I would say that in some way, this is an equivalent that we're throwing out the possibility of protection in the form of this potential law, because there may be someone who would be accused unfairly. And in fact, undoubtedly, if this had become law, eventually some people would be accused unfairly. But our system is imperfect.
Mm-hmm. Thank you, my friend. Representative Nelson.
I see. I'm not a big gun person. I have a gun, but I'm not a big gun person. And my vote on this will not be to help the gun people, because I have seen people who have been taken advantage of, elderly. On the other hand, I think this needs to, I want to see this fixed somehow, but I'm not sure this bill is what's going to work. Is there got to be another state somewhere or somebody that's done this that has a better look or an answer to doing this? Because I'm all in favor of protecting the elderly, and I do believe they got abused, but I also, like the last person said, there are people who, there are bad people, and there are other people that just take advantage of the situation. So I'm not really sure how I'm going to vote on this one.
Thank you. Representative McKay.
Thank you, Mr. Chairman. I won't repeat everything my fellow social workers have said. I'm more pragmatic at this stage of my life. I pretty much know how this bill is going to end up. Therefore, we are hearing a tremendous support for this type of legislation. I think we should get to work and bring that in to the second year and do the best we can, because I think everybody is in favor of that. So even though I'm going to vote against this motion, I very much support going ahead with this and solving it as much as we can.
Thank you. Representative Merchant.
Thank you, Mr. Chairman. More of a procedural issue. Is there any advantage of retaining a bill versus bringing another bill completely different in the fall for next year?
There would be perhaps a time advantage that a retained bill could be heard in January. We have a motion ITL on the floor that would have to be defeated, and then another motion would have to come forward. So I believe, I think that's correct. If Yeah, I'm learning. Thank you.
Yeah.
That could happen. That's what it would take.
So, Mr. Chairman, if I may, I'm learning as well.
Hmm.
So in saying that, it sounds like we do a retain, then the committee or subcommittee or group of this would get together and work on the bill to make it workable for all the parties involved. And then ultimately that goes back into legislative hopper next year versus starting over from scratch. It sounds like retaining it does allow for the opportunity for people in the committee to work on it, either during the summer and the fall, and not have to literally start over from scratch. Is there any, that's all I'm trying to get to.
I think honestly, we would probably start over from scratch, except for the idea that we very much want to help the elderly and as much as possible, knowing it will never be perfect, lower the risk that somebody will be inappropriately accused and ruined. I think we'd have to start over from scratch. And what I would like to see, my fantasy is, when a bill comes back, I want to see 10 Republicans or 5 Republicans and 5 Democrat co-sponsors.
Right.
I want to see somebody who's an NRA member and somebody who's an ACLU card carrier. And if you think Knurk and yourself are going to have fun this summer, this group is going to have a lot of fun, but I think it might be worth it.
Well,
Point of order.
Yes,
Point
yes,
of order.
yes.
Is it possible to withdraw? Like I seconded this bill to ITL it. I would rather retain it. Is it possible if the both of us withdrew and put a new, without voting on it, can we just withdraw it and issue make a motion to retain?
I believe it is possible, Representative Weber.
It is possible if the moving party and the seconding party decide to do that. And I will certainly go along with whatever people decide to do. But I have to say, having worked on this bill 3 times, including the time when we brought it out of this committee, you will remember 20-0.
Mm-hmm.
Because we had addressed many of the issues that we've already talked about. And I could go on for hours about how this bill does exactly the thing that several people have asked that a subsequent bill do. I really think at this point that taking a new start is a better idea, because just the fact that it has the same bill number, even if it is completely reworked, I feel that people who are not going to read the careful reworkings that are done over the summer, I think we are far better to start again with a new bill number and work at that and see if we can't come up with something than we are to retain this bill and bring it back under the same number. I think that well has been poisoned.
I think you're
Okay.
right.
Thank
And
you.
this does not mean that this summer.
And I appreciate the thought.
It could mean that this summer, a group of people from all across the spectrum could try to see if a new bill, yeah, sure, a lot of the work's been done and we know that, but we don't have to give it the same number, because I agree the well's been poisoned. But if a bipartisan, sponsored bill, if it's possible, could be brought forth and thrown into the hopper in the fall and come up next year, I think. Representative Cannon.
I'd be willing to help on that. I have both an ACLU card and an NRA card. So also,
just write the bill yourself.
Well,
yeah, you be the sponsor.
I would love to help out also, because I am a transgender person, to add another voice from a community, because I think it would be important for us all.
Who is also subject to abuse at times.
Yeah, I've been there.
Representative Merchant.
No.
Okay, take your hand down.
Thank you.
Representative Folsom, you got your hand up.
Yes, I would love to work with Representative Cannon on a new bill.
We got
And
it.
could I say, despite the
Go for it.
despite how enthusiastic about this. I don't care about this bill. It's the idea of protecting those people that I'm interested in. And I'll work my buns off to make sure this happens. So now maybe I'm a little too enthusiastic. You may be right. But I can temper myself down if I think there's something that's going to go somewhere. And I think that may be the best solution. But I'm still sort of pessimistic only because of the huge volume, 400 or 500 emails we all got about this matter. And you're absolutely right. No matter what we did, I think it's doomed at this point. So starting it all over, having a different title, doing something else, we may have to do something about creating some more organized organization somewhere like DCYF has now, so that there's actually a plan for how they'll carry this out without leaving it sort of willy-nilly with an ex parte hearing in front of a judge only to carry it out. There's got to be a better way to do it, and I hope we can succeed in doing it. Thank you.
It's come to my attention that Representative Knurk has enthusiasm to spare should yours ever wane. Representative King.
Thank you, Mr. Chairman. I just wanted to maintain the motion that's out there and also throw my hat in the ring. I would love to work on this. As I started out, I think this is really a well-intended bill, and I'd like to see it work.
With the mover of the bill not recalling it, then the motion on the floor is the motion we are to consider. But we're seeing a growing group of people across not only our spectrum, but the spectrum who could start to work this summer. Does anybody have anything else to say, or do we now move on this motion of ITL? Representative Cushman has a index finger up.
Thank you, Mr. Chairman. I would just urge the members of the committee to, since this bill seems to need to start from scratch and not, it's going to need.
Start over.
Yeah, it should be ITL today, and you guys can bring a new version of what you want to do next session.
And my fellow Scotsman's correct. This bill's going to die somewhere. If it doesn't die here, it's going to die in the floor, or it's going to die in the Senate, or it's going to die on the governor's desk. Representative Nelson.
I think this committee this year, I honestly believe they're all committed to fix this. We know there's a problem. We know there's two things out there, but I can't believe with all the talent we have, we can't fix this. So I'd rather see us do it next year and get it right.
And we're all committed in various ways, whether we actually serve on that subcommittee or speak to it. We're all committed to make this happen, folks. This isn't a political lie. We don't like those here. This is a promise to one another.
Yeah.
Representative Knurk.
I would just like to point out that as Charlie McMahon says, let's get this done while we're still young, because a lot of us are getting old enough. We may need this statute someday.
Well, that is one reason why I'm concerned about your not loaning excess enthusiasm. That's not good when you get to our age.
He's not old, Mr. Chairman. He's aggressively mature.
Thank you for that. I was waiting for that. All right. The question is ITL 246, moved by King, seconded by Gay. The clerk may call the roll.
And Jeff needs to show himself.
And let me just say that if you want to ITL the bill, your vote is yes. If you don't want to ITL the bill, the vote is no. Clerk may call the roll.
Everybody ready? Representative Marsh.
Votes yes.
Representative McMahon.
Yes.
Representative Nelson.
Yes.
Representative Acton.
Yes.
Representative Gay.
Yes.
Representative Cushman.
Yes.
Representative Folsom, yes. Representative Kelsey.
Yes.
Representative King.
Yes.
Representative Kofalt.
Yes.
Representative Weber. Representative Weber. Oh, sorry.
My apologies. That was a no.
Okay. Representative McKay.
No.
Representative Snow.
Yes.
Representative Knirk. Representative Knirk.
Mute. Ah! No, usually I'm prepared. Sorry.
I'm sorry, was it?
No.
No, okay. Representative Soloway,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
No.
Representative Shapiro.
No, but if perchance my side loses, I'd be glad to work on another bill.
Representative Woods,
No.
Representative Merchant,
Yes.
Representative Pearson.
Should my side win, I will also want to help on another bill. Yes.
There will be a minority report, Mr. Chairman. When do you need it by?
Oh, probably by tomorrow.
Okay.
And the motion carries 15-6.
Thank you. And I would ask for the majority report to come from Representative King, if I could have it by tomorrow morning early. And the reason for that is I want to get it to the clerk. They may decide to put it on our calendar for voting next week or not, but at least we need to do it. So if I could have that, we will again temporarily suspend. You do not leave the room until I get the report.
I
Thank
think
you.
it has to
Mr.
go on the
Chair.
calendar for next week because it's an early bill. I
Is
don't
it?
think we have a
Is it?
choice of that.
Mr. Chair,
Okay.
could I-
Yes.
Yeah,
Can I
yes, it's
request-
an early bill.
Okay.
may I request, maybe this is impossible to do, may I request the opportunity to change my vote from yes to no? I thought I was the only one that was going to vote no. And so I voted yes. Could we, it still fails, but it would just be,
I believe that's in order, short of me looking it up in Mason's,
okay.
or looking it up in Weber.
Not,
I think we can have an informal, we have often had informal
Okay.
revisions to that, and there isn't a lot in Mason's about committee work, so.
What would that vote be now if I changed it?
It would be 14-7.
Okay, that's still okay, thank
Does
you.
anybody have any objection to that? The results ultimately will be the same, and I didn't drop the hammer. So this hearing still is not, this exec session is not over on this bill. And I think that means it's okay, but if it isn't, let's all pretend it is.
Mhm.
Representative Pearson, I have checked with the clerk and he said it is not in order.
What clerk?
Paul. To
Oh,
change your vote.
Since Mason isn't around,
Is the
the
motion to
co-author is.
reconsider in order?
I
wouldn't.
believe it
Yes, that would be in order.
is.
And a motion to reconsider would have to come from somebody voting on the
On the
prevailing side.
prevailing side.
So if somebody on the prevailing side is willing to move to reconsider, then we can.
I'll make a motion to reconsider.
You're on the winning side?
Yes, ma'am.
Okay, since I know where the procedures, limitations, reconsider.
I'll second
uh,
Representative
We
Merchant's
debate it
motion
again?
to reconsider.
No, we don't debate it
No.
again.
And we,
We could debate it again if
Would
we.
debate it
reconsider,
again, but you
but-
really don't want to.
I was just kidding.
I know that. I
Christine.
wasn't.
Okay, let's see. So the motion to reconsider is coming from King and the second is Merchant.
No, motion's coming from Merchant. The second, I'm not sure. I think it was coming from
Oh,
Solid.
I'm sorry.
Salloway
Okay.
seconds.
Okay, sorry about that. Thank you.
All right, now hold on one second. I believe everybody, but I just want to see it because this cost $100 to buy. And it was a present from my favorite daughter. Reconsider,
Oh, geez.
reconsider.
You're not supposed to claim which is your favorite. That's not nice.
Well, it's easy. I
he
don't
only
do
has
that.
one.
Thank you.
Oh, that makes it easier.
Yeah, it seems to be okay from what I was able to skim. So reconsider. The clerk may call the roll, please, on reconsider.
This is on reconsider. of the motion to ITL. Reconsider. Representative Marsh,
Yes.
Representative McMahon,
Yes.
Representative Nelson,
No.
Representative Acton,
Yes.
Representative Gay,
Yes.
Representative Cushman,
No.
Nope. Sorry,
your vote?
I just think you made a mistake.
Do we need to clarify what the vote is?
Go back to the last person whose vote you weren't sure of and say, what did you say?
Representative Gay, can you?
I guess I'm really lost now.
You
I
gotta
thought
say yes or no.
I don't know what I'm voting on.
Reconsidering the vote, because one
are we-
member,
Are we re-voting or voting on reconsider?
No,
let
this
me
is vote to
explain.
reconsider.
Let me explain it to you. One member wished to change his vote, and the best way that can be done is for us to reconsider the original vote, whereby he will be voting in a different way, and that will be a courtesy to him. And so this is just the
Jen?
vote as to whether we should
Are you on?
do that. Representative Salt, thank you. So this is the reconsideration of the vote, so a member may change his vote.
Okay, but I still need to understand, if we vote for reconsideration, then we vote again.
We vote the
If
bill
we-
again.
Okay, if we approve reconsideration.
Right.
Okay, thank you.
Oh,
So my vote's supposed to be yes.
Okay, Representative Cushman,
No.
Representative Folsom, yes. Representative Kelsey,
Yes.
Representative King,
Yes.
Representative Kofalt,
No.
Representative Weber,
Yes.
No, just give
Representative
back the
McKay,
cookie.
Yes.
Representative Snow,
Just
yes.
give back your cookie.
Representative Knirk,
Yes.
Representative Soloway,
Yes.
Representative Cannon, Representative Cannon, you need to unmute.
I'm trying. Yeah.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Merchant,
Yes.
Representative Pearson.
Yes.
The motion carries.
Now, the motion before us is the ITL motion on House Bill 246, as moved by Representative King and seconded by Representative Gay. You may discuss this, but I really hope you don't want to.
Yeah,
I'll give you a minute.
Okay.
The chair calls whoever just said she has her other index finger up now.
I just want to say I didn't vote no to not be courteous to Representative Snow. I voted no because as far as I knew, and I did mention it and tried to ask Christina to ask the clerk, that before COVID, you had to wait until the next committee meeting for a reconsideration motion.
Oh.
Okay.
Oh,
With that.
Oh,
is that
No.
right? I don't think so.
no.
No.
Well, then I was wrong, but
Not right.
That's okay. Hey, hey.
It doesn't matter.
Yeah.
No offense taken, I can assure you.
Well, you know what? If we later found out this was a very, very sincere error, the original vote stands. But in case it
Yeah, hello.
doesn't, let's do it again.
Okay.
This is the vote on ITL of House Bill 246. Representative Marsh,
Votes yes.
Representative McMahon,
Yes.
Representative Nelson,
Yes.
Representative Acton,
Yes.
Representative Gay,
Yes.
Representative Cushman,
yes.
Representative Folsom, yes. Representative Kelsey,
Yes.
Representative King,
Yes.
Representative Kofalt,
Yes.
Representative Weber,
No.
Representative McKay,
No.
Representative Snow,
Careful now.
No.
All right.
Thank you. Representative Knirk,
No.
Representative Soloway,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
No.
Representative Shapiro,
No.
Representative Woods,
No.
Representative Merchant,
Yes.
Representative Pearson.
Yes.
Okay, that one is 1, 2, 3.
We're at 14-7, I think.
Oh, geez.
2, 3, 4, 5, 6, 7. Yes, thank you very much. Now, I do want to have a moment of personal privilege, if I may.
Okay.
You know what kind of a nightmare this report is going to be for me to put together?
Oh, sorry. I'm sorry.
I have to get this all on paper.
Very sorry.
Representative Nelson and I feel your pain. as ex-clerks.
I think a number of us have gone through this a number of times. It was
and former chairs.
unfun, and we appreciate the effort that it took.
And there's only one more, and I hope this is very brief.
You may have just killed our chances by saying that, but that's okay.
Okay, so I don't know whether I'm supposed to bang the hammer or not, but I just did to close the last one, open the next one. This opens the exec session on 244 relative to the membership and duties of the Joint Healthcare Reform Oversight Committee. You may remember the chief and only sponsor, Representative Abramson, came our way to explain why he thought this ought to happen. And you may remember, said what this committee shall study, including some very, very specific items. And I'll just leave it at that. Would anybody like to make the right motion on this?
I'll make a motion to ITL.
Thank you, my friend.
Second,
And who is that?
Weber.
Weber. Okay, so that is Snow and Weber. Thank you. All right, any discussion on this? Told you it'd be quick.
Don't jinx it.
We all feel the same on this, don't we?
Yes, get your vote right. We're not reconsidering this one.
Oh, God.
No, but I worked for him, so when the clerk is ready.
Okay, sorry. Okay, the vote to ITL on House Bill 244. Representative Marsh,
Votes yes.
Representative McMahon,
Yes.
Representative Nelson,
Yes.
Representative Acton,
Yes.
Representative Gay. Did we lose Representative Gay?
She has to unmute.
Oh,
I'm so sorry. Yes.
Representative Cushman,
Yes.
Representative Folsom, yes. Representative Kelsey,
Yes.
Representative King,
Yes.
Representative Kofalt,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Snow,
Yes.
Representative Knirk,
Yes.
Representative Soloway,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Merchant,
Yes.
Representative Pearson.
Yes.
21-0, the motion passes.
Mr. Chairman,
Yes, in the minute.
before you
Represent-
recess this committee, I
I'm
would
not
point out,
recessing this committee yet. I got your
oh.
text.
we,
Could I
Thank you.
move consent for this bill before we go on to anything else?
We absolutely can move consent on this. And who made the motion? You did, didn't you, Representative?
Pepper.
Mm.
Pepper.
Representative Snow moved ITL, I seconded ITL, and I moved consent.
I was there. Representative Snow, would you write the blurb and get it to me by tomorrow morning?
All right.
Thank you. Now, it seems that in my beautiful, wonderful, there has to be a problem here somewhere, but I haven't found it. I've just been pointed out that there is an early bill that we have to look at to get out the door. I'm sorry, that was it. You were all heading for your early dinner. But Representative Marsh, would you please introduce it while I find it?
Yes, House Bill 314 is also an early bill. My opinion on House Bill 314 is it's problematic as drafted. We also received an amendment. I think it's still problematic. One of the reasons it's problematic is that it includes food and drink in what it would allow. And I believe that would include alcoholic beverages. And probably that would be a violation of a number of laws. So I think this bill is not ready for prime time. Whether we want to ITL it or retain it, it's a matter for the committee to consider.
Is this the food service bill?
Yes, I don't believe we've acted on it.
Homestead.
Yeah, homestead. Homestead food operating license here.
On my colorful notes, I have that we retained it on February 8th.
Yes, 21.
That's what I had too.
That would be good.
yeah,
but I have this report from the HCS that says that we didn't act on it.
If you'd like us to vote again,
No.
Oh, please, God, no. No, I have the,
Yeah, that's what I got.
Retained.
It's just, it must be that the documentation we got from upstairs is incorrect, and I apologize for that. I was just trying to look out for my chairman.
Okay, I just checked, the form was sent in.
yeah, and the, it was moved by Representative Marsh and seconded by Representative Weber, and the vote
there we
was
go.
21-0.
Well, we've been way too busy.
He's just trying
And
to.
we all get a mistake each week, and Bill, this is yours. So there's a few of you who have yet to do one, and that's okay. The week is young.
Your turn is coming.
It is, and what do you mean? It's coming. It's been coming all day. All right. So with that, I adjourned that exec session, and with that, our meeting here today. We did it.
Thank you all.
happy
Good night,
Mardi
everybody.
Gras.
Hi there.
Oh, yeah.
Hi, everyone.
Oh, that's right, tomorrow's Ash Wednesday.
Or if you're Irish, it's pancake night.
Right.
Yes, my little friend here is fasting from everything for Lent.
Oh,
Yes, I guess so.
That's what he wants to look like. Yes.
Uh-huh.
He belongs to my skeleton crew.
No.
All right.
oh.
Oh.
Good night, everybody.
Good night, everyone.
Representative Knerk, you did not cite the reference for your comment about bowls of porridge when you were discussing your amendments.
I think it is in the public domain.
Representative Nelson, can you unmute and talk to me?
Oh, yeah.
Do you have the ability to just scan your notes from earlier today and email them to me?
After I rewrite them so I can read them.
Okay.
Thanks, everybody.
Okay.
Oh, look at the Weber dog.
Ask a
Oh, here we go. Yeah.
Weber dog wanted to apologize, as do I, for inserting himself at one point when I forgot momentarily where I was and that we were all on camera. So, and I will apologize for the word I said into an open mic when I realized that he was on camera. And
oh, we missed that.
Oh, yeah. Can we revote that?
Yeah.
It's okay.
By the way,
repeating, you can
I don't know
make
if you
it
all
up
do.
yourself.
You probably heard Representative Hunt wasn't very happy with cats in commerce, and Anita Burrows is one that had the cats. Her tweet went viral, and she's been in People Magazine and all kinds of stuff with the picture of the cat because of the controversy about this. We made the news again.
Yeah.
I suggest
And Representative Hunt got to be on this committee with his dogs shortly thereafter.
That's
Yes.
perfect. Repentance means change of behavior, not just remorse. And I would suggest that at a future date, we all have a pet of our choice in our lap, just
I
so we
think
can
that would
make
be very
Newsweek.
I
Yes,
ain't got one.
you can rent one. Good night,
Stop.
everybody.
Bye, everyone.
I wonder if Brad Pitt's available to sit on my lap.
No.
Yeah, right.
No, wouldn't work? Okay.
He's not a pet.
Don't
I
say
need to
that.
ask a
I'd take him as my household pet.
Don't say that in a committee with therapists and clergy, please.
No, sorry.
Yeah, and
We'll all
the
meet at
meeting's
your
still
house tonight.
recording too, guys.
My
Meeting's still
husband
recording.
isn't real pleased either. He's starting to voice his opinion in the other room.
Good.
Please tell me if this is legal. Can I send an email to everybody if it's not about a bill?
Yes.
Yeah.
Yeah.
Like
Okay,
thousands of
it's like
people.
we won money or
Oh,
something.
us.
That'd be it.
So you're inviting us to a party?
All
Yeah,
right,
what's
thank
the
you.
party?
I'd love to do that, but no, it's there's a movement afoot to ask for the Wyndham voting escapade, whatever you want to call it, to be studied. And it's going to take a lot of support to make that happen.
Yeah, you
Okay.
can put that.
I'm very concerned because my town uses the same software.
Well, it's not about a bill that anybody's facing. I don't see
If
why
it's
not.
in
We
front
will
of
do it
us,
or
it's
not.
Not a problem. I will
Okay.
say there have been other things that people have found to be tacky. There was a member at one point who was sending out advertisements for his business. Probably
Yeah, that's
not a
not
good
good.
thing, but if you just have a petition of some kind, I don't see that there's any
Yeah.
problem with that.
Thank you.
Good night,
Uh,
everyone.
Yeah. Could I ask a quick question?
Of
I could
course you
not
can.
find a paper copy of a bill. I think it was 617, or was it 607 that we ITL'd? I want to look it up, but I don't want to be looking for numbers. Which one was that?
617.
617.
Thank you very much.
Because the sponsor withdrew it and she said it was no longer necessary.
Yeah.
Yep.
That was the one that she said it could be done without any statutory requirement.
It was redundant, wasn't it? There was already.
It just could have been taken care of under existing statute. She just didn't get to the right place.
It was going to be done through rules. She'd talk to HHS and
Yeah, that's right.
and the rules
Yeah.
we're going to
All
accommodate.
right, for real good night, everybody.
It's a
No,
quarter of 5. Are you still young, Representative McMahon?
Yes. Yes, I
Glad to
am
hear it.
at this point.
I'm glad you are.
Well, it's the result of cooperative collaboration to achieve consensus like we did today.
Good.
I write all my own material, so hopefully.
I
it
know
works.
you do.
I hope
That's
it-
your charm.
No, that was really sweet today when we went to all extra bother so that all the votes could be honest.